You should be able to actually see it now. It should be live now.
No, sir.
Is it the right link? Because the link which we opening is it the one which Pramod has put? And is that the link which Shiv has sent? Can you just confirm that?
Yeah, it says 28th of February. 1700 hours.
So Preeti, is the link same? That is what I'm trying. Smita,
It
you're
has
saying that
started.
you can see.
Yes, I can see just now. Just now it has
So-
started.
It is, and it is Rads day 1.
Yeah.
Yeah. But I don't know here. And there is already people on live chat on the thing.
Yeah, Shiva, I can say it's live now. It's not showing
It's
waiting for
live
Shiv
now.
Kumar
Okay,
to start.
okay.
Yeah.
That's great. That's great. I think we'll start again and welcome everyone to ERADS. Our the live lectures. Well, we won't say live online lectures for the preparation to the live demonstrations in a fortnight's time, and followed by the your hands-on, which will be on a Sunday in a fortnight's time. So today we have got quite a few lectures lined up, and we'll have starting from the basics of PNS and loss of resistance, going on from the head and neck by Akhilesh to shoulders by Dheeraj, then elbow by Shilpa, and then you got the distal forearm blocks by Sanjay, and I'll be talking about the lower limb, starting off with the pelvis, hip, femur, knee. Mohit was supposed to take one of the lectures, but he's unable to do that, so I will take the lecture on the femur and knee. And then we will move on to ankle. We'll do the thorax part, which will be, some part will be by me. Then there we have lectures by Minoti and Dheeraj on thorax, anterior thorax, and abdomen by Prasanna. And in the end, we will have a lecture on segmental spinal by Nandini. So I think quite a lot to cover. And without much ado, we will likely start off with the first lecture by Smita on basics of loss of resistance and PNS guided blocks. Smita, over to you. You would like to share your screen?
Yeah.
We will have time in between each lecture to ask the questions.
Yeah. So good afternoon, everybody. First of all, I thank Dr. Shiv Kumar Singh and organizing team of RADS Mumbai for giving me such a wonderful opportunity to be faculty and presenting on my today's topic of basics of LOR and PNS, that is loss of resistance and peripheral nerve stimulation. Of all the three techniques, that is of regional anesthesia, that is paresthesia, peripheral nerve stimulation, and ultrasound guided techniques. Ultrasound guided techniques is supposed to be more safe and precise due to direct visualization of plexus and needle. But it has got many issues like increased cost of the machine. So unavailability of ultrasound machine in major of the small nursing homes, lack of training, and PCPNDT Act. So more commonly used are paresthesia and PNS technique. Even if peripheral nerve stimulator is not available, some blocks can be given with LOR technique for providing perioperative analgesia. So first we will see the basics of loss of resistance. So LOR techniques is used for facial plane blocks. All facial planes are with some distinct pop. So when you insert a blunt or short bevel needle through the fascia, you can feel bounce and distinct pop. If one can distinguish this pop, one can deposit drug in right plane and have excellent analgesia. So following blocks can be given with LOR technique: fascia iliaca compartment block, then transverse abdominal plane block, rectus sheath block, ilioinguinal nerve block, then PEX 1 and 2 block, then serratus anterior plane block, erector spinae plane block, and thoracic paravertebral block. These blocks provide analgesia to lower limb surgeries, abdominal and thoracic region surgeries. They are simple, easy, cost effective. We require only one syringe, needle and local anesthetic drug. But we have to understand the blunting of needle, concept of cushion effects, filling of pops and clicks, and surgical anatomy. Then LOR needle. These are, we can use either commercially available needles available in operation theater, and hypodermic needles. Commercially available needles are short bevel needles. So as shown in the picture, so which provide good tactile feel of pop when they pass through fascia. Also, extension tubing is available, so it makes it easy to handle and prevents displacement while injecting. Other needles we can use that are available in operation theater are a Tuhi needle, which we use for epidural anesthesia, then blunt drawing up needle, and bullet or pencil point needles. This Tuhi needle and blunt drawing needles are little bit of large gauge, and they are more blunt and they cause more trauma to tissues. We can use pencil point needle of spinal needles of gauge 20 to 25. Then hypodermic needles, they are sharp, so they can pass easily through the skin with minimal damage or pain. They can be used in LR block by modification, by blunting their tips. So how to make them blunt? First method is we can scrape it against the inner wall of sterile glass ampoule with bevel facing inwards till the tip bend towards the bevel and making it like parrot beak. So one can use sterile bowl also for scraping. We can use 2 sterile needles. For this, LR needle should be of smaller gauge than other needles. For example, if you want to use 21 gauge LR needle, use 18 gauge needle for scraping. Tip of LR needle is inserted into large gauge needle and bent like a beak. Remember, the bent tip should point in direction of bevel rather than away from it. Then cushion effect. The concept of cushion effect was first described by Dr. Shivkumar Singh and Dr. William Kureva in 2011 in literature. So one should understand the concept of cushion effect properly, then it is easy to inject the drug in proper place. So when we use blunt needle for LOR, we get resistance to pass through the skin, and considerable amount of force is required to pierce the skin. So when more pressure is applied, the subcutaneous tissue under the skin also gets compressed. Similarly, when we press the cushion, the cotton inside the cushion gets pressed. So the needle will give away and goes into the deeper planes without filling pop of first facial plane, and drug is deposited in the deeper planes. This is called cushion effect. Methods to prevent the cushion effect. You can make a small incision in the skin by 18 gauge needle or surgical blade number 11. So there is no resistance for piercing the skin, and we can pass the LR needle. Or needle through needle technique. Here LR needle is passed through large sharp needle. For obese patient, we can use pencil point needle, which can be passed through the introducer, which comes in the kit. If Quincke needle is used, it has to be made blunt like hypodermic needle. Or assume that the needle has overshoot due to cushion effect. So on insertion, when it has pierced the skin, withdraw again it back till the tip is just under the skin and pass to fill the pop. So the key points for LOR techniques are, before filling LOR, first feel bounce on the fascia. You can even scratch on the fascia and then fill the pop. Initially insert the needle at 30 degree or almost parallel till it pierces the skin, and then change the angle to 90 degree, that is complete vertical position, and feel for bounce and pop. These blocks provide relief only from somatic pain. So multimodal analgesia must be provided to all patients. These are volume blocks. So more volume is required. So one can decrease the concentration of drug to increase the volume. And success depends on thorough knowledge of surgical anatomy, cushion effects, and its prevention. Now we will move towards the basics of peripheral nerve stimulation. Paresthesia technique relies on subjective sensation that the patient experiences, and there is lack of objective response that the anesthesiologist can use. Peripheral nerve stimulator applies small amount of direct current, which is of low intensity and short duration to the needle, which when it is close enough is transmitted to the nerve, and the nerve is stimulated to produce motor response. The motor response is objective, reliable, and independent from the subjective response of patient. So it is important to understand the electrophysiology of the nerve stimulation and be familiar with the equipment to be able to perform peripheral nerve blocks to make it very safe and effective. So electrophysiology of nerve. Nerve cells has resting membrane potential of -70 millivolts. When neuron is stimulated, the electrical potential is decreased to -55. Transient change in ion permeability of the membrane occurs. There is increased conduction of sodium channel, and if the stimulus is strong enough, it causes depolarization, which sets off an action potential, which then propagates along the nerve to stimulate muscle and cause a contraction. The stimulus should be strong enough, and it is need to be applied for sufficient time to produce an action potential. Let us see some characteristics of electrical impulse. Rheobase. It is minimum current intensity required to produce an action potential. Then current below the rheobase will never generate a motor response, even it is applied for sufficient time. Then chronaxy. It is the minimum duration of the stimulus required to depolarize the nerve at 2 times of rheobase. This chronaxy value provides an indicator of relative excitability of nerve. So motor nerves, that is A alpha fibers, they have shorter chronaxy because of low capacitance of their myelinated membrane. Uninsulated nodes of Ranvier are the only place along the axon where ions are exchanged, that is saltatory conduction. Chronaxy of A alpha motor fibers is 0.05 to 0.1 milliseconds. A delta fibers have chronaxy of 0.15 milliseconds, and the pain fibers have longer chronaxy because of higher capacitance of their non-myelinated membrane. And chronaxy of C fibers is 0.3 to 0.4 milliseconds. So shorter the chronaxy, early the stimulation, and longer the chronaxy, late is the stimulation. So due to shorter chronaxy of A alpha fibers, we can stimulate motor nerve fibers without stimulating A delta and C fibers using current of shorter duration. Thus, motor response can be seen without pain. Ohm's law. This is I is equal to V into R, where R is the resistance and it is independent of the nerve stimulator, and it is largely a function of tissue impedance, poor connection of written electrodes and connecting wires. Modern nerve stimulators have constant current output. So by they raise or lower their voltage in response to change in the resistance. Now frequency, it is measured in hertz. It refers to number of repeating events per unit time. Ideal frequency to be kept is 1 to 2 hertz. Higher frequency will give more feedback to the operator, but often causes more discomfort to patient. Then polarity. Always remember negative to needle and positive to patient. So when negative current is applied to surface of the nerve, depolarization occurs leading to action potential. So needle should always be cathode and distant electrode applied to patient should be anode. If needle is positive, then the nerve gets hyperpolarized and higher current is needed to depolarize the nerve and obtain a response. Then Coulomb's law. E is equal to K into Q upon R square, where Q is the minimum current from needle and R is distance of stimulus source from the needle. So when we rearrange the equation, Q is directly proportional to R square. So very high current is required to stimulate the nerve when the needle tip is away from nerve, which may produce significant pain. And at low current, nerve will only be stimulated when needle tip is very close to it. So minimum current required to stimulate is directly proportional to square of its distance from the nerve. So if distance of the needle from nerve decreases from 4 millimeter to 1 millimeter, the minimum current required to stimulate the nerve will be reduced by 1/16. And then about stimulating needles. These are insulated needles are always better as they are coated with Teflon and silicone, which is a non-conducting material. And on stimulation, current density focuses on the tip only. So low threshold is sufficient to stimulate a target nerve. Also, they have depth marking. So for easy identification and documentation of needle insertion depth. Now let us see the stimulation and injection technique. First, check for proper functioning of equipment and connectivity cables. Then set the current to 1 to 2 milliamperes. Then pulse for superficial blocks 1 milliampere, and for deep blocks you can keep more than 1.5 milliamperes. Then pulse duration 0.1 millisecond and frequency 1 to 2 hertz. Once the muscle contraction occurs, reduce the current gradually and advance the needle tip slowly. Threshold current should be 0.3 milliamperes to 0.5 milliamperes. Aspirate and inject the test dose of 1 to 2 ml of LA, which abolishes the muscle twitch. Then increase the current to initial level. No stimulatory response, because loss of response is actually due to increased conductive area and hence decreased current density surrounding the needle caused by local anesthetic. This is the Rads test. So when there is no stimulatory response, inject the remaining drug. If there is failure of twist to disappear or pain on injection or high pressure during injection, it indicates that there is intraneural placement of the needle tip, and withdraw the needle tip by 0.5 to 1 millimeter. So remember, acceptable current range for motor response is 0.3 to 0.5 milliampere with pulse width of 0.1 milliseconds and frequency of 1 to 2 hertz. For sensory nerve, current of 2 to 3 milliamperes and pulse width of 1 milliseconds is required. What are the ideal characteristics of PNS? It should have the constant current generator. Current delivered by the device should not vary with changes in resistance of external circuit, that is resistance of tissue needle and connections. There should be accurate current display, the digital display of accurate current flowing. It should have monophasic rectangular output pulse to provide reproducible stimuli. Then variable output control dial. There should be wide range of current output, that is 0.1 to 5 milliamperes, and fine tuning of delivered current in low ranges should be available. Then ability to vary pulse duration from 0.1 to 1 milliseconds. 0.1 ms is ideal for mixed nerve, and wider pulse duration, that is 0.3 to 1 milliseconds, is useful in stimulating sensory nerves or stimulating nerves in compromised states. There should be a wide range of current output from 0.1 to 5 milliamperes, because for patients with neuropathy and sensory nerve stimulation, a higher current output is needed. And it should have safety features like circuit disconnection alarm, impedance alarm, low battery alert, and malfunction alert. Some newer additions in PNS. These are transcutaneous nerve mapping. It is non-invasive, rapid identification of superficial nerves up to the depth of 3 centimeters. But for this, you have to keep the longer stimulus duration, that is 1 millisecond, and larger energy, that is 5 milliamperes, should be kept. The ball-shaped tip should be atraumatic, and tip diameter is less than 3 mm to provide sufficient current density and spatial discrimination. Nerve mapping is useful to identify best site for needle insertion in patients with difficult anatomy. Then second one is percutaneous electrode guidance. It combines with transcutaneous nerve mapping with nerve block needle guidance. A small aiming device is mounted onto a conventional nerve block needle, which allows conductive needle tip to make contact with skin without scratching or penetrating skin. Once best response is obtained, needle is advanced in routine fashion and remaining apparatus stabilizes the needle. Then injection pressure monitoring. Disposable manometer for objective manometer of injection pressure during administration of peripheral nerve block. High injection pressure at the onset of injection, that is more than 20 psi, indicates intraneural needle placement. And sequential electrical nerve stimulation. This acts like a homing signal to elicit a motor response when needle is far from and not aimed directly at the nerve. So remember, peripheral nerve stimulation is not a substitute for anatomical knowledge. Thank you.
Wonderful, Smita. I think excellent lecture. Anybody wants to add anything or I don't see any questions on the YouTube live chat. Everybody just putting on their MMC numbers. Yeah. Smita, you can stop sharing your screen and
Yes,
so that
sir.
we can actually
Thank
see
you.
other people in the
Yeah.
gallery. Yeah. Akhilesh, we'll wait for a minute. You can stop sharing because we got, I normally keep around 5 to 10 minutes for question and answers. Akhilesh, you can stop sharing your screen for a minute.
Oh, sorry.
Yeah, no problem. So the other faculty can actually come in and if there is any questions or anything you want to add.
So I'll add something, just a comment.
Yeah.
I think one of the commonest things of all the safety features which you mentioned, Smita, and an excellent lecture, and I think this is wonderful starts to the RADS conference, is the making sure that the connection is established. Now, there's a lot of times I've actually seen people use a needle and keep poking the patient thinking, oh, I'm not getting a twitch, I'm not in the right place, and they keep doing it. But the problem is that they have not established the circuit. And when you actually insert the needle in nerve stimulators, the safety feature most of the time is either a noise, which actually changes in frequency, or secondly, there is in some of the nerve stimulators, there is a man. There's a symbol which comes on the nerve stimulator, which tells you that the circuit is complete. And if you're using nerve stimulators regularly, I would very strongly advocate that if you're not looking at anything, but look at that thing, because the amount of time, and all of us have been guilty of some time in the past, doing this and trying, oh, I think I'm in the right place, I'm still not getting a twitch, and then seeing, and you've seen the electrode has got off, or the circuit is incomplete due to some reason. So I would just say as a comment that when you're using nerve stimulator, that is probably one of the most important things you need to do. Make sure your circuit is complete. Otherwise, what you might have done is you might have gone in and out, and you might have actually hit a nerve multiple times, and you've increased your chance of getting a nerve damage exponentially in that. That's the only comment. Thanks.
There's another thing I think I've not seen with other nerve stimulators, but with Pajunk, they provide you the nerve stimulator in a case. And in the case, there is a little red knob-like thing. So you can attach your two ends of the simulator and then you can test. So that provides a resistance. It's like completing a circuit. So you can check the nerve stimulator before you use it on the patient. So you can do it every morning. But I also did it. I took actually a drawing of needle, bend it so that we are able to actually attach it to the connectors, and it worked the same actually. So you can use it along with a blunt large needle which goes into the connectors for the nerve stimulator. Similarly, it goes on to that, and you can actually use it. I had, I think, posted about it previously, but if anybody has doubt, I can actually post that how to test a nerve stimulator as well again sometime.
We've got a question.
Yeah.
So this question is from Kshama Shah, and she's asking, how do you check PNS for a sensory nerve? Can you use peripheral nerve stimulator to check for a sensory nerve?
I think Smita actually answered that very, very nicely. If they had, you want to tell that, Smita? Then I can add to it.
Yeah. For this, you have to increase the current to 5 milliamperes and increase the duration to 1 milliseconds. Then only you can check the sensory nerves because it has a longer chronox.
Yeah, exactly. I think that is we all read Chronexy during our first MBBS time. We just probably ratified it and never actually thought what exactly it is. And it is here that actually it makes sense here that for sensory nerves you need to require higher stimulating current, and you need to increase the duration as well, so they don't get stimulated that easily. That because of the Chronexy, which is 0.3 to 0.4, or maybe a little bit less than that. Actually, that's foreseen. Yeah. So and that's the main reason why in awake patients, when you use a lower current and lower frequency, you get muscle twitch, but they are not as painful unless as you are going to. You don't actually have to use more than 1.1 milliamp in awake patients. You can start off with 1 milliamp and 100 milliseconds. So that's all you need to actually use that. So high current, remember that. And same thing is true for patients who have peripheral neuropathy. So you can use PNS in patients with peripheral neuropathy, but you would actually need to use a higher current, and this duration of the stimulus need to be increased as well.
Yeah. So there are a couple more questions.
Yeah.
So-
One more thing, Dheeraj. There is actually a whole chapter on the Medicis apps on basics of the PNS and ultrasound they can access. So it's all mentioned there. So they can go into Medicis app and actually read that.
Yeah, thank you, Shiv. I think it is so important that to understand that every knob on the nerve stimulator has some function. Yeah. So your frequency and your duration of current and the amount of current applied. These are the three things which actually Smita explained very, very nicely. And I think, when you actually have those, use it and think about it. The question I'm trying to make sense of this question, Shiv. I'm so sorry, but the question has come back as like, can we use any nerve located, or does it make any difference? I'm still trying to understand what that question means. That's from Suryakant. If you can make that question slightly more clear, it'll be useful. And Vadi Raja said that circuit check also comes with B Brown PNS. So thanks for that, Vadi Raj.
Yeah.
Means we can't use nerve locator for nerve blockade.
Oh, is that what he's asking? Okay.
I think it might be that he's asking about is there a difference between different peripheral nerve stimulators as well. So most of the peripheral nerve stimulators work on the same principle. They might have slight differences. Like for example, B Brown has got sense, whereas the Pajunk hasn't got that. So there are only few small differences, I think, in the nerve stimulator. But if it means that can you locate all the nerves with peripheral nerve stimulators, I think most can be, actually, to be frank.
Yeah.
I think
I've actually shown how to use it for erectus spinae, even for tab block, for even ilioinguinal. I've shown for almost every block you can actually use a nerve stimulator.
We have nerve stimulators in India where we can do mapping as well as we can do nerve location, or there are different modes of stimulation. So nerve stimulating mode, nerve locating mode, all those things. And while giving the blocks, we use that nerve locator mode. It's not nerve stimulation mode. So that is how. Yeah.
So nerve locator can be actually attached to any nerve stimulator. You just need a different kind of electrode system for that. It can be used. It's only about if you're able to increase the amount of current, like we have said, for stimulating a nerve. So it's okay for superficial nerves. So for example, if you're using it for maybe interscalene or supraclavicular, you'll be easily able to locate it. But the precision of the nerve locator has not been validated. That means that if you actually mark the stimulated nerve, mark it, and then put a needle there, it is not necessary that you would be 100% sure that it will go and stimulate the nerve. People have used that kind of mapping system, and it was published in BGA long ago. It's a good teaching tool, though. You can stimulate and show this is the response, how it changes from one to other as you move the electrode system. You can actually solve. So it's a good teaching mode. And it gives that, okay, fine, you need to actually have your needle in this location. Don't be 100% that your needle has to be just at the point where you got the response. You might actually have to adjust it a little bit here and there. That's thing. I think, but it's a useful thing. But don't try to actually stimulate your lumbar plexus with that. You will never be able to actually reach that cut. So superficial, yes, but deeper ones you won't be able to stimulate with a nerve stimulator. Okay.
In the interest of time, we'll just allow one last question, which is from Renuka, which is saying that why is it important to blunt needle tips?
Do you want to answer that, Smita?
Yeah, because we have to feel the bounce and pop that cannot be filled with the sharp needles.
Yeah.
So that's why we have to blunt it. And the nerve plexus goes through the fascia. So we have to do the volume blocks.
So I think the confusion is probably because some of the it's very common for people to just use a hypodermic needle for paresthesia technique for supraclavicular. But for the facial nerve blocks where we are trying to pierce the fascia and feel the pop, you won't feel those pop if the needle is not blunted. So that's the difference. So if you're using it for a nerve plexus for, say, supraclavicular, people would want to do that. But again, even you can use a blunt needle, because if you are touching the nerve, the patient still feels, so you don't have to be touching it with a sharp needle. If you look at the block needles, which are short beveled, the one we use for our ultrasound guided blocks or PNS block, they are also a little short beveled. They give you the similar kind of pop, and when they touch the nerve, patient feels them. So it doesn't have to be a sharp needle to feel paresthesia as well. But going through the skin, it might be difficult. You need to use different techniques, which you have very well mentioned, Smita, like using a little nick on the skin or using a sharp to make a nick and going through that. That's a different thing. And for facial nerve blocks, always remember the cushion effect. You need to go through the skin before you start advancing the needle to feel the different pops. And we will demonstrate this in the live workshop. We will demonstrate what exactly is cushion effect. How do you get away from the cushion effect? Yeah.
Okay. I
So
think
shall
it's
we move on to the
7:30.
next one, Dheeraj?
Yeah. So
Thank you, sir.
Smita, thank you very much. Excellent
thank
talk.
you.
It's
Thank you,
woken me
thank
up
you.
at least. Yeah.
Yeah.
Very, very
Well
good.
done,
Thank you
well
very
done.
much.
Yeah, very well done.
Thank you for giving me opportunity once
Yeah.
again.
So shall we move on to the next lecture? So we'll start with the head, start from the head, then move around the body. And with that, I would actually ask Akhilesh to, I'm sorry, I didn't actually introduce the speakers at all. I assumed that they would actually introduce themselves. So please do give a little introduction when you are speaking, and then go on from that. Akhilesh, over to you for your head and neck lecture.
Yes, sir. Yes, sir. Thank you, sir.
You can share the screen.
Yeah, I'll be sharing the screen. Am I visible, sir?
Very clear.
Okay. So thank you, Smita ma'am, for a wonderful lecture prior to this one. And I am Dr. Akhilesh Pahade. I am Assistant Professor, SRM's Institute of Medical Sciences, and I'm from Bareilly. I'll be presenting my topic of head and neck nerve blocks. So why do we need this? Why did we need this lecture? Why do we need nerve blocks for head and neck procedures? And the answer to that is that these blocks can be used as sole anesthetic techniques in the OR, like for example in awake craniotomies, or you can use them in the EDs where there can be some scalp suturing going on, or they can be used in patients who are poor candidates for general anesthesia. They can be used for intraoperative and postoperative pain relief as adjuncts to general anesthesia. They can be used for treatment of painful conditions like neuralgia and headaches. And they can be used for one of our favorite indications, facilitating airway access. Now, briefly, we'll go through the head and neck nerve supply. Now, as you can see in this figure, the face and the underlying structure, part of the anterior part of the scalp, is supplied predominantly by the trigeminal nerve or its three divisions, the ophthalmic, the maxillary, and the mandibular. The posterior part of the scalp, that is the occipital region, is supplied by the greater occipital nerve or the lesser occipital nerve. The area behind and below the pinna is supplied by the great auricular nerve. The region in front of the neck is supplied by the anterior cutaneous nerve of the neck, while the lateral part is supplied by the supraclavicular nerves. Now, this lesser occipital, greater auricular, anterior cutaneous nerve of neck are all arising from the cervical plexus. And in subsequent slides, we'll be learning how to block them as well. The nerve blocks that we'll be discussing today will be the scalp block, followed by cervical plexus block, the airway blocks, and for completion, we'll be completing with finishing it with maxillary and mandibular nerve blocks under the headings of indications, where exactly these can be used. What is the relevant anatomy? What landmarks should be followed for performing this procedure? What are the complications? And a few tips, tricks, and caution points to make your block more successful and complication-free. Moving on to the scalp block. Now, this picture everyone I'm sure must have noted somewhere in some news channel that a neurosurgeon is performing a brain surgery and the patient is either reciting a poem, playing cards, maybe playing a violin. And this is actually the expertise of the anesthetist. That is why this surgery has been possible, that the anesthetists have performed a wonderful scalp block, resulting into this beautiful procedure. Now, the indications for scalp block include neurosurgical procedures like awake craniotomies, stereotactic brain biopsies. The plastic surgeon might use it for some kind of reconstruction of the scalp. Short procedures in the ER, as I mentioned before, for suturing of some lacerations, and for management of headaches and neuralgias in the pain management clinic. Now, if we go to the scalp block, there are about 6 to 7 nerves that need to be blocked. The supratrochlear, supraorbital, auriculotemporal, greater occipital, lesser occipital, and the greater auricular nerve. We'll be discussing each of them. First, we move on to the supraorbital nerve block. The landmark for this is the supraorbital foramen. Now, the audience who are listening to this lecture, I will just, if possible, just go through your own face and try to palpate the supraorbital foramen. It is around 2 centimeters from the midline laterally, lies somewhere under your eyebrow. And once you palpate it, what you do is you just take a needle with 1.5 to 1 ml of local anesthetic solution, inject it. Beware that you should not go inside that foramen. It should, subcutaneous wheel should be raised just above the periosteum. As the problems for this nerve block are globe rupture and hematoma, and your block is likely to be more successful if once you have raised the wheel, you can apply firm pressure on it. Now, while preparing for this lecture, I had come across one of the study which compared the point of insertion, whether we should insert the needle from above the eyebrow or from below the eyebrow. And they found that any injury to the eyeball is probably lesser when the injection is done from below the eyebrow, maybe because the pointed structure of the needle doesn't come directly in contact with the globe. But anyway, that's a personal choice, how you're comfortable with. The efficacy of both the techniques is almost the same. Now, once you have done the supraorbital block, you move to the extension of this block, that is the supratrochlear nerve block. you just move around 1 centimeter towards the midline, and again inject a local anesthetic solution of 0.5 to 1 ml here, and your nerve will be blocked. The complications and the pulse for this block are almost the same. Next, we go on to a nerve block of the zygomaticotemporal nerve. This nerve is slightly different from the other nerves of scalp block because it has got two segments, the superficial segment and the deep segment. So number one, you have to reach the deep segment. It's a bit painful. The nerve actually arises and then ramifies once it pierces the temporalis fasciae. And the landmark for this nerve block is the supraorbital margin, the posterior aspect of the supraorbital margin, just lateral to the posterior aspect of supraorbital margin. And superficial and deep segments together, they will need around 8 to 10 ml of local anesthetic solution. Beware that this is painful and you might need some amount of sedation for performing this block, especially the deeper segment block. Next, in the scalp block is the auriculotemporal nerve block. And this is also again a superficial block where you use around 3 ml of local anesthetic solution. And the level of block is just anterior to the level of tragus above the temporomandibular joint. However, you should be careful enough because there is a superficial temporal artery running nearby. If you just palpate, you can even feel the pulsations in this region. And if you go deeper in this, you're likely to affect a facial nerve block. So beware that you should be maneuvering in the superficial planes only. Do not go deep. Aspirate before you inject, and you will be successful. Next is the greater and lesser occipital nerve blocks. Now, the landmark for this is you palpate your mastoid, you palpate the occipital protuberance, and you draw a line. You divide that line into three segments and at the junction of the lateral 1/3 and the medial 2/3, you will find the lesser occipital nerve, and at the junction of the medial 1/3 and lateral 2/3, you will find an artery which is called as the greater occipital artery. Just medial to this, as you can see in this figure, is our greater occipital nerve. So you have to block both these nerves to get the desired effects. Again, aspirate before you inject. From the scalp block, we move on to the neck, the cervical plexus block, and it has got a variety of indications. Maybe I don't know how many are using it, but it's a wonderful block. And one of the primary indications for this block is carotid endarterectomies. We have a surgeon here who actually has done a carotid endarterectomy only on this block, a totally awake patient. Apart from that, you can perform clavicular surgeries, central venous cannulations, thyroid and parathyroid surgeries, treat cervicogenic headaches, vocal cord surgeries, dental abscesses can be drained, lymph node dissections, and plastic repairs on the neck. All of this can be achieved with this cervical plexus block. Now, briefly, I'll be explaining about the cervical plexus anatomy. The cervical plexus is formed from 4 roots, C1, 2, 3, and 4. Now, these 4 roots, they form 3 loops, the C1, 2 loop, C2, 3 loop, and the C3, 4 loop. Now, from this part, the C1 is completely motor, and it gives a branch to the hypoglossal nerve, which innervates geniohyoid and thyrohyoid muscle. Then they form the descendens hypoglossae. And from C2 to C3, we get the descendens cervicalis. And together, when these combine, they form what is popularly known as the ansa cervicalis. The C3 and C2, C3, and C4 also give deeper branches, muscular branches to sternocleidomastoid, spinal accessory nerve, innervating the trapezius, levator scapulae, and the scalenus muscle. Now, this cervical plexus has superficial branches as well, or the cutaneous branches. And they can be divided as ascending branches, the transverse branches, and the descending branches. The ascending branches are the greater auricular nerve and the lesser occipital nerve, which we just encountered in the scalp block. The anterior cutaneous nerve of neck, which innervates the front of the neck, and the supraclavicular nerves, which innervate the part above the clavicle. The superficial cervical plexus block, the landmark is from the midpoint of the lateral border of the we palpate the sternocleidomastoid, the posterior border, and find the midpoint of that posterior border. Invariably, you will find one vein, that is the external jugular vein, crossing over. And what I do is, with around 10 to 12 ml of local anesthetic, I give a fanning or a field block on both sides of this midpoint. Now, to increase your success rate, what you can do is, especially for the surgeries involving the midline, you can you can give a midline injection from the thyroid cartilage to the suprasternal notch, so that the crossover nerves from the other side of the cervical plexus can also be blocked. Next, we go on to the deep cervical plexus block. The landmarks for this block are the mastoid process and to the Chesnack tubercle, which is the transverse process of the 6 cervical vertebra, can be palpated, as you can see in the figure, just posterior to the clavicular head. Now, you divide this, from this posterior line that you have drawn, you go 1 centimeter further posteriorly and draw another line and divide it into 3 equal segments, separated by 1.5 to 2 centimeters away. The topmost division, the point of division will be C2, next will be C3 and C4. Now, you can block each segment with 3 to 5 ml of local anesthetic solution. And sometimes, even if you give a single injection at C3 level, that will be sufficient to block the whole deep cervical plexus plexus. However, you should avoid deeper injections for epidural injections, in order to avoid epidural injection, any spinal cord trauma, subarachnoid block, or any nerve injuries. Next is the intermediate or subfacial cervical plexus block. Now, what you can do is, you can see in this figure that this is the skin. The inside one, this is the investing fascia of the neck. Now, this intermediate cervical plexus block is the drug is being injected just below this investing fascia of the neck, behind the sternocleidomastoid. This is the sternocleidomastoid muscle. And the deeper cervical plexus block the drug is being located near the transverse process under the deep cervical fascia. The local anesthetic volume that is required for intermediate cervical plexus block is around 15 to 20 centimeter. The depth is 1 to 2 centimeter. And you have to just go deep from the midpoint of the posterior border of sternocleidomastoid, perpendicular to the skin. Moving on, next we get to the airway blocks. Airway blocks can be used for 2 indications. One is the awake fiber optic, which can be done through the oral cavity or through the nose. Or you can use it for awake look procedures, where you insert a video laryngoscope to have a look exactly what you can visualize. The airway is innervated by trigeminal nerve, which innervates the nose and the nasopharynx. The glossopharyngeal nerves, which innervates the posterior 1/3 of the tongue and the oropharynx. And the lower airways are supplied by the vagus, the superior and the recurrent laryngeal nerve. Trigeminal nerve block, this is utilized when you are going for a nasal intubation. And you will probably need a cotton pledget applicator for this. And the landmarks for this are the upper border of the medial turbinate, posterior wall of the nasopharynx, and the dorsal, for the innervating the dorsal nose, the cribriform plate, near the cribriform plate. By this, you can block the greater and the lesser palatine branches, palatine nerves, and the anterior ethmoidal nerves. The application, the clinical pearl for this is that you can use nebulizers, atomizers, and spray as well, instead of going for the pledget application. Next, we move on to the glossopharyngeal nerve block methods. And in this, there are 3 methods. One is the topical spray application, nebulization, and sprays, which are safer but less efficient. They can be, you can put soap pledgets, especially in the palatal glossal, near the palatal glossal folds, for 10 to 15 minutes. The third and the most effective, even though not that safe, are the intraoral or the peristyloid approach, where you deposit the local anesthetic by injection, submucosal injections. Going on to the glossopharyngeal nerve block intraoral approach. Now the landmark for this is the base of the posterior tonsillar pillars, as you can see in this figure. This is the base of the posterior tonsillar pillars. You have to inject submucosally 2 to 5 ml of the local anesthetic solution. But beware, there is a major artery going by, and that's a carotid artery. So always aspirate prior to injecting. Secondly, the patients might have difficulty in complying with your orders when you especially depress the tongue. So topicalize the airway or oral cavity or tongue prior to the block. Another approach for glossopharyngeal nerve block is the peristyloid approach. A bit difficult, I must say, and a few complications also associated with it. Number one, the landmarks for this is you have to join a line from the angle of mandible to the mastoid. Try to insinuate your finger between this line, between the mastoid and the angle of mandible to palpate the styloid process. Now, it's a small structure and difficult to be palpated. Now, with your needle, you just try to hit this styloid process. Once you have hit the styloid process, you redirect this needle slightly posterior and then inject 5 to 7 ml of local anesthetic solution. Now, the points to ponder on this is that there's a carotid artery nearby. If you happen to block the hypoglossal nerve, along with it, you are likely to lose your airway. And number 3, there is a recurrent laryngeal nerve vagus also nearby. So the patient may complain of hoarseness of voice once you have given this block through this approach. Going on to the vagus nerve blocks. Now, as you can see in this figure, it is the superior laryngeal nerve and the recurrent laryngeal nerve which are predominantly supplying. Next, we go to the superior laryngeal nerve. It has got 2 branches, the internal laryngeal nerve and the external laryngeal nerve. The landmark of this block is the greater corner of hyoid. Local anesthetic of choice is 2% of lignocaine. You have to give this block bilaterally. But beware, once you have palpated this hyoid, you push this hyoid to one side, but don't be forceful, be gentle because it's a weak bone and can get fractured. You put the needle on the greater corner of hyoid and redirect it slightly lower and then push it slightly inside. You will have a giveaway feeling of the thyrohyoid membrane. Suppose you happen to give the block outside this thyrohyoid membrane, you are likely to block the external and the internal laryngeal nerve both, resulting into cricothyroid muscle block, which is the dilator of the airways. Going on to the recurrent laryngeal nerve block. This is the transtracheal block also, as it is called. The landmarks are the cricothyroid membrane, which lies between the thyroid cartilage and the cricoid cartilage. The local anesthetic of choice, in this case, around 4% lignocaine. 4 ml of local anesthetic is needed. Just if you palpate your thyroid and you move downwards, you will find a depression between the cricoid cartilage and your thyroid cartilage. You just have to move in and be very, very sure that before you inject your local anesthetic, you are aspirating air from, and once you have aspirated the air, you give a rapid bolus injection of 4 ml of local anesthetic. The patient, you should warn the patient that there will be a vigorous cough that he might be experiencing, and he should not be really concerned, because the faster the injection, the chances are that you will have a better block. Next is the mandibular nerve block, and the indications are mandibular surgeries. Surgeries on the anterior 2/3 of the tongue, trigeminal neuralgia, post-herpetic neuralgia, and mandibular trauma. The mandibular nerve block, the landmark for this is the mandibular notch, which is around 1.5 to 2 centimeters in anteriorly and below the tragus. And once you have entered, you should try to enter this notch from the anterior aspect. Going on to the maxillary nerve block, the suprazygomatic approach is preferred. The superior edge of the zygomatic arch below and the posterior part of the orbital rim above. You inject at 90 degrees and then you go in by around 2 centimeters. You encounter the wing of sphenoid and then you further direct it caudally and you inject 5 ml of the solution. This block is better appreciated if it is nerve stimulator guided. And you can find temporalis muscle stimulation and mandibular movement as well. Thank you. Shiv, should I stop sharing?
Thank you. Yeah. Thank you, Akhilesh. You can stop sharing. That was wonderful. I think very concise, to the point, and I think he covered everything, which is important. Things, docs, which are important for the anesthetist. I think the chronic pain guys could do a lot more blocks related to head and neck, but for the anesthetist, I think this covers everything. I couldn't actually see any questions posed on the live chat to that. So anyone from the faculty would want to add anything or want to ask anything? Dheeraj? Looks like he's going to get a cup of tea. It's early morning. It's nearly 8 o'clock. I think one of the blocks, I think airway blocks are important, but most people just go for spray as you go. There are people who still do superior laryngeal nerve block and recurrent laryngeal, injections into the trachea or transtracheal injections are very commonly used by respiratory physicians. They take 10 mLs and first injection, they just give 2 mLs. Once they let the patient cough, it spreads, and then go and give the rest of the 8 mLs of lignocaine, and they just use 2% lignocaine. And they are able to do awake bronchoscopies with that. So it's quite a useful technique to learn transtracheal injections. And then coming to another block, which is very useful, is the cervical plexus block. And in that, your intermediate cervical plexus block, which I've discussed numerous times on the group, is very good. It blocks not only the superficial nerves, but also the deeper nerves, the deep plexus as well. Easy to do. You pop through the investing fascia at the posterior border of sternocleidomastoid midpoint, and you're done. You just inject 10-15 mLs of local anesthetic. But if you want a quicker action, you can again do a combined intermediate and superficial cervical plexus block. And people do carotid surgery just using these two blocks, intermediate and superficial. So the deep plexus block hasn't got much of an indication in the present times. You can use these blocks even for your, internal jugular in awake patients. Simple procedures like lymph node biopsies. I would say it's a very useful block. Mandibular nerve block, we first demonstrated this in Rajkot in 2015 with nerve stimulation. And useful block again for, fractures, fracture mandible. It's very, very useful block. One of the faculty there was who does quite a lot of this, and they were doing, just landmark like the dental people do. And we said, no, why not we actually do it with nerve stimulation? And we got a good response. The video is still there on the group. Anything else? Anybody else wants to?
Sir, there's a question from Dr. Dilnar.
Yes.
She has asked about how we can identify the posterior border of sternocleidomastoid in obese patients.
Yeah, same as like you do for your interscalene. Ask them to, in a awake patient, you can do it very easily. Ask them to lift their head up and turn, and you can actually feel the sternocleidomastoid stands up. It stands up in them. Yeah. And sorry?
But I'm asking login.
Who is that? Sorry, somebody is.
No, I'm muted. Don't worry. It's fine.
Yeah.
Someone's
Okay.
talking in the
Oh, so
background.
yeah, yeah. Yeah, so you can ask the patient to lift their head up and look. It can be difficult in patients who are short necked. So two things I would actually say is, one thing is that don't have the patient completely supine when you're trying to do that. Have the patient at around 45 degrees or little propped up. And that brings the shoulder down and increases space. That is actually a good thing even for when you're doing blocks on the interscalene block or supraclavicular blocks in the obese patients. Have them sitting up. The whole body weight drops and you create more space rather than actually having patient lying supine, where everything is bunched up. Then you don't have any space at all. You can't feel anything. So have them sitting up. The other thing people do is they put a pillow under the shoulder, but that is uncomfortable for the patient. And you don't need to actually. That's not really required in obese patients. You just sit them up and feel, and ask them to do a like a hold your neck up and maybe do a like a sniffing the air kind of thing, and you will be able to see the sternocleidomastoid and feel it. I hope that is clear, Dinesh, that you got your answer to that. Oh, Dr. Kale, you're muted. You're muted.
Hello.
Yes, Dr. Kale.
Yeah. Yeah. See, I want to ask, have you any time encountered surgical emphysema while giving transtracheal injections or something like that? And how did you manage that?
No, I haven't actually seen any because, like I said, we don't do it that regularly, but we have a respiratory physicians. We have a list with respiratory physician is a friend of mine who I actually trained together in intensive care. He does every Wednesday. He does a list with the bronchoscopies, and he does it in all cases. That's the technique he uses. Transtracheal injection, 10 mLs, 2 mLs initially, let them cough, then go back again and rest 10 mLs, and then he does the bronchoscopies on them, and not a single case of this surgical emphysema or.
Because I myself have experienced this when giving transtracheal injection.
Right.
And maybe patient had coughed a lot as soon as the injection was done. And then that might have punctured the needle somewhere else. And that causes the surgical emphysema. And it was huge surgical emphysema. So you need to manage that.
Yeah. So it's probably not from it is from the coughing, maybe a violent coughing, which actually just patient probably had a bullae which ruptured and caused that. And anyway, the management for subcutaneous emphysema is just, you wait and watch. But if it becomes too, then people do actually do a nicks in the skin.
Yes.
And let
or
that,
little puncture, multiple punctures.
Multiple punctures to actually that they have. But most of the time it is just a wait and watch and just.
Thank you.
Just
it's actually it's actually
Yeah.
the air which causes quite a lot of problem, and just multiple punches. I mean, we do tracheostomy. I did a fiber optic just awake bronchoscopy just day before yesterday, and I actually find that giving quite just spraying along as you go is also works very, very well. I mean, this patient I just sprayed along. I didn't have to go just below the carina. That's where you have to just slightly be worried about touching the carina in awake bronchoscopy. Even when we do a lot of percutaneous tracheostomies, it's not necessary that we actually see sort of surgical emphysema in them. I think it's a combination of when they do open tracheostomies, if you have not dissected the pretracheal fascia properly, and then you have IPPV which goes on to the patient, or your patient's breathing, there's a lot of air leak which causes that. During COVID, we had a lot of patients who had surgical emphysema, and all we did was observe, and then you actually, just do multiple punches. Sometimes you can actually do cannulas and leave them open. So instead of giving multiple punches, what we do is you put in a cannula, remove the stellate, keep the cannula, and then just press the skin on that so the air escapes from that. It's not the oxygen or the CO2 which is a problem because it gets absorbed very well. When it is air, it is the nitrogen which actually doesn't get absorbed, and that causes more problem. But when you're ventilating a lot of patients, the oxygen content is very high. Sorry for deviating. I think we are almost in time.
No, this is that's absolutely fine. I mean, you actually see we see it very commonly in the upper GI surgery patients where they do transhiatal repairs and kind of things. It's very common with and CO2 that rises. So that's a different situation. Well, I think this is because for violent coughing,
Yeah.
and with the rupture of a bullae somewhere, it can happen with any patient.
We have a few questions
Volume
on
of use,
thyroid
yeah.
surgery. Thyroid surgery, sir. What is the volume of the LA that is required for a thyroid surgery? And secondly, do you go in for a bilateral cervical plexus block or a unilateral block is enough?
No, so if you're using for thyroid surgeries, like you don't have to. I think the worry is with people who talk about, oh, we need to do a deep and superficial both. You don't have to. The surgery is mainly cutaneous. You don't actually have to block the muscles. If the surgeon has to dissect through the strap muscles, then that is not a good sign. They have to just retract them, and they need to be very gentle. So coming to the volume of the block or the volume of local anesthetic required for superficial cervical plexus block, you just need around 10 mLs on each side. And you can use 0.25% or 0.375% for that. And you need to have patience. You need to check before you do the incision. Just check that it's working properly. And don't even think of you can give intermediate plexus block, but if you're worried, you can do one side intermediate plexus block and other side we can do just a standard the superficial cervical plexus block. Now there is a little bit of confusion in the literature, but I think Akhilesh has made it very clear, and that's also there in the review article I've written about a cervical plexus. The intermediate plexus is injection under the investing fascia. Okay. Outside the investing fascia is superficial cervical plexus block. So, okay. So that need to be very, very clear for both. So I think that should clear that.
So one last question. Is there any block can help give for a patient with a nasal fracture for reduction? Nasal bones.
Reduction of nasal fracture. There used to be something called a bridge of nose block, which was described in pediatrics by T.C.K. Brown. He's written a textbook as well as Australian from Melbourne, Children's Hospital. What do you say that you actually go on a bridge of nose and inject local on both sides subcutaneously? I don't know whether it will catch any of those branches which supplies that. But again, I think it could be just a local nasal spray, which can block the nose very easily in the nose. So I think that's the only thing I can think of about nasal surgeries. I have used when they have on the GA, given the bridge of nose block, it works, but then the surgeons tend to inject local anesthetic anyway, local with adrenaline so that also gives some amount of analgesia for the surgeries.
Okay, Shiv, I think in the interest of time.
Do you know anything about any?
No.
Yeah, I think it's a combination of just local infiltration or spray or bridge of nose block. Yeah. Okay. Shall we then move on to your talk, Dheeraj? So Dheeraj will be talking about shoulder blocks. He does a lot of them. I think he does mostly with ultrasound, but then we move out from his to the mainly PNS guided blocks. Over to you, Dheeraj. Yeah.
Yeah, so you can see the
You can
thing, yeah?
introduce yourself, right? Yeah, see.
Okay. Oh, not much. I mean, I don't want to say anything much. My name is Dr. Dheeraj Jail. I'm intensive care stroke anesthetic consultant, work in Dartford in the UK. And thank you, Shiv and Pramod and the organizing committee of RAD for giving this opportunity to talk on shoulder blocks. As Shiv rightly said, this is probably what I do the most, but most of the times or all the times now, I do it under ultrasound. But in the past, we have done this with the nerve stimulator, and that's what I'm going to talk about. So what are the blocks which can be used for shoulders? I mean, there are multiple blocks which can be used. Commonly, the most common one is the interscalene brachial plexus block. You could use the supraclavicular block. You could use the upper trunk block if you're using an ultrasound. You could use a costoclavicular plus suprascapular nerve block. You can again use a suprascapular nerve block plus infraclavicular block. You can use a suprascapular nerve block plus an axillary nerve block, or nowadays, more and more people have started using PENG. But when you talk about these blocks, it's very important to understand what is the purpose for which you're giving the block. And I think this is very, very important. You either give the block for optimizing surgical conditions and doing the whole procedure under a block, in which case you are actually providing an anesthetic. You might require a very small amount of sedation along with that, or you can do a patient completely awake. You could use it just for a post-op analgesia, in which case you are going to be using a general anesthetic for the patient, and you use the block for providing pain relief. And then you think of methods in which you can prolong the pain relief for the patient. You could use it for both. For example, you use it for anesthesia as well as for post-op analgesia. As Akhilesh mentioned in his starting slide, you could use it for acute and chronic pain conditions. Now, shoulder is a very unique joint, okay? It's a joint made up of a few joints. It's a joint made up of ligaments, and it's a joint which is made up of a lot of muscles. And the pain which arises from the shoulder is not just which is limited to the bones or to the ligaments or to the muscles. I mean, it can be muscular cramps, it could be adhesive capsulitis, it could be capsular pain, and hence you find that a lot of patients have both acute and chronic pain with the shoulder, and blocks could be quite useful for that. I mean, there was an old adage which they always used to say is doing a shoulder surgery without a block is like doing a laparotomy without an epidural. But slowly we are finding that, epidurals are not being used as much as they used in the past, but blocks are here to stay for shoulders at least. You want to reduce complications and you want to reduce costs. And, there's a lot of discussion. I'm thinking recently we had a discussion about green anesthesia and how do we save the planet, and we should go more greener. And I can tell you that there is nothing more greener than actually giving a regional anesthesia or a regional anesthetic block. And of course, all of us are interested in reducing the length of stay of patients. We don't want them to be in the hospital for a long time, and giving blocks is highly beneficial. Now, for the shoulder, it is very important to understand the anatomy. Now, I know this is a very busy slide, and this is the reason I put it there. Now, most of you will not be able to read it, so don't worry about it. But here you have a suprascapular nerve. Here you have a lateral pectoral nerve. Here you have axillary nerve. You've got musculocutaneous nerve. And the whole thing, if you look at it, it's just bunched up, right? It is nerves which supply various muscles there. It supplies various part of the capsules there. And that's why it is a very, very complicated joint. It's not as simple as having the hip joint replaced, which is a ball valve kind of a joint. It's completely different. Now, we develop better understanding with this picture rather than talking about what we call as individual nerves. We talk about bridges to the shoulder. Now, this photograph which we have here, when Philip Peng of the Peng blocks, the guy who's become very famous because of that, he had actually put it on Twitter even before he had published the articles, because he was so excited, because he was saying that we should not be talking in terms just of about nerves, we should talk about bridges, and these bridges are generally made up of three major nerves, which are suprascapular nerve, lateral pectoral nerve, and axillary nerve. And I think if you look at this chapter written by in Regional Anesthesia for Shoulder by Alfonso Rodriguez Gomez et al., you'll find that they describe the shoulder joint and its innervation this way in terms of bridges again, where you have axillary nerve which supplies this part of the shoulder joint. You've got the suprascapular nerve which supplies the posterior part of the shoulder joint, and then you've got lateral pectoral nerve and nerve to subclavius to a certain extent. Now, if you want to keep it really simple, I mean, I've just taken a part of the brachial plexus, and you will be discussing brachial plexus in the next 3 or 4 lectures multiple times. So I'm not going to dwell on it. But the most important part, if you look at what we have talked, the nerves which are very important to us are suprascapular, it's axillary, lateral pectoral, and maybe the nerve to subclavius. There is a little bit of innervation from the medial cutaneous nerve of the arm, and sometimes the intercostobrachial if you're doing proximal humerus. Apart from that, it doesn't have much importance. But all of this, if you look at it, it originates from C5, C6, right? The C5, C6 joins, forms the anterior and posterior division. Before that, you have suprascapular nerve, which has been given. You have nerve to subclavius given. This is the famous or the infamous Erb's point, where if you get injury, you get what is called as the Erb's paralysis. And then you go down again, if you block the C5 and C6, and when the anterior division joins the division from C7, you get the lateral pectoral nerve here, which means then you have C5, C6, C7 as the innervation of lateral pectoral nerve. And then the C5, C6, the posterior division goes and joins all the posterior division to form the posterior cord, and axillary nerve comes from the posterior cord. And hence, even though we say that the nerves supplying the shoulder are the suprascapular nerves, you've got your axillary, lateral pectoral, subscapular, the median cutaneous nerve of arm or intercostobrachial in some instances, what becomes absolutely clear is if you block C5 and C6, and if that local anesthetic somehow tracks to C7, you will be able to take out most of the nerves which supply the shoulder. And it is not surprising because of this, that interscalene block still remains the gold standard. If you want to learn one block which will help you supply the shoulder joint, it is the interscalene block. There is no other block for this. Okay. Now, interscalene block using the nerve stimulator, there are various approaches which have been described. The classical approach is the Vinny's approach. This is the approach which was described for paresthesias. It was never described for nerve stimulator. And I think there are a few of us here who've actually used paresthesia technique in the past and probably used this Vinny's technique. The posterior technique is when you come from behind and try locating the brachial plexus from behind. It was modified by someone called as Pippa, and it's called as the Pippa's technique. But these are the two techniques which I won't be describing much, because I think it's very important you learn one technique. And if you want to learn one technique, it is a low approach to the brachial plexus, or the interscalene approach to the brachial plexus, which you should be using. 15 to 30 mL of local anesthetic is what we normally recommend, and it's useful for shoulder and proximal humerus surgeries. People give interscalene block. Sometimes if you use a large volume, you can block your hand. It can be used for hand surgery, but it is not a block to be used for hand surgeries, because you get a lot of ulnar sparing. It's hardly ever blocked, and you won't be able to use it for anything below your mid-arm. Now, the procedure which has to be done, this is what Shiv was saying in relation to Dilnaz's question. And I think the landmarks is very important to find out three things, right? You want to know where the clavicle is, you want to know where the posterior border of sternocleidomastoid is, and you want to know the external jugular vein. Now, sometimes in patients where you can't locate it, you know that the sternocleidomastoid will run from the suprasternal notch to the mastoid process. That is where the muscle is, and the clavicular head comes and runs somewhere just before the midpoint of the clavicle. That's how you look at it. You can use the maneuvers, which again Shiv described very nicely. You can actually ask the patient to lift the head up. When you lift the head up, you can see the sternocleidomastoid slightly better. If you're actually feeling the groove, so when you actually ask the patient to lift the head up, you feel for the border of the sternocleidomastoid, and then when you come down, you feel the anterior scalene muscle. Just roll your fingers down, and then you have the interscalene groove. At this stage, if you actually ask the patient to sniff and sniff very hard, you will be able to also see or feel the interscalene groove much better. And if you're not sure that you can see the external jugular vein, ask the patient to do a Valsalva maneuver and the vein will suddenly become stonking and you'll be able to see the vein. You always start with an initial setting of 1 milliamp. I mean, I would normally say 0.8 to 1. There's no point in doing anything more than that for such a superficial block. Okay. You probably put the currency at 2 hertz. That's what I do, and 1 millisecond. And we've actually described the reason why we do that. You maybe need to use around 20 mL of local anesthetic. Some people use around 25, some people use around 30. But we know that the complications increase the more volume which you start using. You basically use AAGBI monitoring techniques. You use a local anesthetic infiltration which is ready, and you do stop before you block. So this picture, which I've taken from originally Hazik's book on peripheral nerve blocks, you can actually see that this is where your suprasternal notches, this is where your mastoid processes, this is where your sternal head of sternocleidomastoid runs, this is where your clavicular head ends, and you can actually see the external jugular vein there. You feel for the scaleni process. He's gone in the interscalene groove, and with the direction of the needle probably towards the sternal notch. Again, this is the standard approach. The difference between this and the originally described Vinny's approach is Vinny used to say, find where the cricoid is, and then at the level of the cricoid, go in there. Whereas in the low approach, it says, find the interscalene groove and go around 3 to 4 centimeters above it. Now, the logic of this is that we do a lot of ultrasound, and we can actually see that as you go higher, you see the nerve branches of the brachial plexus, you see C5 and C6 are separate. But as you come lower, where you find the upper trunk, that's where you start seeing the C5 and C6 together. So the logic of going down or using the low approach is that you get these nerves more closer together, and your chances of getting them is much better. And if you inject the local anesthetic here, when we actually look at coming down even further, you see that the C7 is also there. So your local anesthetic will track from your C5, C6 down to your C7, and you'll probably get the lateral pectoral with enough volume of local anesthetic there. Your acceptable twitches are going to be your pectoral twitch there, deltoid, triceps, biceps, or any twitch on your arm or your forearm. Now, there's always adjustments to be done with the brachial plexus block here. Like you would always read that when they used to say, okay, if you get a trapezius twitch, you're posterior to the plexus. If you get a scapular twitch, you're posterior to the plexus. You direct your needle anteriorly. If you're getting a diaphragmatic twitch, you're too anterior, direct posteriorly. I mean, someone like me with my problems with dyslexia, I always get confused. What is this anterior and posterior? Does it mean I go up or I go down, or does it mean I go behind, I go ahead? And then what I used to do is I used to take a photograph of the brachial plexus, or in this case, what I've done is I've taken an ultrasound image of a brachial plexus and visualize it. Okay. So your needle, if you're looking at it, if you turn the neck and you go in this direction, right, this image needs to be tilted slightly, and your needle comes from here. Okay, so you're trying, when you're giving your brachial plexus block using a nerve stimulator, you're out of plane, it comes, your needle is going to come here. This is the C5, this is the C6, right? Now, we know that somewhere along this plane here, you get the phrenic nerve, you'll get your cervical plexus somewhere there. And in your middle scaleni, it is very important to realize that there are 2 nerves. Yeah, you have your dorsoscapular nerve there, and you have your long thoracic nerve there. Now, let's see what happens. So if you take your needle, okay, and if you either go in here or you either go in here, you will be causing a direct muscle stimulus, yeah, and you will cause the muscle to twitch. So that's why it says local twitch, withdraw, and reinsert. Now, trapezius. Now, this is very interesting because trapezius is actually innervated by the 11th cranial nerve, okay? And if you have done that, what it means is you've gone too behind, okay? You've gone too posterior. So you've got to direct your needle anteriorly. So it's slightly confusing because if you look at it, we're going to talk at this as anterior and this as posterior. But what you have done is you have gone behind the plexus. You've gone behind in the back part of the neck, right? Now, if you talk about getting a scapular twitch, Now, when we did ultrasound, when we do an in-plane approach, we have to be very careful about the muscle, the middle scalenus muscle, because there are two nerves there. One nerve is your long thoracic nerve. Long thoracic nerve supplies your serratus anterior. And if you get a serratus anterior twitch, you know you have gone posteriorly, which means you have gone here. So what you have to do is direct your needle more anteriorly. That's what it means. If you get a twitch of the scapula, now, you know the dorsoscapular nerve supplies your rhomboids, it supplies your levator scapulae, which again means that your needle has gone down, yeah, this way. So this is it, you have gone posteriorly. That's what it means. So you have to go anteriorly. Now, if you've got a diaphragmatic twitch, what it means is that your needle has gone somewhere here, okay, in this plane. It is going here anteriorly. That's why it is catching the phrenic nerve, and that's why you're getting a diaphragmatic twitch. So all it means at that point is you direct it slightly more posterior. So if your angle is this way, direct it more posteriorly, so you will get the brachial plexus. And of course, you get a bony contact. That means you've come down again, you've gone very posteriorly, and you've gone very deep, come out and direct it anteriorly. I hope this image makes more sense. So whenever you read and you find, oh, these are the adjustments to be made, it is very simple. Just put a diagram in front of you, any diagram. It doesn't have to be an ultrasound diagram. Even if you have the cross sections and diagrams which are described in the textbooks, you'll find that it's very useful. And what are the complications of the interscalene block? Well, you get Horner syndrome in a lot of patients. Vertebral artery injection, I don't think so. You should be doing that because you have gone very, very deep. Generally, if you look at the plexus, and if I show you this view, this is hardly at 1 to 1.5 centimeters. It's not deeper than that. In an obese patient, it'll be around 2.5 to 3 centimeters. You really don't need to go any deeper than that. If you are going very deep, well, then you've got too deep. You have to just come out. So phrenic nerve palsy, again, depending on the volume of the injection, you get it very easily. So you have to avoid doing this block in someone who has got reduced lung function. Estimate loss of around 25 to 30% of lung function or your inspired reserve volume if you actually give a phrenic nerve block. You may get the recurrent laryngeal nerve. Last is a complication which can occur with any local anesthetic, and if you are practicing regional anesthesia, you should know how to manage the last. Neuropraxia and nerve damage in brachial plexus block is slightly higher, but if you use appropriate precautions and if you use the nerve stimulator in the right way, then you can minimize the chance of this. Again, this is just to show, the cutaneous innervations. If you see anteriorly, this is the supraclavicular nerve, and this is the supraclavicular nerve posteriorly, which innervates the skin over the shoulder. So it's not very surprising that a lot of people use supraclavicular nerve block along with brachial plexus block to provide anesthesia for a shoulder block. I'm not going to describe this technique again because I think Akhilesh has described it very beautifully. The only thing is that it's not always necessary to do it. My practice, I rarely do it, but it's a very simple block to do, and it really doesn't take much. It's just a subcutaneous infiltration of local anesthetic along the posterior border of the sternocleidomastoid. The supraclavicular brachial plexus block. Now, this I am not sure is always as useful as an anesthetic, but with the ultrasound, we use a lot of our upper trunk block now. Supraclavicular brachial plexus block is slightly lower. This does not prevent phrenic nerve block, because if you're going to give as much volume and if it's going to track upwards, even with supraclavicular brachial plexus block, you would get phrenic nerve palsy. So I don't think so it's that good. Okay, it can be definitely used for analgesia. It will also cause the blockade of the entire arm. This technique is going to be described by Dr. Tivaskar in a next lecture, so I'm not going to go deep into it. And beware of complications. When you do a landmark guided supraclavicular brachial plexus block, there are some complications which you have to be very careful of. Now, then we go to what we call as phrenic sparing blocks. So what are phrenic sparing blocks? Well, you could give an infraclavicular brachial plexus block. Again, it can be used as an analgesic to supraclavicular block. It prevents phrenic nerve palsy if you give infraclavicular. It can cause pneumothorax, and there are other complications which can occur with that. But if you're going to give this will only take care of the posterior cord or the lateral cord nerves which you're looking after. You will need to do a separate suprascapular nerve block for this to be complete, and it's not a commonly used practice. So we'll come to the other blocks which are useful as an analgesic in shoulder surgery. If you're giving a GA, this can be used as an analgesic technique. And the most commonest nerve is the suprascapular nerve, which we give. And you can actually see how the suprascapular nerve passes through here, and then it supplies the supraspinatus muscle. It passes through the suprascapular notch to the spinoglenoid notch, and then it lies on the lateral supraspinous groove, and then it winds around the greater scapular notch, and it actually ends up innervating the infraspinatus muscle. So how do we give this block? This block is classically described by what we call as the Myers approach, where you actually feel the spine of the scapula. On the spine of the scapula, you go to the most medial part of the scapula. The lateral side, you go to the acromion there, and then you actually connect that line. You find where the midpoint of that line is. From there, go 2 centimeter up, and then go 2 centimeter medial. You direct your needle. Now, they say you have to be 45 degrees in the coronal plane, which means if you divide the body, from this body, it should be 45 degrees. And from this line, it should be an approximate 30 degrees. Basically, what you're trying to do is you're trying to, the scapular spine is this way, which goes that way. You have to actually direct your needle so you get into that point. Now, you actually might not be able to elicit the twitch. The typical twitch is the stimulation of your infraspinatus muscle, or you will get a painless, the patient will say, oh, I'm feeling a knocking in the shoulder. It's a painless knocking in the shoulder. If you get that, you're in the right place. Inject the local. If you don't get that, you can actually just walk. You will hit the spine of the scapula, just walk along the bony surface and just inject your 20 mL of local. There has never been studies, because you can look at various sites and the volume always is somewhere around 10 to 20 mL of local anesthetic. We really don't know what is an ideal volume in this condition. But when you give a suprascapular block, you have to actually also supplement it with an axillary nerve block. Axillary nerve supplies 2 muscles, deltoid and teres minor. It supplies the skin overlying the deltoid. Bone-wise, it supplies the humeral head and the posterior humeral neck. And you actually supplies the lateral and inferior part of the capsule and some part of the anterior capsule. There is considerable debate after the PENG's bridges came, whether the part of axillary nerve which we block by using this technique or using ultrasound is actually useful and is sufficient to block. Just, withdraw your needle and go up like that, because you might enter the capsule of the joint. You can inject on humeral surface below the deltoid. And if you actually keep on pushing and you don't get any bone, then you have probably entered the tricep muscle. So you have to withdraw and change your direction. Now, local infiltration analgesia is another something which you can use. It's phrenic blocking, but it is not pain blocking. Okay, there are multiple studies which have been done. There are studies which you will see in mostly surgical journals, which says that they've compared local infiltration analgesia, anesthetic, as in you give local anesthetic, and it is as good as interscalene block. It's absolutely nonsense. Those studies are retrospective studies, and most of those studies are single center studies. People have started injecting liposomal bupivacaine thinking there's going to be some benefit. Again, I don't think so. That is necessarily true. There are multiple studies which has rubbished it. This is an option which, if you have not given anything, at least give some local anesthetic to the patient. And remember chondrotoxicity. Local anesthetic is neurotoxic, it is myotoxic, and it's just severely chondrotoxic. And if you see some of the photos of chondrotoxicity, you will never want to inject local anesthetic in anywhere where there is connective tissue or articular tissue. Now, the PENG block is what we call as a pericapsular nerve block. It is an ultrasounded guide block, where you go between the deltoid and you go between the subscapular muscle. The only reason I'm showing this is basically, it just came to my mind when I was reading this, that we are doing so many blocks with the loss of resistance. This is a very simple block, which probably for analgesia is very, very simple to do. So going forward, is this a block where we can develop a loss of resistance technique? I know there are many stalwarts here in this group who may find that there is a method where we might be able to do this block sometime in the future with the loss of resistance technique. But that's the only reason I put in. But at this point, it is just purely an ultrasound guided block. With that, I finished my talk. And if there are any questions, please let me know. Thank you so much.
Thank you, Dheeraj. I think Again, a very nice, precise, to the point lecture, covering what is essential. And I think the basics, the foundation are very, very important. I think it's not just about, knowing what block to how to do a block, but it's also what block you need to do to cover what kind of surgeries. I think knowing the surgical anatomy is equally important, and what structures the surgeon is going to do that. Again, I think we talked more about, the orthoplasties, but also this is also, again, arthroscopies and things like that. You can. I don't think I saw any questions in there, but I think the coming to the PENG block, now the surgeons, and now this is again PENG block anywhere in any joint. A lot of surgeons used to do this injections into the joint, just without any even radiological thing, just by landmark they're described.
Yeah.
So it's not difficult to actually do these blocks just by landmark technique.
I think
yesterday,
I think this is actually, if you're not going to have kind of what I find very challenging is trauma cases, right? Where
Yeah.
you actually have a trauma and you sure your patient has got some kind of paresthesias. You're not sure whether you give a block. I mean, if you have got a patient who understands your explanation, you've said that I've checked the distribution of where your problem is.
Yeah.
I know you've got a little bit of neuropraxia there. It is pre-existing now. I'll give you a local anesthetic. It's not going to cause any worsening. But that actually tends to make people very nervous about people having some kind of paresthesias or neuropraxias even before we start a block. When you can't do anything, a block like this is absolutely wonderful because you give good pain on postoperative analgesia. It cannot be used. And it's very important to understand with the shoulder. I mean, my personal experience is, apart from interscalene block, you cannot do anesthesia. You can't have an anesthetic, a sole anesthetic, with any of the other techniques which I described. Okay, if you're lucky you can try with the supraclavicular, or with the ultrasound, we use upper trunk. So that can be done and you will get a good analgesia. But apart from that, shoulder is such a thing that, a good interscalene block, an easy interscalene block provides absolutely fantastic anesthesia and analgesia. But these are all analgesics block, because the most challenging thing when people come to me is that they say, oh, this patient is actually very, very high risk for a general anesthetic. And these are the respiratory cripples. And when you say that they are high risk for general anesthetic, they become high risk for giving an interscalene block, because you might actually block their shoulders, or block their diaphragm. But I think now with lower volumes and, being a little more careful, I think but not getting a phrenic is very challenging. I find still it is like, it's very variable. I can't absolutely certainly say, but it's a risk benefit thing in that scenario, I think. And we go ahead with that.
Yeah. I think that's a fair point. I think the phrenic sparing block probably are more for analgesia, post-op analgesia, combined with your GA. So just more of a GA, RA, and multimodal analgesia technique. Multimodal should anyway be used, whether using pure regional or pure GA or combined technique. Yes, I think interscalene is probably, we have a big orthopedic center, and we do one of the highest numbers of shoulder procedures in our thing. And Liverpool used to be the only center used to give MCH in orthopedics. And you won't believe that when this is when I joined as a consultant here, the only blocks which are mostly done were interscalene blocks. And that's what people were actually very confident with. And that time it was PNS. I mean, ultrasound only started coming in. I introduced ultrasound in 2006. So before that, it was all PNS guided, and people were doing it really well. And you would have seen all kind of complications possible during that time. Phrenic nerve, I think overstated. It will happen, but in most patients, it doesn't cause much problem. I think patient tolerate it quite well. Phrenic nerve is actually pretty resistant to a block. It might get blocked, but it doesn't last that long. So worst come worst, you need to supplement oxygen and not do it. I don't know whether it is exactly a contraindication to giving interscalene for respiratory cripples. We do it under GA. I do a lot of these cases of GA with blocks. I have not seen any problem. What's your opinion in that? Would you, if you like you were just mentioning that they send you a patient to say, oh, this is a high risk for GA. Would you be going for a phrenic sparing block, or they say, no, it's fine. I will just give a
No. So my practice is I actually talk to the patient. I tell the patient that this is the thing. And I said that GA is going to be equally dangerous or very dangerous for you. That's the reason you've been sent to me. I keep an NIV ready in recovery sometimes, or a CPAP if they develop breathing problem. And I see it's just getting used to that initial part where they have lost that sensation. Yeah, it's more, I feel, a subjective feeling which they have with, and the reason we're talking about respiratory cripples is in normal patient, even if the phrenic is blocked, they'll take a little bit of deep breaths and say, oh, I can't take deep breaths or something of that sort, and everything is sorted. But for those respiratory patients, I mean, we've taken the consent of the patient. We say that I know this is going to happen. We're going to give you, if required, an IV, or I say we can give you a GA. This is the risks, and I can give you sparing blocks. And I ultimately advise the patient that probably, interscalene, because I use ultrasound, I use lower volume, the chance of getting phrenic is smaller, and this is what I would recommend. But if you are not happy to accept that risk, then I can give you a GA again, in which case I have to book an HDU bed if you're not very well, and then you have to put you in HDU or ITU post-op. So I personally think, there's a lot of noise made by this in some of the international forums, and I find it's not really justified saying that, oh, Nysora says if you have got a respiratory cripple, don't do this. It's absolute nonsense, according to me. I think I've done many blocks where I do them awake, and thankfully, as long as I've taken precaution, I've spoken to the patient, I've taken their consent, that's the most important thing.
I think there was one question. I think this is related to, I don't know whether related to shoulder surgery, but saying while performing infraclavicular block, is it compulsory to combine it with supraclavicular block for upper limb surgery? I think what you meant is the superficial supraclavicular nerves, not a supraclavicular block, but a supraclavicular nerve blocks. I think yes, 100%. Even with when you are giving the phrenic nerve sparing block, axillary and the suprascapular nerve, I think it's important to give a supraclavicular nerve blocks, which is a superficial cervical plexus block, basically. To cover the port side. But again, if you are not comfortable giving that block, you can always ask the surgeon to do local infiltration for incision. It's just for incision. It's not for analgesia. So infiltration at the port site, if they're doing arthroscopic, or incision site, if they're doing a arthroplasty, that is possible. Next question is what is the volume we should stick to in interscalene and supraclavicular block to prevent phrenic nerve block? Is there a definitive guideline, Dheeraj?
No definitive guideline.
Absolutely not.
And especially with the line, with the ultrasound, I think even what people don't realize is with the ultrasound, there is a variable in the amount of volume which people actually inject. So if you look at it, there are studies which have shown that if you use between 2.5 to 6 mL, it's sufficient. But I have not seen anyone use that volume and do an awake shoulder. All these people who are talking about this is for analgesia and just post-op analgesia, and the amount of time you have under a GA for that local anesthetic to have chai and have some biscuit and then creep into the nerve and act for post-op analgesia is different. I have not seen. If I actually have to do an awake shoulder even now, even under the ultrasound, I find that I have to use at least 10 to 15 mL of local anesthetic, and then the patient gets a block right away. Otherwise, I have to wait quite a long time, and my managers as well as my surgeons are not going to forgive me for doing that unless we have a block room. So 20 to 30 ml is what is recommended in the literature for nerve stimulus if you're using it. And I think using more than 30 ml is absolutely pointless. That means you're not in the right place. So I think 20 to 30 ml would be what I think, Shiv. I really don't know, because it's been a long time since I've done just a peripheral nerve stimulator. I mean, I think there are other faculty in this group who actually do it more regularly than us with nerve stimulators. And I don't think so. Like I can see Shilpa shaking her head. I don't know whether she uses.
No,
more
no,
than
sorry.
30.
It was my monitor just slipping
Okay.
off. No, I will likely come to that because I was going to actually mention that. This actually is one of my colleagues who does upper limb list and other thing. He came to me and asked me. He says that this guy is from, I think, Russia or Georgia, somewhere that side, and he said, I have done thousands of these blocks with landmark technique and never failed, did all kind of surgeries. But since the time I have started using ultrasound, I'm having more failures. And as we described, we actually tend to use anywhere from 10 to 20 mLs of local anesthetic, and that's what he was using. And he said, when I was doing a landmark technique, I was using 40 mLs of local anesthetic, 0.25%, instead of using 0.374, 0.5. I told him, I said, if you are comfortable using larger volume, go ahead. That's not a problem. We will see what happens. And since then, he's come back and he says that since the time I have used larger volumes, I am actually getting a better results. I don't exactly know what it is, but I think it also depends on what you are, the understanding of our, especially the supraclavicular anatomy, the supraclavicular region anatomy is changing. I've got some micro dissection, which I will probably show you during the tea time, which actually shows that you can't rely on just injection and looking at corner pocket and injection around. People who used to go and poke, we used to say, oh, you are dangerous. Probably you're saying, no, you were right. Okay, the concepts are actually changing. And with larger volume, we probably actually tend to have a better distribution of local anesthetic. But interscaling, I don't know you. Do you need larger volume? Probably not. I think I don't go anywhere more than 20 mLs ever for interscaling, whether it was a nerve stimulation technique or it was a thing, I would probably not go more than 20 mLs there. It's not necessary, I think. Supraclavicular, I can understand that.
Should we go to Shilpa, because we'll get a
Yeah.
little more understanding of
Yeah,
infraclavicular?
exactly. She's going to actually, talk about more about that. So we move to the next lecture, which is on the elbow block. So we would be actually moving down to the supraclavicular, infraclavicular, and other areas. So over to Shilpa for the next lecture. Shilpa, you okay to share?
Yeah.
Yes. Yeah, thank you.
Yeah, good afternoon, everybody. Thank you so much, Shiv sir, for this opportunity, and Dr. Kali sir and team Rads. Hope I live up to the expectations of audience and everyone. Today, I am Dr. Shilpa Tivaskar. I work as a consultant at Bhaktivedanta Hospital, Mira Road. Today, we are going to discuss blocks for elbow surgery. Dr. Dheeraj has very beautifully covered most of it. I had a female patient with a left elbow fracture. She was a diabetic with CKD and compromised cardiac function. So I explained her and relative that the regional would be best option for her, and I would go for a regional block. I went for a left subclavian perivascular brachial block. The pain decreased, she allowed scrubbing, she allowed position. But the moment surgeon took incision, I found her complaining of pain. So I gave some local anesthetic to the surgeon to infiltrate at the skin. We waited actually 10 more minutes, but still she had pain. And instead of doing any jugglery in her, I went for general anesthesia. So whatever explanation I had given to the relative and her about choosing regional went for a toss. So what went wrong? Did I miss a segment? Or should I have supplemented with axillary brachial plexus block or added a muscular cutaneous nerve block? So today I'm going to talk about what exactly is blocking the elbow. To block any region, we have to know the nerve supply to that region. So the nerves which supply the elbow, let's go from number 1, the radial nerve, which comes from behind, supplies the elbow. Then you have the muscular cutaneous nerve. Then here we have the medial nerve, which is crossing the elbow. The ulnar nerve, you see, it's still behind. Then you have the posterior cutaneous nerve of forearm. And of course, you have here one more nerve. Sorry, this is the medial cutaneous nerve of forearm. And here is the posterior cutaneous nerve of forearm. There's one more busy slide. Now, regarding this slide, I would like you all to know that suppose we are blocking the forearm. Divide the forearm compartment into a medial compartment, a lateral compartment, and a posterior compartment, right? So medial compartment, if you see, you have the intercostobrachial, which is the T2 nerve, and you have the medial cutaneous nerve of arm and medial cutaneous nerve of forearm, which are directly coming from the brachial plexus cords. If you go to the lateral compartment, okay, lateral compartment, the upper part we are not concerned, which is supplied by axillary, but as we come to the near the forearm, you will find that radius, which gives the radial nerve, which gives the inferior lateral cutaneous nerve of arm, which we are concerned. And if you go further down, then the lateral part is supplied, the lateral forearm is supplied by the musculocutaneous nerve. So here we have medial compartment directly from the cords. The lateral compartment we have from the radial and the musculocutaneous. What about the posterior compartment? The posterior compartment, both the nerves, the posterior arm, cutaneous nerve of the arm and posterior cutaneous nerve of the forearm, both are from the radial. So we have radial, musculocutaneous, and the cords. Now this figure, which is a common figure which I have put up here, so that as Dheeraj sir said, what exactly we need to block for the shoulder, for the elbow, these are the trunks from the brachial plexus. So we can block the trunks which supply the elbow, or once they divide, we have the cords. What is important to see is we saw in the previous figure that we have the medial cutaneous nerve of arm and medial cutaneous nerve of forearm, which we have to block. If you see, then at the level of the cords, this nerve already separate from the brachial plexus. So it is important that if you have to block the elbow, you have to at least give nerve block till the cords. Also, if you see the musculocutaneous nerve, which comes from the lateral cord, it is also going little away from the main chunk of the brachial plexus. Hence, if you want to block the elbow, we are clear that we either block at the trunks or we block at the cords. So blocks to be given for elbow surgery. It is supraclavicular block at the trunks or the infraclavicular block at the cords. Thus now, as we saw, the axillary block, if you try to give, then the musculocutaneous already moves out, the medial cutaneous nerve of arm and forearm already move out, and of course, there will be tourniquet pain because of the intercostobrachial nerve, which is already out. So we cannot give axillary. Now this slide is why we have not to give interscalene block for elbow surgeries. We see MS, that is the middle scalene, the anterior scalene, and we give block somewhere here, the interscalene block. But suppose we give the interscalene block, then the lower trunks C8, T1 usually get spared. Hence, we are not supposed to give the interscalene block, is not the block of choice for elbow surgeries. Saying this, we have to keep all the block basics ready with us. And now we directly go on to the supraclavicular block. We have discussed at length how to identify the lateral border of the sternocleidomastoid, head turned to the another side. The elbow should be in the flex position preferably. Some people, though it is uncomfortable, sometimes in obese, the supraclavicular fossa is deep. You may keep something below the shoulder. Now palpate the lateral border of the sternocleidomastoid. You can also see an EJV crossing it. Go 1 inch or 2.5 centimeter lateral to the sternocleidomastoid. Then you hold the needle perpendicular to the skin and go at least 2 to 5 millimeter deep till you pass the skin and subcutaneous tissue. And then you have to make the needle parallel to the midline. Remember, do not insert the needle more than 2.5 centimeters, even if you don't get the twitch of brachial plexus. What should be your PNS settings? PNS settings, it should be at least 1 milliampere. Once you are searching the plexus, then you can slowly reduce it to 0.5 milliamperes. We reduce it further to 0.3 or 0.2 just to check that we are not intraneural. What is the response? The response is muscle twitching of the fingers. Now, troubleshooting. Suppose we have gone too lateral, then as we have seen, there is a steep downward direction of the plexus. Hence, do not go very lateral. If the twitches disappear, you have to do angle insertion anterior-posterior. Like Dr. Dheeraj said, this anterior-posterior is confusing. So if you're putting the needle, just go a little above or below, then if you're not getting the plexus. Now, this is a slide where you get supraclavicular block with the help where it is perivascular, where you first palpate the subclavian artery and move little away from the subclavian artery, 1 centimeter above the midpoint of clavicle, and you inject there. You can walk on the rib while you are injecting. This is one more technique which, as Sir said, Dheeraj Sir said, that you would like to give interscalene block at a lower level. So there, some nerves of shoulder could be spared, as Sir has said, and hence we can give supraclavicular block somewhere. Here, what mistake usually can happen is, do not check the sternocleidoid and the anterior scalene groove. You have to go behind that, the groove between the anterior scalene and the middle scalene. This is a plumb bob technique. This was described way back in 1997, where you have to just drop a needle. They say you have to drop a needle at the level of just outside the lateral border of the clavicle, where the subclavian artery is, and then find the plexus. Complications, all which are common with the block, especially with the supraclavicular block, you can have pneumothorax, you can still have phrenic nerve palsy, though we have not seen that. The drugs which can be used, it can be ropivacaine 0.375%, it can be bupivacaine 0.25 or 0.5%. Normally, I use 20 to 25 cc's of local anesthetic with dexamethasone 4 milligram and clonidine 60 microgram. Sometimes I use a combination of bupivacaine and lignocaine if I do not want to prolong the action. Now coming to the infraclavicular block. This block is difficult to master, but once you master it, you will like it so much. There is no injury to pleura. There is no phrenic nerve involvement, of course, unless you are going too medially. There is no need of special arm position. Tourniquet is well tolerated, and coracoid and clavicle is palpable even in the obese patients, and it is easy and safe for a continuous catheter. Now, to palpate the coracoid process, usually you ask the patient to lift the arm and you check below the clavicle. Medially, you put your fingers, and as the arm is brought down, the first bony prominence that you feel is the coracoid process. The other bony landmarks which are there is the sternal notch, the acromion process, then you have the humeral head which is there lateral. Now, infraclavicular block can be given by 3 approaches. The one first, which is more easy to learn, is the coracoid approach, where you check at the lateral tip of coracoid, go 2 centimeter medial and 2 centimeter below, that is caudal, and that is your point of entry. If I have to show on a volunteer, then you have in the first figure, left side, you have the coracoid process. I am going down. Then I am checking the deltopectoral groove towards the axillary artery, and there I can, in that direction, I am putting the needle and injecting the drug after I get the response. The second approach is infraclavicular block with a vertical approach. Here you have the landmarks. First is middle landmark, that is the middle of the jugular notch. Then you have the anterior part of the acromion process. You join them, and just below the midpoint, here you have to give the block. You have not to be near the coracoid process nor the humerus. So where the line connecting this tissue is your injection site. Now, if I have to show it on the specimen, then it would be somewhere here, where you can see the subclavian vessels here, and here you can see the cords which have clustered. So this is how I give the block, with the vertically down, immediately below the line joining diacromion and the sternal notch, with a smaller needle if possible, so that you don't go deeper. There is one more technique, it's the Raj technique. The patient is again in supine position with head turned. And if you see first in the figure below, you have to draw a line between the subclavian artery and the axillary artery. And on this line, go 3 centimeters below the midpoint of clavicle. And there you will likely to find the brachial plexus at an angle of 45 degrees. This slide, as given by Shiv sir, it's a Raj approach original article. Now, the main thing in infraclavicular block is getting the response and interpreting it. The branches are, now if I have to check the lateral cord, then the branches, lateral half of the median nerve, the musculocutaneous and the pectoral nerve. Now, which response should I accept? For the medial nerve, there is flexion of fingers and opposition of the thumb. But the opposition of the thumb is not checked because even ulnar nerve, which supplies the lumbricus and adductor pollicis, can cause opposition. Hence, we look at the flexion of the fingers. Then regarding the flexion of the elbow, suppose I get a response of flexion of the elbow. The musculocutaneous supplies the biceps. It can cause flexion of the elbow. But if you remember the diagram, musculocutaneous, after the cords, it leaves the cords away. So suppose you take the musculocutaneous response and inject the drug, it is likely that the nerve may have left the cords away and hence your block may not fully act. At this juncture, the flexion of the elbow could be also because of pronator teres, which is supplied by the median nerve. But we are confused whether that flexion is because of pronator teres or biceps. And hence, we do not check that response of flexion of the elbow. We just take fingers. So we have eliminated ulnar, we have eliminated musculocutaneous, and we just take the response of finger flexions. Now, this is regarding the posterior cord. The axillary, as we have seen that it has separated higher up. Now, the thoracodorsal, upper and lower subscapular nerves, they are supplying their areas. Coming to the radial response. Now, the radial response is abduction of the thumb and extension of the wrist and fingers. Again, the radial nerve also supplies. Brachioradialis is a muscle which has dual supply from musculocutaneous as well as radial. So, in radial response, you may get again flexion of the elbow because of brachioradialis, which is supplied by radial as well as musculocutaneous. But are we going to accept the musculocutaneous response? No, because musculocutaneous may have separated from the cords. Hence, if elbow flexion is associated with radial deviation, then only we accept it. The crux of the story is either flexion or extension of the fingers and not the elbow flexion. The medial cord, the ulnar nerve and the median nerve, of course, they cause again the flexion of the fingers and the opposition of the thumb. So the pulse of infraclavicular block is at the level of the cords. The three cords surround the axillary artery. The lateral cord is superficial, posterior is next, and the medial cord is deepest. Remember that the musculocutaneous nerve is often outside, though it could be close to the lateral cord. So to summarize, supraclavicular block, though Dr. Dheeraj sir may not agree for shoulder, but for the other parts, it is the spinal of the upper limb, where we have all the crowding of the trunks which are present. Try it with proper landmarks. It's not just you feel the artery and go lateral to it, but it should be the sternocleidomastoid, lateral to it, and direction should be up or below. and not medial or lateral direction of the needle. The infraclavicular block has fixed identifiable landmarks, and hence, though it has a longer learning curve, of course, it is painful also, it is deep block, and hence, but it is more, if you get the response, then action is definite. And the newer block on the horizon is costoclavicular approach to brachial plexus, which is the new block. Thank you. Thank you very much. Yeah.
Thank you, Shilpa. I think very well elaborated the blocks for the elbow. I think the case presentation, you actually had a case. I think that's a very good indication that elbow is densely innervated, and you need to have a very good block for elbow surgery. I've had in the last few weeks, I've had quite a few elbow surgeries, including very elderly patients for total elbow replacement. And one was just last week was a 82 years old patient. This was post-trauma, and she needed ending up with a total elbow replacement. And then one I had just day before yesterday, another total elbow replacements in a rheumatoid arthritis patient. A supraclavicular block works really, really well. But again, I think for the elbow, what I have realized is that it's very important to give a higher concentration. So for elbows, I've actually moved from 0.375, which I normally use, to 0.5%, around 20 mLs, 15, 20 mLs supraclavicular. Rather in the elderly patient, I did an infraclavicular, and we do ultrasound guided, but I've done hundreds of the VIBs, but that was one of my favorite blocks. I wouldn't actually with PNS do supraclavicular, so it was interscalene and infraclavicular. And it's not a coracoid, it's actually called subcoracoid approach because you go below the coracoid. You're not going at the coracoid, as a coracoid is your landmark. And because you're going below the coracoid, and that's a subcoracoid. So VIB is a very superficial block, actually. Amazingly, you don't need to actually use more than 4 centimeter needles. Whereas for the subcoracoid approach, you need to have a longer needle. In some of the well-built patients, muscular patients, you might actually even need to actually go up to 80 centimeter needle. But in most patients, you would actually require probably 5 centimeter needles they require. And again, the response for the cords, we don't usually talk in terms of the nerves, though we know that they follow the nerves, follow the cords, like posterior and radial. But one of the ways they have been described is that how do you know which cord you are stimulating? Is to look at your little finger response. So it is a hand response, no doubt what you have said. It is. So if your finger moves towards your medial part of the body, little finger moves medial, that is your medial cord. It moves posteriorly, the radial response, that is your posterior cord. If it moves laterally, and then you know there's a lateral cord. So it's called Guru in one of the our Nbfm, Sarva Nagpur was talking. He says, look at the pinky. The pinky, isn't it? So it is like looking at the little finger. You can see where the little finger moves. If it moves towards the body, medially medial cord, laterally lateral cord, posteriorly posterior cord, because that's all you're looking at. And here, obviously, in the infraclavicular, you are with subcoracoid, you are going to look for a posterior cord. And again, these ones depend on the volume. So you need to use at least 20 to 30 mLs of local anesthetic. Otherwise, you're not going to get a circumferential spread of the local anesthetic, so volume block. With ultrasound, it's totally a different thing. But with, I think, PNS, volume is very, very important. And it's a great block. I mean, I think VIB can be very easily mastered. People are unnecessarily scared because you don't go medially at all. Even if you actually go through and through, you will end up hitting the scapula on the other side.
Yeah.
You don't actually go into the lungs. You cannot go into the lungs because it is nowhere near the lungs. Okay, fine. You can do a vascular puncture, but even if you go deep all the way, you take a 100 millimeter needle and poke through it. All you do is you go through and through, and you hit the back of the scapula. That's it. So pretty safe. Anybody else wants to add or wants any comment? I don't see any.
I think
question.
so. I think we used to have this 25 millimeter needles, especially for VIVs. I think they've gone now. People were
that
so.
was
You remember
Dheeraj,
those
those
needles?
were for the interscaling.
Oh, is it? They were for
Yeah,
the
yeah.
interscalene. Yeah. So
Oh,
they
for
say that
interscaling,
never go more
2.5
than
centimeters.
2.5. Yeah.
Yeah,
And it's very interesting. So
They're
Shilpa,
disappearing.
the question or the comment which I wanted to make was, is there a safe area to avoid? So if you're giving like a supraclavicular approach to make sure that you don't go into the pleura, is there a safe distance or a safe approach? Do you know?
No, I
Yeah,
think
like,
it's the technique you use that is more important.
and
Yeah.
they have said that if you roughly say the clavicle, the middle third, and the lateral third, so avoid the middle third and the lateral third, you won't get response. So basically, it is the center of the clavicle. If you
Yeah.
avoid going medially towards the sternocleidomastoid, directing the needle, then maybe you can avoid the pleura.
Yeah, so the other thing which they actually, roughly they say is that if you actually look at what your the distance of your clavicular and your sternal head of the sternocleidomastoid, if you actually take that distance and put it next to it, and if you go lateral to that, there is no way you're gonna, because the dome of the pleura already ends there. So that is one of the ways they say that you can actually, if you don't know how to use the distance, if you can see the clavicular head, just go from the suprasternal notch to the clavicular head and have that distance. And the other thing is your subclavian artery, isn't it? If they say that if you actually palpate your subclavian artery and go lateral to it, and with your direction being slightly lateral, you're probably safe. And as Shiv said, you might go through tissues and tissues, but very rarely hit the lung. This is interesting about you. You showed about the Raj technique. Initially, when Raj actually described this technique, there were many Westerners saying that, oh, there is no point of doing this technique. Because Raj mentioned that he uses this technique, but he found it much safer, and he found that his incidence of pneumothorax was much less. But then there were a couple of other people say, oh no, what he's talking is rubbish, you're never going to get that. But then later on, people started actually accepting Raj technique as a better technique for in clavicular blocks, because it was supposed to be associated with very fewer incidents of pneumothorax. So, and your diagram very nicely portrayed that, where you actually see where your chest wall ends, and that part lateral has got just tissues, nothing else. It's just muscle and tissues. It's got no pleura and no lung below that.
Actually, the Raj technique was described as a landmark technique for infraclavicular. So people were actually doing it as infraclavicular. It is basically following the deltopectoral groove, putting local anesthetic into that. So it was described more as initially as a landmark technique, but later on. But another thing which I think Shilpa missed out in that is the just like what you have VIB for below the clavicle, infraclavicular, there is VIB for supraclavicular area. It's called a plumb-bob technique. And that again is pretty safe. It has been well described anyone in the Miller's textbook. So plumb-bob technique is that. I think the chances where people tend to make a mistake is that you don't need to point the needle, even if you're doing the paresthesia technique. You don't need to point the needle towards the lung. Now, if you look at your clavicle, clavicle is the one which is actually protecting you from going towards the lungs, and you direct it actually more laterally, and you can walk on the clavicle. You can hit the clavicle, then you are not going to puncture the pleura. I think probably I will tell you what, people probably do more pneumothorax with ultrasound than with landmark technique, because it is so close. The way the needle is going from lateral to medial, they are going towards the lungs. People probably are not publishing their data, but I have seen people. We have had patients who ended up with pneumothorax. And because we don't have intensive care orthopedic center, patient been transferred to the main hospital because of pneumothorax. So we need to be careful with ultrasound, equally careful with ultrasound. Ultrasound might actually tell you, okay, you can use lesser volume, but it doesn't tell you that, or it doesn't prevent you having a complication. So people don't have to feel inferior that they don't have ultrasound, and neither should people who use use ultrasound for supraclavicular feel any superior about it.
So there is one more approach, something called as a retroclavicular.
I wouldn't even go near that.
Okay.
It is all published, having a name, having publishing thing. What is retroclavicular? It's infraclavicular block. It's a VIB block. Under ultrasound is retroclavicular block.
Okay.
Yeah, it's just giving different names, putting the names to the blocks. Okay, and for any regional anesthesia enthusiast, especially younger ones, you just need to master few blocks. And if you know how to do interscalene, right? You know how with landmark technique, if you do a supraclavicular, you can do most surgeries. Okay, like I said, if you do supraclavicular, know how to do a supraclavicular landmark and do a, also surgeon to infiltrate the incision site or the port site and give, you can do most of the surgery on the arm. And infraclavicular is a fantastic block to master if you're using PNS, right? So people are still afraid to actually use PNS for supraclavicular for the same reason that it might actually cause pneumothorax. But if you follow the right technique, that's again very, very less. So master interscalene, master infraclavicular, and the elbow blocks, which next talk will be about. and you're fine with rest of things. Yeah, yesterday again we had this is day for yesterday. I had a trainee, and he said, "Oh, I'm on a hand list tomorrow. That is on Friday. This is on Thursday." And he said, "I've never done any blocks on the thing." And I just showed him that it's so much easier to actually block the individual nerves. So you learn that they become your rescue blocks if you miss out. So they'll become rescue blocks for you. Upper limb is actually very easy to master. Yeah, the blocks. Any more questions? Samir Deshpande, I do supraclavicular and getting only biceps, that is muscular. How do I maneuver my needle? That's one question. And says, other one is, what can be done if you didn't get any twitches while performing block with PNS, provided your technique is perfect? How can you see your technique is perfect? You're not getting any response. Shilpa, you want to answer the first one?
Yeah, the first one, what Dr. Samir has asked.
Yeah.
If you get the musculocutaneous, you have to withdraw the needle and redirect it more caudally. Means this is the plane, you have to redirect it more caudally if you get the musculocutaneous now. And regarding the second question, if you're not getting the block, check your landmarks again. You might be more medial, or you could be more superficial above the upper trunk.
I think with supraclavicular, musculocutaneous response is actually accepted. It is supraclavicular, isn't it? So you are still either at the formation of the trunk, you're not actually below. Infraclavicular, if you're saying that you're getting musculocutaneous, I would actually say no. But if you're supraclavicular and you're getting a bicep response, it is acceptable. I'll just need to probably use larger volume, and you'll be fine. I don't think you will get a failure if you get a musculocutaneous response with supraclavicular region. And if you're not getting any response, two things. One is that you check your nerve stimulator is, like we discussed in the basic, that you have actually connected, it is working properly. And second thing is maybe your landmark. You might have to actually come out and just redo your landmark and see that. You may not be in the right place. Because with the supraclavicular area or interscalene area, if you're in the right place, you will get a response. And Again,
So,
whether
Shiv,
patient is asleep or awake, you don't have to actually go above 1.5 milliamps for for taking your response. Awake patient, you can use 1 milliamp, and for patient asleep, 1.5 milliamp. I've never used more than 1.5 milliamp to start off even with the deeper blocks. So check both.
I think the only thing about the musculocutaneous shift, which is very interesting, is actually the point where you do the thing. Because with the ultrasound, where we see is that actually, if you go for supraclavicular and if you've gone up to the clavicle, the musculocutaneous is already gone under the belly of the overhead. It's already in a. No, sorry, I'm getting confused. Sorry, no, you're right. You're right.
Suprascapular.
Yeah. So the musculocutaneous,
No,
you should be able to
It
get.
should be there. Yeah, yeah.
You should be there. You should accept that. That's right.
It is suprascapular you are actually talking about where it is
It's my
gone under.
confusion.
So musculocutaneous is accepted. Bicep response for supraclavicular is accepted
Yeah,
as well. I think that with that, I think we done till the elbow. Let's move a little lower down. And Sanjot will be talking about blocks. These are also elbow blocks, good blocks for, like she will explain to you why these are wonderful blocks to learn. Over to you, Sanjot. Yeah. Slideshow.
So, hello everyone. I'm Sanjot Abhade and practicing since 30 years as a freelancer in Dombivli. And thank you, the organizing committee and Shiv sir, for giving me this opportunity to speak on the distal forearm surgeries. So for the surgical anesthesia, we need to anesthetize not only the skin, but also the muscles, ligaments, connective tissue, and the bone. This is the most popular figure. And when we look at this figure, the most popular mnemonic that comes to our mind is Randy Travis drinks cold beer. And I am left with the most interesting part of this mnemonic, and that is where the B stands for the terminal branches. However simple and schematic this diagram may look, there is tremendous individual variation due to the anastomosis between the adjacent peripheral nerves, the overlapping terminal branches, and the variation in the terminal branching anatomy. And this is more so over the elbow and the wrist. Now there are 7 terminal nerves of the axillary brachial plexus which innervates the upper extremity, out of which the first one is the axillary nerve, which innervates the shoulder joint, which has already been discussed. We have the musculocutaneous nerve, the radial nerve, the ulnar nerve, and the median nerve. And the most often missed nerve is the medial antebrachial cutaneous nerve, which is the intermediate branch of the medial cord. We also have the medial brachial cutaneous nerve, which is the 7th terminal branch of the brachial plexus. And we also have the intercostal brachial nerve, which is the anterocutaneous branch of the T2 spinal nerves. Now, these 2 nerves are of importance since they supply the medial aspect of the upper arm, extending from the medial aspect of the upper arm till the elbow. So any surgery which is occurring in the forearm and requires an extension of incision to the medial aspect, we need to consider the blocking of these 2 nerves. So for example, like the transposition of the ulnar nerve or decompression of the ulnar nerve. Now coming to the just proximal to the elbow, the musculocutaneous has motor innervation to the biceps, the coracobrachialis and the brachialis muscle, which leads to the flexion of the elbow. The radial nerve has the innervation to the tricep muscle, which is responsible for the extension of the elbow. We also have the cutaneous branch of the radial nerve called as the posterior antebrachial cutaneous nerve, which supplies the posterior aspect of the upper arm. The median and the ulnar nerve do not have any cutaneous branch in the upper arm, but they do innervate the articular branch of the elbow joint. The musculocutaneous nerve extends beyond the elbow, and it is called as the lateral antebrachial cutaneous nerve, which supplies the volar aspect of the forearm from the elbow to the wrist and even to the base of the thumb. It emerges from the brachialis fascia and lies very near to the cephalic vein, which is an important landmark. The counterpart of the lateral antebrachial cutaneous nerve is the medial antebrachial cutaneous nerve, which supplies the volar aspect of the forearm from the elbow to the wrist. The radial nerve, just before entering the elbow joint, gives another cutaneous branch called as the posterior antebrachial cutaneous nerve, which supplies the complete posterior aspect of the forearm as seen in this figure. The radial nerve also gives it divides into two parts: the superficial radial nerve and the deep nerve branch. The superficial radial nerve lies deep to the brachioradialis muscle and suddenly becomes superficial in the anatomical snuff box, and it innervates the dorsal aspect of the hand as seen in this figure, right from the thumb to the lateral aspect of the fourth digit. The deep branch is also called as a posterior interosseous nerve, which supplies the major extensors of the hand. The median nerve does not have any cutaneous branch in the forearm, and it lies sandwiched between the flexor digitorum superficialis and the profundus muscle, and it has a cutaneous branch beyond the ulnar nerve called as the cutaneous branch, palmar cutaneous branch of the median nerve, and supplies from the palmar aspect of the thumb to the lateral aspect of the fourth digit. It has a branch called as the anterior interosseous branch, which supplies the major flexors of the hand and the finger, and also gives innervation to the thinner and the first two lumbrical muscles. The ulnar nerve does not have any cutaneous branch in the forearm, but it has two cutaneous branches: the palmar cutaneous branch, also called as the nerve of Henle, and the dorsal cutaneous branch of ulna, which supplies the medial aspect of the little finger and the lateral medial aspect of the fourth digit, that is the palmar cutaneous nerve, and the dorsal supplies the dorsal surface of the little finger and the medial aspect of the fourth finger. The ulnar nerve, however, gives motor innervation to the flexor carpi ulnaris and the medial belly of the flexor digitorum profundus. Now, what does all this mean when we are performing the distal forearm surgery blocks? It means being just clear to know what are the cutaneous areas and the musculoskeletal areas that need to be covered when we are considering the blocks. The distal forearm surgery nerve block approaches are the proximal blocks and the distal blocks. In the proximal blocks, we have the supraclavicular and the infraclavicular, which has been covered by Dr. Shilpa, and we have the axillary blocks. The axillary blocks are, however, more denser, causes more sensory and motor impairment, requires a larger volume to be given, and a proper care has to be taken of the patient. They might require a sling, and patient should be told about the care of against the temperature and pressure. The distal blocks are the mid-humeral or the humeral canal block. Then we have the lateral and the medial antebrachial cutaneous nerve of the forearm and selective nerve blocks at the elbow. The distal blocks are also called as the rescue block, and they come into the picture when the proximal blocks are incomplete. Only we have to be very careful when giving the rescue blocks, because the patient is unable to complain about the paresthesia and the pain while giving the local injection. Coming to the axillary block, this is the most distal block of the plexus. It is one of the commonest, simple to perform yet very complex, easy landmarks, provides anesthesia to the distal upper limb, no effect on the phrenic nerve, and no risk of pneumothorax or chylothorax. So can be done even in the patient with respiratory diseases. Easy landmarks, we have the axillary fossa, the brachial artery, the coracobrachialis muscle, the triceps muscle, and the pectoralis major muscle. So these are easy landmarks. But we say yet it is very complex. I would like to refer to this slide where the usual positions of the median, ulnar, and the radial nerve and their variation as shown. It is a circular area around the axillary artery divided into 8 quadrants. The median nerve in the quadrant would be in 1 and 8 in 56% of the times, and ulnar nerve would be in the area 2, as they have shown the percentages here. But for the simplicity, I would like to say 2 M's above the axillary artery and you are below. So if we consider this as a clock, then from the 12 o'clock to the 3 o'clock, the median nerve would lie anywhere in between that. And from the 3 to 6, the ulnar nerve would lie. And from 6 to 9, anywhere the radial nerve would lie. From the 9 o'clock to 12 o'clock, the musculocutaneous position would be seen for the musculocutaneous nerve. Coming to the indications, so surgery indications for the axillary block or any surgery on the forearm, wrist, or hand of moderate or long duration, with or without the tourniquet. Coming to the contraindication, the contraindications are local infection, any abnormal anatomy at the axilla, like the axillary lymphadenopathy, patient having pre-existing neurological disease or severe coagulopathy, or any patient who is unable to give the position for the block or is unable to abduct the forearm for more than 45 degrees at the shoulder. Anatomy specific to the axillary block. This is from the lateral cord, we get the musculocutaneous nerve and the lateral position of the median nerve. And from the medial cord, we get the medial portion of the median nerve and the ulnar nerve. And the posterior cord, we have the 2 important nerves, the radial and the axillary nerve. The position of the patient and the arm after following the proper guidelines and the checklist, that is taking the consent, identifying the site and the side of the limb. The patient is taken in a sterile in a room, that is the operation theater. Patient lies supine with the monitors attached and IVL line taken. And the position of the patient is, the operated arm is at 90 degrees at the shoulder. We require a sterile trolley, which has sterile gauze pieces, gloves, and cleansing solution. We have ½ inch 26 numbers needle for skin infiltration. We require to have the skin electrode, the 22 gauge, 40 to 55 mm insulated stimulating needle, 18 gauge gauge for the catheter, that is for the continuous axillary block, and 10 to 20 ml of syringes containing the local anesthetic agents and the peripheral nerve stimulator. So what are the techniques for giving this block? So by the PNS technique, we have the single injection, double injection, and multiple injection. And for the palpatory method, we have the transarterial technique. Now for the single technique, the nerve stimulator is said to deliver the current of 0.5 to 1 milliampere with frequency of 2 Hertz and the pulse duration of 0.1 milliseconds. The electric connections with the needle and the neutral electrodes are checked. Depending on the surgical site, the stimulating needle is inserted above the arterial pulse towards the median nerve or below the arterial pulse towards the radial nerve. As the superficial fascia is penetrated, we get a characteristic click, and the current amplitude is slowly increased to 1 milliampere and is slowly increased at 1 milliampere increments until the desired twitch, either we get a flexion or extension of the wrist and fingers are obtained. After the initial motor response is obtained, the needle is slowly advanced towards the stimulated needle while reducing the amplitude. And when we get the desired response at the current amplitude of 0.3 to 0.5, we inject the local anesthetic agent slowly with intermittently aspirating so as to avoid the inadvertent intravascular injection. Even the injection pressures can be monitored so as not to cause any trauma. In the double injection technique, the stimulating needle is first inserted above the artery below the coracobrachialis muscle. And after penetrating the fascia, the amplitude is increased until a synchronous wrist flexion, pronation, and flexion of the first 3 fingers are obtained. That is the median nerve, is stimulated, the needle is advanced slowly towards this nerve while reducing the amplitude to 0.3 to 0.5 milliamperes. At this point, half of the plant volume of local anesthetic is slowly injected with an intermittent aspiration to rule out the intravascular injections. The needle is withdrawn and inserted below the artery, and above the triceps muscles, the fascia is again penetrated and the amplitude slowly increased. The first response is usually the arm extension, that is because of the stimulation of the triceps, and we would get thumb adduction and flexion of the last two fingers, that is the ulnar nerve. However, this response is ignored and the needle is directed much more deeper, often slightly upwards and behind the artery till we get the wrist extension. So after stimulation is obtained using the remaining local anesthetic is slowly injected again with intermittent aspiration. Then I'll also like to add, how do we distinguish between the median nerve and the ulnar nerve stimulation, because both causes flexion so at the wrist. So when there is flexion with pronation, that is the median nerve. Also, when we keep the fingers on the wrist, we can see the twitching of the pulmonaris longus tendon and the flexor carpi radialis, that is for the median nerve. The multiple injection techniques gives maximum success rate. It is preferred with the PNS or USG guided. All the four nerves, the median, radial, ulnar, and musculocutaneous, are targeted separately using local anesthetic agents injected intermittently, aspirating. The local anesthetic agents are per nerve is 5 to 7 ml, and depending upon whether it is used as a sole technique or for analgesia, the concentration would vary from 0.5% to 0.375% or 0.25%. The catheter technique is for the prolonged surgeries, acute postoperative pain or chronic pain, or treatment of vascular disease, for example, Raynaud's disease. In this, the catheter is threaded through the cannula. 18 gauge catheter is usually used, and it is it's threaded cephalate 5 to 6 centimeters, and it is secured to the skin either by taking the stitches or by making a tunnel. Then we come into the trans-arterial or palpation method, where we do not rely on the PNS technique, but we palpate the artery. Mostly it is done more high up in the axilla, so as to include even the musculocutaneous nerve block. Now in this, what we do is we palpate the pulse of the artery, and the artery is pierced with a 1.5 gauge long bevel 25 gauge 25 number needle, and we continuously aspirate. Once we get the bright red colored blood, that means we are in the artery. We go beyond it till we do not get any red blood in our syringe while aspiration, and there we inject half the volume of local anesthetic agent, and that would block the radial nerve. And we keep on withdrawing till we are in the artery again, and till we get the red blood in our syringe, and we keep continuing to withdraw till we get no longer blood in our syringe, and we are outside the artery, and we inject the remaining half volume, and that would block the median or the ulnar nerve. Then coming to the quick assessment of the block, that is by the 4 Ps, we have the push, pull, and the 2 pinch. So this tests the 4 peripheral nerves, the musculocutaneous nerves that innervates the bicep muscle. So we ask the patient to pull his forearm against the resistance. So if he's unable to do that, that is musculocutaneous nerve. Similarly, we ask the patient to push against the anesthetist's hand, that is we testing the tricep muscles, that is the radial nerve innervation. The ulnar nerve is tested by pressing, pinching at the base of the 5th digit, and the median nerve at the base of the 2nd digit. Complication could be because of the drug, that is leading to anaphylaxis or LA toxicity because of accidental intravascular injection or absorption of the LA. Or it could be due to the technique itself, vascular puncture, hematoma, infection, or nerve injury due to direct injury by the technique itself or by the tourniquet itself. I also would like to mention, wherever we cannot palpate the radial artery, in that case, we should especially in the patients who are obese or there's a lot of fatty deposit in the axilla. In such patient, we go with the initial stimulation of the initial motor response can be used as a guide of the needle to redirect to achieve the desired response. For example, when we get elbow flexion, that is stimulation of the coracobrachialis muscle or the musculocutaneous nerve, it indicates that our needle is outside the neurovascular sheath and the needle should be directed downwards and more superficially. So all these proximal blocks should be monitored in the post-operative room and should be supported with the sling. Patient should be explained about the care against temperature and pressure. And most of the times the patients are they have discomfort because of the complete no sensation in the limb. That's why we have the distal blocks. Distal blocks coming to the mid-humeral block. This targets the musculocutaneous nerve and the radial nerve. And here we can see that it is just 3 fingers from the axillary crease, and it is at the upper 1/3 and the junction of the lower 2/3 of the upper arm. Or we can palpate the biceps belly and pull it upwards, and the needle going and hitting the humerus bone. Just before it elicits the response, we direct the needle towards the bicep belly and 5 ml of the drug is injected. Similarly, we can go below the humerus and pulling the triceps belly downwards, we can stimulate the radial nerve. Only thing is that electrolocation of the radial nerve could be challenging here because the radial nerve goes around the humerus in the radial groove. But we can also anesthetize the posterior antebrachial cutaneous nerve at this junction. This comes into play when our the mid-humeral block comes into a picture when the proximal blocks fail, and we can give this block. Only we have to remember that the patient may not experience the injection, paresthesia or the injection of local anesthesia pain. Coming to the more distal block, that is the lateral antebrachial cutaneous nerve block and the medial antebrachial cutaneous blocks. This is a beautiful diagram showing the relation of the two nerves. The lateral cutaneous nerve of the lateral antebrachial cutaneous nerve of the forearm lies deep to the biceps tendon, while the medial antebrachial lies slightly superficial, more proximal to the elbow joint. The indications are superficial surgeries of the forearm, for example, the AV fistula, and it supplements the incomplete brachial plexus blocks. We know that the lateral antebrachial cutaneous is the continuation of the musculocutaneous nerve, and it innervates the lateral half of the volar forearm. And the medial antebrachial cutaneous nerve is a branch of the medial cord, and it innervates the medial half of the volar surface of the forearm. This is yet another beautiful diagram showing its relation to the cephalic vein, and the medial antebrachial cutaneous nerves lies close to the basilic vein. So any perivenous infiltration can give this block. Or by the landmark technique, if we have to go, then we have to go 1.5 centimeters lateral to the biceps tendon, a little deeper, and a further 5 ml of solution still lateral to this point, and that will block the lateral antebrachial cutaneous nerve of the forearm. And superficial injection on the medial aspect of the elbow proximally could block the medial antebrachial cutaneous nerve. Now coming to the selective nerve blocks of the elbow. Again, this is very easy landmarks. We are targeting the 3 nerves, the radial, the median, and the ulnar nerve. These are indicated again for the hand surgeries and the wrist surgeries, where we do not want any more proximal blocks or paralysis of the paralyzing the muscles or making it more numb. Now we have to remember that in this, the anatomy is in such a way that they lie in close approximation to the brachial artery and the vein, and it is a tight compartment. So we have to restrict our volume while injecting in this blocks. so that we do not cause the compartmentalization of the nerve and compression injury. So this is a beautiful diagram showing all the relation of the radial medial and the ulnar nerve relation. See, this is the radial nerve, which is lying in close relation to the biceps tendon, the median nerve lying immediately medial to the brachial artery, and the ulnar nerve, which lies in the ulnar groove, and it has a parallel course to the ulnar, lying medial to the ulnar artery. This is the relation to the arteries. Then coming to the radial block, this is while giving the radial block, one has to also remember that just before it divides, we have to block the posterior antebrachial cutaneous nerve, which supplies the posterior aspect of the forearm. And this can be blocked by giving superficial subcutaneous infiltration just above the condyle of the humerus. And in the radial nerve, the superficial and the deep nerves can be blocked at the elbow. This is the position of the patient with the arm, patient lying supine with the arm directed at 90 degrees. It's a beautiful slide which Dr. Shiv sir has given. And here we can palpate the biceps tendon and we just go lateral to it and we deposit the local anesthetic. Only the volume here we have to go is about 3 to 5 ml, and we note the extension of the wrist. If you are going by the PNS technique, but if paresthesia, then the paresthesia over the dorsal aspect of the hand is expected. For the median nerve, we go immediately medial to the brachial artery. This is how we palpate it, the brachial artery, and we go immediately medial to that. And by the PNS technique, we would get pronation of the forearm or the flexion of the the wrist flexion can be seen. And this is another technique where we can palpate the palmaris longus tendon or the flexor carpi radialis muscle twitches can be felt. Coming to the ulnar nerve, the position would be either this or folding of the hand over the upper limb. It is in the ulnar groove, lies between the medial epicondyle and the olecranon process. It is a small canal, and we have to keep it in mind that the amount of local anesthetic which we inject should be very small, that is 3 to 5 ml. And the response by PNS technique, we would see there will be ulnar deviation, or by the landmark technique, we would get paresthesia on the little finger. So I like to stress that for the proximal blocks, we require more volume. We require to take the consideration of the musculocutaneous nerve in the axilla, which could escape the neurovascular sheath. So we have to direct our needle towards the coracobrachialis muscle while giving this block. We have to be very thorough with the cutaneous and the musculoskeletal innervation of the limb so as to know which areas require to be blocked. The forearm blocks are more denser, requires to be protected in the sling, and patient should be monitored. The distal blocks are the rescue blocks, and we have to remember the volume of the drugs should be reduced, and the patient is unable to complain about the local anesthesia injection pains and paresthesia when it is when it is used as a rescue block to the proximal block. We also need to know that when we are performing a forearm block, we need to target the median nerve, the ulnar nerve, the radial nerve, and with this, we require to also block the 3 cutaneous nerve, the medial, lateral, and the posterior brachial nerve. So I like to conclude by saying that though the proximal blocks are the gold standard blocks for the forearm, for the arm, the forearm blocks can be promoted from their status as rescue blocks to as a useful technique in the regionalis armamentarium. Thank you.
I'm good. No. Hi, Sanjay. That's very well done. I think you could have added a bit if you're explaining and talking about the axillary. I think we didn't have much images. We could have added some images to that.
Yes.
And yeah, I think we will demonstrate. I think hopefully we'll be able to demonstrate some of these peripheral nerve blocks, the rescue blocks in the live demonstrations in a fortnight's time. Anyone got anything to add or any pearls to add to the thing? Dheeraj or anybody else who's on here?
No, I think it was an excellent presentation, Sanju. Very, very nice. And I think it's very important to realize, like, I think there was a question asked, which unfortunately I could not answer, but Shiv's answered it on the forum, where someone asked, like, if they're using a nerve stimulator and they do a suprascapular or supraclavicular block, and then they find there is a partial block. So can they use a nerve stimulator at the same place to actually elicit a nerve response? I think it's a good question, actually, isn't it, Shiv? It's just, and it also elicits that rather than try it at the same plexus, because there are multiple studies done on this previously, where they don't know that when you actually are having a nerve stimulator and you go near a nerve, and then you suddenly lose the twitches, is the loss of the twitch secondary to the local anesthetic immediately acting, or is it basically because the nerve is pushed away from the needle? And there have been a few studies done on this to find out what actual reason is. I mean, I think the most common reason is probably the local anesthetic pushes the needle away. You can't expect it to act in a matter of seconds. But once you've actually given a block and you've waited for a block to act, and then you try to, you waited for 25 minutes, 30 minutes, part of your plexus, it has acted, and then you try to start sticking the needle in the same plexus, would you elicit a same block? And the reason to actually put it with your talk and ask this question is that, there are other blocks which are available. So there's no point that you've tried something like a supraclavicular and try infraclavicular very near where you have actually injected your drug. But coming to these distal peripheral rescue blocks, especially, I mean, it won't help if you're going to operate on your shoulder or something, but if you're actually operating on your hand or distally, then these are the blocks you need to go to. And Shiv, coming back to that, it's an interesting question. What are your thoughts on that? If you have waited for 20-25 minutes and part of the plexus, the local anesthetic has already acted, part of the plexus it's not acted, giving your needle directly, does that stimulate the nerve? And this understanding the mechanism of local anesthetic action is also probably quite important here.
So the answer to that is why your twitch disappear, the so-called Roche test, is got nothing to do with the moving away or blockade of the nerve. It is to do with the creation of a ionic curtain. So when current flows through any of a solution which can dissociate, it dissociates into positive and negative ions, and it forms like an ionic current. So it won't allow current to force through. That also means that if you were to actually inject a normal saline, you will not actually get the same, well, you will get the same response, that you will stop getting a twitches. So you will not block, you're not used anything. And that is why in the catheter techniques where we use using a stimulating wire, you need to use dextrose, because dextrose does not dissociate. Okay. So the nerve does, you're right, the nerve does actually move a bit, and we see it all the time when we do ultrasound block. There is obviously shift, but that is not the main reason. The main reason is that when the current passes through the local anesthetic, it dissociates into positive, negative, and it forms a ionic curtain, and then further no. So what happens in 2020? We have, again, we have seen that how the local anesthetic disperses along the nerve. It goes cranially and caudally. And when you actually go up for 10, 20, 25 minutes, you can actually stimulate the nerve again.
Mm-hmm.
So it is possible to actually redo a plexus block. But the chances are that if you actually do the block again, you might actually end up having the same kind of mixed segment. Maybe it's a anatomical variation. We see all the time where there are tissues between different parts of the plexus. There could be vessels going through, there could be muscle between them. And in that case, I think that's where the rescue block, you have to say, okay, fine, I have actually got some response, and then look at which nerve have you spared and go for the rescue block.
Yeah, I think that's a very interesting point. And this I know because I think there's Ernie who was working with Ariar Cole actually. He had a lot of interest in this and he's published papers in Cambridge when I was working with him. And he was always injecting a little bit of local and normal saline. And he was saying, see, now you can't stimulate even with normal saline. He had done quite a lot of work on that at
Exactly
that
the
point.
same reason.
Yeah. And this is where I think, coming back to the question was that if you actually already have a spread of local anesthetic in that area, it is like, it's not simple like you're saying that, oh, you've had a failed spinal, you try putting your spinal again. It's very much on that lines, isn't it? You might have a partial block at that time. You can't be sure of what is happening. So in your opinion, like, going near the same plexus, is it something you would do? Would you try again? Or would you just go for a more like what, Sanjot's talking about a rescue block, or just say, oh, lift your hands up and say, okay, this is, I'm not going to get it today. Sometimes being a regional anesthetist means accept, your limitation where you should stop. Accept failures.
Yeah, you have to accept failures for the main reason that the anatomy is not the same. So it may not be because you didn't do a good block. It's quite possible that there is anatomical variations present, and then you have to do. Now it depends on what exactly you think is a failure of a block, right? Sometimes the cutaneous nerves do not come from the area where you actually have done the block. And the surgeon pinches the skin and patient. That is acceptable thing. It happens all the time. And all you need to do is you tell the surgeon, just use 1%. You don't need more than 1%. Even you can use even 0.5% lignocaine and infiltrate the skin. So if you are getting the motor block is there, but sensory block is not there, it's not a failure in my opinion. Okay, so just, sometimes you need to give time for the block to work. And you will see that at the end of the surgery, patient has got complete block, which initially wasn't there because maybe local anesthetic took time to seep to the areas which you thought. So testing the block, I mean, we don't get, because a lot of our blocks in UK are done under anesthesia. We never get time to actually test them. But if you're doing it as a sole regional anesthesia technique, learn to test them. Both dermatomal distribution, as well as motor response, which again was shown by Sanjot and other members here have shown it. Just learn to assess your block properly. The other thing I would like to mention again, I mentioned when we're talking about elbow blocks, was that concentration of local anesthetic is very, very important. Now, this is where the conflict occurs between if you're doing under regional anesthesia, you can use lower concentration. You have time for it to work. It's analgesic. Whereas when you're doing a landmark technique or PNS technique, you want to use good concentration as well as you want to use larger volume. Okay, you're afraid of, if you use lesser volume, it will not spread or will not work. So you're limited by that. So you can use lower concentration, higher volumes, but then you need time for that. And sometimes like 0.25 can give you a fantastic motor blockade, but it takes so long. It can take as long as 60 minutes to get a complete block with just 0.25. Whereas 0.5, absolutely, I mean, very, very quick block, is proximal block. Within 5 to 10 minutes, you see it. So that's where the conflict occurs. So if you're actually using it as a sole anesthetic technique, if you have a block room, do a block, go and get a cup of coffee, give them around 30 to 60 minutes to work. That's fine. With ultrasound, it's obviously much more easier. So use good concentration for getting a quicker motor blockade. And don't mix your lignocaine and thing. You are actually not going to actually get any advantage of that. I think Preeti had her hand up. Preeti, did you want to?
Yes, sir.
Yeah.
So the way
Yeah.
I look at it is when you give a proximal block and have a patchy action and the procedure is about to start or the incision has just been taken, that is when you have already almost exhausted the amount of drug that you have already wanted to give. So repeating the block at this time at the same level means you're not very sure about the volume and the amount of drug that you're going to repeat. So at this point in time, I think it makes more sense to, just wash up and give a rescue block where you're just going to use 5 to 7 mils at every point that you decide to choose. So again, in the interest of safety, it's definitely better. And in the meanwhile, also we could, try sedating up the patient a little bit just so that that panic reaction has settled down. That's it, sir.
Yeah. And again, like I said, that's where the conflict actually lies, that when you are actually using larger volume, you are getting towards the toxic limit. And you don't want to use more of the same drug in the area where you may not get. So go for find the definitive nerve which you have missed out and just inject 3 to 5 mLs, or even if you inject 7 mLs or so, it's enough, more than enough for that distal block. So another concept probably which we didn't discuss here is something called the core and mental bundle, concept. Now the way the nerves are arranged in a nerve are like your cable. The outside the fibers tend to block the proximal muscles and area, and the most distal ones are in the center. So if you're giving a proximal block for a distal surgery, you need to give more time for it to work. And you can actually see it all the time. You have given a good shoulder block and patient is still moving the fingers. It's not because you have missed out the C8T1 or what that. It's because those are going to be lost fibers to be blocked. So if you're doing a distal surgery, the more distal you are with your block. So if you're doing a surgery on the wrist, I would actually go for elbow block to get a quicker onset, lesser amount of drug is used, and it works quickly because you are actually as closer to the site of operation. The first shoulders, why do your interscalene work immediately or near immediately? Because you are doing a proximal surgery and you're doing a proximal block. So proximal surgery, proximal block, distal surgery, distal block makes sense. So core bundle or core mental bundle theory is very, very, very important to understand. The people giving supraclavicular block for hand surgery or finger surgery, you have to wait. Don't expect that your surgeon will be able to give an incision in 10 minutes. No, give time, hold time to it.
So I think our timing is such that we have crossed the.
No, we have. Now it is the tea time, isn't it?
So it was, yeah, actually our tea time was between 2:50 to 3:30. I don't know what time it is in India. Is it 3:30 already?
Let me check.
Yes, it's 3:31.
Oh, 3:31.
Okay, yeah. So we have actually crossed. I think, but then we have actually discussed a lot of
done
things
quite a lot
which
of
we would have
questions,
actually
yeah.
discussed now. Yeah. So we would have, I think, covered. Is there any other questions which are pending or which we need to actually answer?
So only one question I'll ask Sanjot, and do you want to catch a quick cup of tea or something before your talks? Because you've got a couple of talks there.
Who, me?
Yeah.
No, I'm fine.
You're fine. Okay.
Yeah.
So Sanjot, one question which always troubles people about these blocks, axillary blocks and stuff like that is, one, we know about the median cutaneous nerve, right? I mean, it branches away quite a bit when you actually go near where you're doing the axillary nerve block, especially if you're going lower. We find that even on the ultrasound. And the other thing is this tourniquet. Okay, if you actually, people are always worried, oh, will I get tourniquet pain if I give axillary nerve block? Or if you're using distal blocks for hand surgeries, what do I do with the tourniquet? Do I put a high tourniquet or a forearm tourniquet? So what's your experience with this? What is it you would recommend with these kind of patients?
So we require a denser proximal block, and we need to block the median cutaneous nerve and the intercostal brachial cutaneous nerve at the axillary crease when going from the biceps tendon to the triceps tendon.
Okay. So just an infiltration of local anesthetic along that crease will help take care of both these nerves, isn't it? Because
Yes.
sometimes you find that people start on the medial side and then
Yes.
only on the medial side you get pain and you say, oh, I blocked the ulnar, but they're still getting pain there. It is just because they've not blocked. So would you routinely advocate giving that with an axillary nerve block, or?
We should give, because that will complete our block with the cutaneous nerves.
Okay. Okay, any other questions, anyone? If not, I think I will, I don't need to introduce Shiv. No one wants to introduce, no one can introduce Shiv. But I think the next talk is going to be Shiv. So Shiv, can I please ask you to introduce yourself if you need introduction?
I will likely introduce myself today, because I think there are people here who may not be on the Facebook and not this thing. Okay, so I will likely introduce myself. What has happened? Can you see my screen? Because my thing is sent.
Yes, I think Shiv doesn't need any introduction.
No,
Everybody knows him
I will
very well.
introduce myself like others. My full screen should be visible now. So I work as a consultant anesthetist in the University Hospital, Liverpool, which is a conglomeration of 3 hospitals. Probably have more, but we call. I chair the department as well, and I'm also lead for audit and improvement, as well as regional anesthesia and clinical governance lead. And as you all know, my main interest is regional anesthesia and education and training. And obviously improvement, audit and improvement is there. I have no conflict of interest. And with that, so this was going to be a single talk, but because there is a bit of an overlap and Mohit is not able to do his lecture, I will cover everything from the hip to the knee, and then Preeti will take over the ankle part. So we were talking about hip fractures and pelvic fractures, or surgeries around hip and pelvis. And most important thing is hip fractures. And when you talk about hip fractures, we're looking at intercapsular fracture, extracapsular fracture, and the surgery depends on this. So you could be doing a cannulated screw, that is the internal fixation, or internal fixation with a hip compression, which is a dynamic hip screw or DHS. And in some patients, you would need to do a partial or total hip replacement. And the regional anesthesia does vary a bit between what you're going to do, because the surgical incision site, the muscle, the myotomes involved, and obviously the bones which are taken off are different for different of these ones. Okay. Pelvic fractures, not all centers deal with them, but these can be quite painful. They can bleed a lot, and they could be just external fixators, and they could also involve numerous platings. Some fractures may be just very stable fracture, which just require a pelvic band, but there are some complex ones which would require fixing with plates and open surgery. So to know the what blocks to be used, it's not only important to know the surgical anatomy, but also important to know the nerve supplies. And if you look at the pelvis, people usually don't understand it much, because they normally come and ask me, I say, what blocks can we give for these patients? So if you look at the pelvis, the nerve supply, and you look at the iliac crest and the ilium, they are cluneal nerves. Here it's only showing the superior cluneal nerve. And this slide was there, but it's not only fractures. One of the other common procedures on the pelvis actually is bone graft taken from the posterior iliac crest or anterior iliac crest area. And that's why you need to know what blocks can be done for these surgeries as well. Sometimes the bone graft is much more painful than the actual surgical site. So superior cluneal nerves, there's medial cluneal, lateral cluneal nerves, and then you have the superior gluteal nerve supplying the main body of the ileum. But there are also the ilioinguinal and iliohypogastric nerves, which travel all the way till the symphysis pubis and supply that area. So you need to also block that nerve depending on where the fracture is. So if you get a patient who's got fracture around the pubic rami, then the nerves you need to block is ilioinguinal, iliohypogastric nerves. Whereas if we look at a hip, the hip is supplied by all the nerves which are coming from your lumbar and sacral plexus. So your femoral nerve, obturator nerve, accessory obturator nerve, the superior inferior gluteal nerves, the sciatic nerve, the nerve decordatus femoris, they all supply the nerve. So you can look at the hip joint, and if you look at the anterior part is mainly by the femoral nerve. The medial part, sort of 1/4 is by the obturator nerve on the medial side or accessory obturator nerve, and the rest of the posterior part of the hip joint is by the sciatic nerve. But the incision goes on to the side of the lateral cutaneous nerve, the area which is supplied by lateral cutaneous. So you require the lateral cutaneous as well. So all of the nerves of your lumbar plexus, as well as most of the sacral plexus, is required if you want to give a proper analgesia for hip surgeries. So for hip fractures, like I said, you need to block the cluneal nerves, you need to block the ilioinguinal, iliohypogastric nerve, and maybe superior gluteal nerve, depending on which part of the hip is fractured. Okay. So cluneal nerves are not only just the superior cluneal nerves, there are lateral cluneal, medial cluneal nerves, and these come from almost L1 to S1. So it's the lumbosacral plexus block would actually cover most of them, but L1 is not part of the lumbar plexus because it starts from L2, and you could get contribution from T12 as well. So the lateral and some of the superior cluneal nerves get their supply from T12 as well. So you need to block those nerves for the hip joint or the pelvic fractures as well. And you can use erectospinal block, part of it. And this is a very common block because these are from dorsal divisions and they're easily blocked. Or you could just use infiltration, and of which all the complex block is lumbosacral block, which I will talk about. So one of the common fractures for pelvis is the pubic rami fractures or distraction of the joint. And that can be quite painful. It happens even during pregnancy, normal pregnancy as well. So pain there. And the nerve you need to block for them is ilioinguinal, iliohypogastric nerve. Well, you'll require bilaterally if it involves the joint, pubic joint. But otherwise, if it is a fracture on one side and they are going to, so it will cover ilioinguinal, iliohypogastric nerve blocks will cover your fracture site as well as the incision site. But in most trauma, you have to also look at that the joints are usually affected. So even though the surgery may be on one side, it is usually that the pubic joint, the pubic symphysis area is affected by the trauma, which has caused such a strong bone to fracture. So it is actually more sensible to give bilateral blocks, even though the surgery on one side. Ilioinguinal, iliohypogastric nerve has been described in various ways. The main landmark is anterospiralic spine. People describe it as going 2 centimeters medially and above, 2 centimeters medially and below. But the one which I tend to follow is the Eichenberger point, which is you go 2 centimeter cranially and then go 2 centimeter posteriorly. At this point, both the nerves are lying in the transverse abdominis plane. So this is also a transverse abdominis approach to ilioinguinal and iliohypogastric nerves. And you will see both the nerves lying in the split in the internal oblique fascia, deposit local anesthetic, and you block both nerves. Whereas if you follow the classical points, you need to go between the internal oblique and external oblique first, and then internal oblique and transverse abdominis, because the internal oblique, your ilioinguinal nerves comes out, and then it lies between the internal oblique and external oblique muscle and goes into the inguinal canal. So better to just go, it is like a tab block. Even if you do not measure, you go over the iliac crest in the mid-axillary line, just above the iliac crest, you angle the needle towards the iliac, so sort of caudally and medially, and you will get the twitch. You can use a nerve stimulator, you can just use loss of resistance technique. Either of them actually works pretty well. And again, we will try to demonstrate that if we have patients. I've got quite a few videos which I have shared on this screen. So, the erector spinal block, this was described as a ultrasound guided block, but I think we've been doing it for a long time. And this is nothing but one step before your, landmark guided thoracic paravertebral block. So the landmark is you mark the spine, you mark a distance of 2.5 to 3 centimeters laterally, and they just go through the bone, go through the muscles and hit the transverse process and just inject there. Okay. Now, if you're using a hypodermic needle, if it is sharp, it can go into the periosteum. So I tend to actually tell that you need to withdraw it a little bit. It can be painful. But if you're using a blunt needle, like the block needle or short bevel needle, you don't actually have to even withdraw. You just hit the transverse process, let go of the needle and inject local anesthetic, and it will spread in the erector spinae area. Okay. It is, I've done it. I have actually done an ultrasound scan, and it works again. The question is, how much local anesthetic would you deposit for the erector spinae? So talking about the pelvic fractures, and the area where you need to block is a T2L, because that will block T2L and L1, and then take care of your clinical nerves. And the way it is considered to work is that the local anesthetic, you can see the, let me get the pointer. Okay, so that is your costotransverse ligament, foramen, and local anesthetic is supposed to seep through that to the paravertebral space, and with time, it will block at least 2 or 3 segments above and below that. Okay. And it's seen that it doesn't matter whether you use 20 ml, 30 ml, it does not spread more than 2 segments above and 2 segments below. So you're looking at around anywhere from 3 to 5 segments blocked. So if you have to cover a lot more, then give multiple levels. Otherwise, if you're doing it at a single place, you can expect it to cover at least 4 to 5 segments easily. So that was for pelvic fractures. Now, for hip fractures, it's very important. There are 3 things you need to know. You need to know your anatomy, that is the innervation of the hip, which I've already discussed. Second thing, you need to be very clear what is the surgery. Is it a dynamic hip screw or the cannulary hip screw? Or are you doing an intramedullary nailing, or it is a hemi or total arthroplasty? The incision, the tissues which are involved is totally different for all the surgeries. And again, you need to have idea about the dermatomes, myotomes, osteotomes, which are involved. So hip fractures and the nerve blocks. So it could be, people do femoral nerve block, fascial block, lateral cutaneous nerve combined with femoral nerve block, lumbosacral block, lumbar plexus block, sacral plexus block. There are huge numbers. So which blocks are done for which surgeries? So if you're doing a DHS or cannulary hip screw, you can do the femoral nerve block along with the lateral cutaneous block. Or you could do a fascial block and or the superior inguinal fascial. So fascial above the inguinal, fascial below the inguinal. Now, because you do not have ultrasound, if you're doing ultrasound, then you can do suprainguinal. But without ultrasound, with landmark technique, you need to use below, don't go above the inguinal ligament, always below the inguinal ligament. Then there is 2-in-1 called 2-in-1. It's used to call 3-in-1 block, where you do a femoral block and give larger volume of local anesthetic, but it tends to block only the femoral lateral cutaneous, which is good enough for the DHS or Canada hip screws. Yeah. So it is never 3-in-1 block, and we will likely discuss that in a minute. But if you're doing a intramedullary, hip screws, or you're doing a hemi or total arthroplasty, then in that case, the mother of all blocks, the lumbar and sacral plexus block, and you will cover everything. They're deeper blocks, they're advanced block. And with the ultrasound, we talked about PANG for shoulders. Similarly, you have PANG for the hip, and you can combine it with lateral cutaneous, because PANG will provide analgesia for the hip joint, but not for the incision. Or you could use PANG with local anesthetic infiltration as well. So both can be used for analgesia. Okay. Fascial iliacal block, all of you would have done. It's very easy. You mark the inguinal ligament from antecephalous spine to pubic tubercle, divide into lateral 1/3 and medial 2/3, a centimeter or so below it. And you go through the skin, you feel the first pop through the fascia lata, second pop through the fascia iliaca, deposit local anesthetic, and it'll spread over to medial side. So you can actually see it here. You need to pierce the fascia iliaca and the local anesthetic. The femoral nerve lies under the fascia iliaca, whereas the lateral cutaneous lies above the fascia iliaca or under the fascia lata. Right. So easy block to do, easy to master, as long as you understand that concept. So what is the spread of local anesthetic? So you're using large volume here with fascia iliaca. Now, if you got a patient who is 50 kgs, maybe 20, 30 ml work. But if you have a patient who is 70 to 80 kilos or 100 kilos, you need to use larger volumes. You're looking at 50, 60 mLs of local anesthetic to get a good spread. Now, the commonest spread occurs obviously over the psoas muscle, but a large amount does actually spread over the iliacus medially. Okay, sorry, laterally. And very rarely you'll have spread going up to the lumbar plexus, the origin of the lumbar plexus. Okay. So more than 60% of the time, you're blocking two nerves. You're blocking the femoral nerve, and you're blocking the lateral cutaneous nerve over the iliacus, which is lying just under the fascia lata. So that's the spread of local anesthetic fascia iliaca. People say that if you are injecting above the inguinal ligament, it will go more proximally. How true that is, we don't know. Okay. The spread is probably still, it's more likely to spread over the iliacus to block the femoral and lateral cutaneous nerve. Now, coming to the lumbar plexus block is a block which is by PNS. It is the landmark I use is Capdevilla's approach, wherein you first mark the spine and then draw a line across. That's the first line. The second line is a two-fierce line. And third line lies parallel to the first line, which goes from the posterior spine parallel to it. And then what you do is the line between the third line and the first line divided 1/3, 2/3, and go a centimeter above that. Now that's where you got the transverse process. You're going to hit the transverse process and walk off it. Okay. No, it's a deep block. People are concerned that, oh, it's a very deep block. So what do you do? So yes, it's a deep block, but it depends on the size of the patient. For patients who are thin patients, you can hit the transverse process around 3.5 to 4 centimeters. But in obese patient, it might be as long as 8 centimeters. But that is hitting the transverse process. But beyond the transverse process to the plexus, when you walk off it, the distance is very constant. It's almost 18 to 20 millimeters or 2 2 centimeters or so. If you're not getting a twitch by hitting the transverse and moving 2 centimeters, then you need to come back and look back at your landmarks. So yes, it is advanced block, but it is mother of all blocks. It's deep block. It gives you perfect analgesia for the hip joints, but not on its own. You need to combine the lumbar plexus along with sacral plexus for it. So for sacral plexus and lumbar plexus, patient is on the side. The landmark you follow is that you have already marked the posterior iliac spine for lumbar plexus. Then you mark the ischial tuberosity and draw a line from that. And again, you divide that into lateral 1/3 and superior 1/3 or inferior one. That is, inferior is looking at the feet level towards the feet. So 1/3, 2/3, and then just go at that point. And the response you're looking is similar to what you would look for a femoral for lumbar plexus and the sciatic nerve response for sacral plexus. So you would look for, it doesn't matter what you're looking for, plantar flexion, dorsiflexion for sacral, that doesn't really matter, but the response is same. For lumbar plexus, you're looking for the twitching of the quadriceps. Now, one of the things you will notice when you are doing a lumbar plexus block, the sacral plexus block, sometimes you tend to stimulate the superior gluteal or the inferior gluteal nerves, and you see the gluteal response. And you have to be careful. There are gluteal vessels and that, so always aspirate and inject before you do the block for these levels. You can use classical approaches as well to the sacral plexus, like the Raj approach, which is a midpoint of the junction between the greater trochanter ischial tuberosity, the nerves. The sciatic nerve follows that course. So you can draw the course and you can block the nerve anywhere on this course. The parasacral blocks, which was described by Mansoor, was basically going from the posterior superior spine on 6 centimeters. So that's a fixed point, which may not be true for patients who are big or patients who have a very large pelvis or high pelvis. So they may not be actually true for them. So using proximal 1/3 and distal 2/3 is the landmark we tend to use. Now, Peng block became very popular, or it was more fashionable, and still is, but it is described as a ultrasound guided block. Peng stands for pericapsular nerve group block. And so this is looking at the nerves which supply the joint. So these are articular branches which are coming anteriorly from the femoral and obturator nerves. So it doesn't provide the analgesia which is coming for sciatic nerve. But it has been seen that the main pain generator comes from the obturator and from the femoral nerves. So blocking and giving local anesthetic at this point will provide good analgesia in the postoperative period. Now we have seen how to do the facial iliac block. I just described it. Now if we move a step forward, okay, you take a longer needle, you get a 2 pops, and you just keep moving in till you hit the bone. There, you will be hitting the iliopubic eminence or the bone there, and you just deposit local anesthetic in there. It will spread in that area. Now, the whole idea of Peng was to actually say that we don't want any motor blockade, so it was a motor sparing block. But you should also at least look at that. If the local anesthetic spreads anteriorly, it can block the femoral nerve. So there are quite a number of case reports where they said, oh, we did a Peng block to spare the motor effect, but we still got a local effect. That's because it can spread over the iliopsoas and block the femoral nerve. So that's quite possible. So it is possible to do a Peng block in patients. Useful block after given a spinal anesthesia. I would suggest if you want analgesia for post-operative period, do that, inject around 30-40 mLs of local anesthetic, probably better than the surgeons doing LEA for that. I've used it as along with Spinal, and patients get excellent analgesia for a long time. So that was actually just one lecture, the first part of the lecture. And because the femur and knee are in continuation, and some of the blocks which are done, I would actually continue with the second, which was Mohit was supposed to do this lecture. So I will actually continue into femoral and knee surgeries. Okay. So the femoral surgery can usually be intramedullary nailing, where they ream the femur all the way till almost the knee joint and put a long nail into it. Some do short nail, long nail, depending on the type of fracture, or it could be plating, which can be again be a single plating or double plating. Most times it is actually a double plating of the femur, lateral side and anterior side. So the blocks for that, I've already said that for intramedullary hip screws, lumbar and sacral plexus is a preferred block, but you can use a combination of the femoral block and lateral cutaneous block for platings, for intramedullary nailing. Intramedullary nailing requires blockade of sciatic as well. So if you're using intramedullary nailing, the incision is pretty high up. It is almost goes to the level of your iliac crest. You can ask surgeon to local infiltrate if you get any response. But main nerve for the IMHS still is femoral nerve. You need to block that. So coming to the other area which is common, and it's the commonest surgeries are knee arthroscopies and arthroplasties. And knee arthroplasties can be very painful. You could also add the anterior cruciate ligament reconstruction to this, but that is also again part of orthopedic arthroplasty surgeries. It is done arthroscopically, and posterior ligament, which is not as common, but still done by some. Okay. So the knee innervation is complex. You have got lots of nerves around it, and no doubt, despite the best of anesthesia, patients can still have pain after the knee surgery. So it's complex. You can look at that. There are branches coming through femoral nerve, branches coming from obturators, branches coming from sciatic. So there are all different nerves which are supplying that, and you can actually see in the diagram. It's a very clear diagram. You can see nerve to vastus medialis, nerve to vastus lateralis. Then there are genicular branches coming from them, genicular coming from saphenous, coming from femoral, coming from the branches of sciatic nerve. So pretty complex surgery. Well, if you look at the osteotomes, you look at the nerves which supply the anterior and posterior part of the knee joint. You can see that there's L3, L4, L5, S1. Okay, so L3, L4, L5, your lumbar plexus. The nerves which coming out from this are your femoral and obturator nerve, and L4, L5, S1, S2, S3. That's your sciatic nerve or branch of the sciatic nerve. So you need to actually require both the branches from lumbar and sacral plexus. So looking at the blocks, you can actually talk about the motor sparing blocks and non-motor sparing blocks. So it has become fashionable to do surgeries at day cases or early recovery. And motor sparing blocks, you have the adductor canal block, genicular nerve blocks, local infiltration of anesthesia. And non-motor sparing blocks, femoral nerve blocks, and a combination of the popliteal fossa blocks or this branch of sciatic nerve block. These are the common blocks. So what are you looking at is doing adductor canal block or IPAC, which is more of ultrasound block. So it's nothing, I'm just mentioning that. Genicular nerve blocks, again, they're more ultrasound guided or radiologically guided blocks. But then they are becoming more popular as well. And then you can have selective. The posterior capsule is supplied by the tibial branches or articular branches from tibial nerve. and in the end, local infiltration by the surgeons. Okay. Can adductor canal block be done with PNS guided or landmark technique? Landmark technique, probably not, but you can actually do a PNS guided block, and this has been published by us, and it has been demonstrated multiple times. So here we are actually going pretty close to, this is more of a adductor hiatus block, and what I'm doing in this, if you look at the image, my left hand is pinching the sartorius. So sartorius is coming across there, and you got the vastus medialis, and there's a groove between the sartorius and vastus medialis, and I'm going into the groove along with the needle. Okay, the needle will go and stimulate the nerve to vastus medialis, and that is the response you see. So you see a local response around the vastus, end of the vastus medialis, because the saphenous nerve and nerve to vastus medialis are lying close by here at this point. The other advantage of adductor hiatus block is that the blood vessel is there, the local anesthetic seeps along it, and you can see some amount of local anesthetic which will go and block the tibial, which lies just above. If you look at the popliteal fossa, it's just lying above it. So you get, and that is the one which provides the analgesia from the posterior capsule. So you can see. So this is just describing the whole of the adductor canal. Most people tend to do more proximal, and there is a recent article about classification of adductor canal. We have always done, in our cases, done the adductor canal much lower down at the hiatus level, where you can stimulate the nerve along with the the nerve to vastus medialis and see a motor response from that. IPAC is a ultrasound guided block. I don't think you can do this block by the landmark technique or by the PNS technique, because there's no nerve. This is just deposition of the local anesthetic between the capsule and the blood vessels. So you don't want to be actually doing that. So that's how where the local anesthetic is deposited. But again, you need to be aware of that. There is something called an IPAC block, which is between the blood vessels and the thing. And you will realize that this is actually important for posterior because it has been deposited near to the artery. So you got the nerve and you got the artery, and the nerve lies just under it. So it will provide analgesia for posterior capsule. Okay. Genicular nerves, we tend to block the superior medial, superolateral, and the inframedial. We don't block the infralateral nerve, which is actually in a tight compartment. But these nerves are blocked. They lie along with blood vessels. You can see them with ultrasound. They can be done, with people do after in the X-ray guidance done by chronic pain people. But I think as a landmark technique, it's very difficult to just do it without any kind of imaging. So what do I do for my cases for the knees, arthroscopies, ACL repairs, or for total hip replacement? Now it depends whether I'm giving a patient, spinal anesthesia, which is a very common technique for knee, or if there are patients who have refused or there is contraindication to doing these blocks and they give GA, that's a different matter altogether. So if the patient is having a spinal anesthesia, then they will all get a multimodal analgesia, and they can get either adductor hiatus block, and this is followed by the local infiltration analgesia by the surgeon. They tend to use just now they're using just plain local anesthetic. 100 mL of that is injected, and you need to tell the surgeon, please, concentrate on the posterior capsule, because that is where the most pain comes from for patient. They need to give a good amount of local infiltration into the posterior capsule. When I'm doing a GA, then I'm actually more diligent. I tend to give them adductor hiatus block, and I would either do IPAC or select tibial nerve block with small volumes. So I would put around 3 mLs to 5 mLs, even not 5 mLs, actually probably less than 5 mLs for the selective tibial nerve, and just at the popliteal crease. And then very recently, I have actually started combining them with genicular nerve blocks, especially in the awake patients. Sorry, in the patient who are having GA, or patient who we are going to actually discharge home, the same day or early on. So these are the techniques I actually use for them. And I think that's the end of both the lectures, and it'll be good to actually have a good discussion on that. Thank you, guys. And thank you, Team Mumbai, for taking this forward. And I'll see you all in a fortnight's time. Let me stop sharing. Yep, I'm happy to take questions. I don't know what questions have been asked on the YouTube.
Hi, Shiv.
Yeah.
I think there have been a few questions, and
Yeah.
thank you for a wonderful talk as always. Very informative, and I think I like that last slide of what I do maybe going forward. But you see, I'm not as recognized as you, so people won't care what I do. But I think
not everybody should know what you're doing.
But
yeah.
But it's a very interesting perspective. So a few questions. I mean, I think our dear friend, Dr. Dilip Parmar is asking a couple of questions. One of the questions he's asked is that, is erector spinae block at T12 level to cover the cluneal nerve?
Yeah.
Yeah.
That's right. That's right. So cluneal nerve, you can actually do it with just local infiltration above the iliac crest. That is one way of doing it. Others is just you put some local anesthetic around T12L1. Some of the components do come from there. So if you're using it as a part of, say, lumbosacral as well, so very well go and actually put some local anesthetic around T12 as well. And that is it. But if you're not actually doing lumbosacral block, then you can just do infiltration over the iliac crest, posterior iliac crest, and you will catch the cluneal nerves.
Okay.
The local infiltration also works quite well.
Yeah. So the other question to add, I know we are going to discuss thoracic ESPs later on. Is there a difference between a lumbar ESP as compared to a thoracic ESP when you do a sort of a landmark technique for ESPs?
100%. I will discuss that when I actually talk about the posterior spine surgeries. There is a marked difference between the two.
Okay. The other question from Dr. Parmar, I mean, he's asked a lot of questions, is about, so he's asking the difference between the PENG and the fascia iliaca block. Why would you choose PENG? I know you've already answered about the motor component of that, but what's the main reason of PENG over FICB?
Main reason obviously is that it's a motor sparing. PENG is motor sparing because you're only blocking the articular branches. Whereas when you are doing fascia iliaca block, the local anesthetic will spread to the nerves, the femoral nerve, so it will cause motor blockade. So, but like I said, if the local anesthetic moves around your iliopsoas, it will end up blocking the femoral nerve as well. So if you are injecting larger volume and spreads, you can still get motor. So even though it is a motor sparing block, there are case reports of patients having motor blockade from the spread to the that.
And this another question which I want to ask you based on this because of the FICB, and what people don't realize is that when I actually worked in Singapore, I think in 2001, we were giving sort of fascia iliaca block for knee surgeries. And what people don't realize is that fascia iliaca block actually, if a successful block, has to block the femoral nerve. So when you were giving all this, the various modes, I mean, suppose someone doesn't have a nerve stimulator and wants to do a block for the knee, they can still do a fascia iliaca block, right? It will block the femoral component of your knee pain massively. So they could technically combine a fascia iliaca block along and ask the surgeon to just infiltrate the posterior capsule or along the posterior capsule.
Absolutely.
And that should actually give sufficient analgesia, won't it?
Lots better. It gives a much better analgesia than, just relying on fascia iliaca.
Yeah.
Like I said, the pain, the posterior, capsular pain is quite significant. And you will actually see that when patients have had surgery and spinal is wearing off. And even though the patients have had local infiltrating analgesia, if the surgeons have not concentrated on the posterior capsule, patient will complain of pain, posterior pain. And in some cases, it has been said that if you go and then give them popliteal fossa, the pain disappears within minutes. But again, you don't have to do a proper popliteal fossa block. You don't have to block the sciatic, both the components. You can go and block just the tibial, because that's the main component is coming from the tibial. So you just, if you see the division is already there, then you target the tibial nerve. The common peroneal also provides a component. You see that your lateral genicular branch, lateral inferior genicular branch does come from the the common peroneal. But the capsule, the main capsule is branches from tibial nerve. You get excellent analgesia.
Yeah, so this is very interesting, isn't it? Because initially the posterior capsular pain is what was the reason a lot of us used to do a sciatic block for initially.
Yes.
And if you actually have got a surgeon who's quite well trained, I mean, it's one of your regular surgeon, and you actually tell him to infiltrate the posterior capsule, all right, the need for sciatic block for knee probably goes off, right? It's only
Absolutely.
then if you need to have a rescue block that you need to use that.
Yeah.
Sorry, who was that?
Hello.
Hi, hello, Dr. Yeah. Hi, Dr.
Hi. Hello.
Hi. Yeah, we can hear.
Yeah. I want to ask, generally these lower extremity blocks are called as high volume blocks, if I'm correct.
Not necessarily, but I think it's the kind of volume we will
It
normally
is
with
generally a basic teaching that most of these blocks require very high volume.
Yeah.
So how much high volume do you generally use? And do you add any additives like dexamethasone or maybe fentanyl, or many people have added so many additives, even clonidine, dexmedetomidine, fentanyl, all those things. They have been adding in these blocks. So whether you do that or no, and why?
Yeah. So the first question is that about the volume. Now, for example, I actually have probably the largest series of lumbar and sacral plexus block.
Right.
I've done more than 1,500 now.
Absolutely.
And so the volume used with PN, it's a PNS guided. It's not a landmark technique. It's a PNS guided. And all you need is 20 mLs for the lumbar plexus and 10 mLs for the sciatic, the sacral plexus.
Okay.
So it's not a large volume. 30 mLs for covering two plexus is not large volume. So
What about fascia iliaca?
So fascia iliaca, will come to the fascia iliaca in a minute. So if you're looking at the specific nerves, then again popliteal sciatic, I've done thousands of them with PNS and probably much more. It probably goes beyond, numbers is pretty high. I do them in the clinics as well for removal of frames. So we do have huge numbers of these popliteal, no more than 20 mLs in most cases. If I actually get a patient who is like, 6 feet, big guy, I might use 30 mLs. But in most patients, I haven't used more than 20 mLs. And I can actually show you videos of where the whole thing has been removed, big fins been removed awake in these patients. So you don't require larger volume when you go into a specific nerve. But coming to the fascia iliaca is a fascial plane block. So whether it's in the abdomen, whether it's in the leg, wherever fascial plane blocks are done, you require larger volume. And like I explained with the diagram where I was showing how the local anesthetic spreads, your assuming that it was also known as, well, there was 3-in-1 and there are fascia iliaca block. There are actually similar large volume blocks where you're hoping that the local anesthetic will spread proximally towards the lumbar plexus. But it doesn't actually happen that way. It spreads over the iliopsoas. So, and iliacus is a large muscle over which is spread because it's got a fascia under which spreads under that, and it spreads over the iliacus muscle. So you need to require larger volume, and it depends on the patient size. So if you're doing you cannot use it for a surgery. You normally use it for analgesia, and you require 0.25%. So I tend to actually use a very simple formula. If you're using levobupivacaine, you can use volume equal to patient body weight. Even though they say that the toxic limit for bupivacaine, levobupivacaine is actually same 2 milligram per kg, but actually it's not true. You look at pediatrics, they always use 3 milligram per kg for that. But again, if you're using ropivacaine, you can use 3 milligram per kg anyway with 0.2. So you can use larger volume of that equal to patient body weight. So if you got a patient who is like 90 kilos, 60 mLs of 0.25 is not a large volume for him.
Okay.
Yeah. So even though we say it's large volume, that's because you want a good spread. Fascia iliaca block, I would actually, if you can't do lumbar plexus or other kind of blocks, then okay, fine, you need to use larger volume for that. But if you're using it for, say, dynamic hip screw, which is a very common surgery, then you need to block just the femoral and lateral cutaneous.
Okay. Yeah.
That too, you can actually do separately. You can do a landmark technique, lateral cutaneous block, which actually I didn't talk about, where you go, anticipilic spine medially 2 centimeters and 2 centimeters below, and you feel for a single pop, not a double pop. You single pop through the fascia lata and deposit local anesthetic 10 mLs there, and you use 20 mLs for fascia iliaca, or do a peripheral nerve block, do a femoral nerve block with ultrasound, with PNS, and inject 10 mLs there, or whatever, 20 mLs, and you got both. You cover everything with that.
And what about
Okay.
additives?
Additives, sorry, the last question, no. Do not use any additives with my local. I do give dexamethasone to all patients IV, and that provides analgesia for 18 to 24 hours. For shoulder surgeries, I would actually, like Dheeraj said, does it with just blocks. I think there it makes sense. You can actually add it. It does improve the quality of the motor block and duration of the block. But if you're using for analgesia, I don't see any reason why you want to add a dexamethasone with the local anesthetic, unless of course you have got a preservative-free dexamethasone. Then yes, you can add it. It gives the same, but advantage is actually very minimal if you're mixing with local anesthetic or giving it IV for analgesia. It's no difference.
Just for prolongation of the duration of anesthesia, maybe clonidine or dexmed is also added in this.
Yeah,
do you recommend?
No, like I said, if you're doing for awake, that's fine. But if you're doing under GA, you don't need to, because GA covers that. Analgesia will be 18 to 24 hours with IV. So, but if you're doing awake, then yes, you can add dexamethasone or clonidine to the blocks. I have got no problems. But like I said, I don't do that kind of surgeries as Dheeraj does. So he might be able to answer that. Dheeraj?
No, I don't add anything more than what is required. That is my normal practice. I just follow it very simple. And you make quite good points. I mean, it just, it's not about prolonging the surgery too. Sometimes having these helps in giving a slightly denser block than what you would get. And you've already mentioned that, Shiv, about, just making it more slightly denser. There are a few more questions, Shiv. I mean, I think Kaushik asked a question about the total volume of bupivacaine and concentration, which you have already answered. Yeah. And there is another question which I think you've answered about. So there is, we've already answered. Someone's asked about, can we use FICB instead of ACB? And we said it's the same thing. Yeah, you're targeting the femoral nerve, so you can use that. Dilip has asked a question about if you actually use a high volume for ACB, does it spread to the posterior compartment?
Yeah. So with that, no, ACB, then again, I think we need to be very clear about ACB and adductor hiatus block. The one I do, and I always have been doing, is the adductor hiatus block, which is almost, if you were to take a 4-finger breadth above the knee joint. Okay, that's where, with ultrasound, you can be very clear. You can actually see where it becomes a hiatus, where the artery starts dipping down, that's there. So you require no more than 20 mLs again in the adductor hiatus. So injecting 30, 40 mLs wouldn't give you any greater spread to the posterior compartment, but you do get enough local anesthetic seeping. I think the way I describe it is that because your local anesthetic is in a space where you have an artery, pulsating artery, when the local anesthetic moves there, I think it moves along that compartment. And you know that the your tibial nerve is lying in close proximity to your popliteal vessels. So, and even if when I'm doing a very selective block, I tend to use just around 3 to 4 mLs. And that's enough for providing analgesia from posterior capsule. So that's probably is enough for, and that's for adductor hiatus block. We did a study in for ACL reconstructions, and we were doing adductor hiatus block, and we were able to reduce the morphine requirement from, which was anywhere from 30 to 40 milligrams, to just 2 to 3 milligrams, or maybe 5 milligrams at the most. Okay. And that I can only explain on the basis that the local anesthetic is actually seeping down to the posterior compartment.
That makes very good sense. A couple of other, I mean, most of the questions are about concentrations in fascia block. And I think you actually have to marry your concentrations to what your volume is sometimes, depending on the patient.
Very simple. Like I said, volume blocks 0.25%.
Yeah.
Okay. And if you're using levobupivacaine, you can use volume equal to patient's body weight, and you still have a leeway. So even if you're going like 40, 60 mLs for a 70 kilo, but you still got 10 mLs left where you can use 1% lidocaine. That comes to another point. Somebody has actually asked, oh, I have used all the volume for bupivacaine and lignocaine, and can I use ropivacaine? Actually, that's the wrong answer completely. First of all, I think they were already thinking that they have used the highest volume for lignocaine and bupivacaine. It is additive. So if you have to use 2 local anesthetics, right, you take the maximum amount for the bupivacaine, maximum amount for ropivacaine, and then you divide into half, whatever and that is your maximum amount you can use. It is not that you can use 2 milligrams per kg of levobupivacaine and 3 milligrams of kg of ropivacaine. No, you can't. It is either 2 milligrams per kg of ropivacaine or 3 milligrams per kg of bupivacaine. Levobupivacaine is 2 milligrams per kg. Yeah.
So the toxic dose is additive, isn't it? So when you actually calculate the toxic dose, it is an additive. So you have to calculate the toxic dose of each local anesthetic which you're using.
Yeah. Yeah. And then they will say, I want to use 50 of that, 50 of that. Then you use half the maximum volume, half the maximum volume of that, or 1/3, 1/3, 1/3. First of all, don't mix anything. It makes no sense at all mixing 2 long actings or mixing a long acting and a short acting. Short acting will go and block your sodium channels, and by then your long acting is getting metabolized, so it's useless. Okay, either use it sequentially, right? So sometimes this I do it for minor procedure, day case procedures, where I do a proximal block with a local lignocaine and tell surgeon to use long acting infiltration. So that's enough. The lignocaine is enough for the surgery, and for post-op analgesia, the infiltration actually works.
If you are using 2 drugs like lignocaine and maybe bupivacaine, then do you mix it prior to injection or you give it separately?
We don't do either.
Okay.
Yeah, the reason is very simple. Okay, fine. You will likely have good lignocaine. Obviously, it is quicker acting, right?
Yes.
and it will go and block the sodium channels. And how
Correct.
does local anesthetic? They go inside the sodium channel and block it from inside,
Correct.
right? Now you give a lignocaine, it's already blocked. So what is the bupivacaine going to do? It is going to block for you 60 to 90 minutes.
Right.
And you can see that when you get, your tooth done with lignocaine, your numbness lasts for at least 3 hours.
Okay. Yeah.
So you already blocked that, but at the time you got the local anesthetic, the long acting, which is outside, and it is getting metabolized.
Correct.
So when you actually, when it should be working, it doesn't. So it's better to have a slight, slower onset and use just a long acting one, than try to mix it.
Okay.
Yeah. And I've had experience myself with that. I had a finger surgery done, and the first time the surgeon did the same thing without, actually, I didn't realize that he was doing that. And I had my surgery, and by the time actually I reached the recovery, I was actually in agony. The surgery went fine, absolutely fine. The bupivacaine they had used did nothing to it. So when I had my repeat surgery, I told them, please just use 0.5%. And I can tell you that the local anesthetic were working and they were injecting. It was a finger surgery, so they were doing a metatarsal block. And as he was injecting, I could actually feel the numbness. So the onset is actually pretty quick if you're doing a distal block for a distal surgery. And the analgesia lasted for me for more than almost 24 hours.
Wow.
Yeah. So there is no point in actually mixing I think I think it's a wrong concept. It's a myth that, you're going to enhance the onset and but I think because most of us do not follow the patient up post-op for a longer period of time, we do not realize that they probably might have been in agony, they would have worked out.
Okay, Shiv, one last question, because I think in the
We should
interest of
move on.
time. Yeah, there is one. So Dilna's is mentioned a question. I'm just going to make it more interesting. So what she said is like, when we inject for FIB, does ropivacaine or bupivacaine make a difference? Now, what I'm going to ask you is change this question slightly, saying that, if you're going to do a nerve block with ropivacaine, you probably get lesser motor block as you get with levobupivacaine. But if you're talking about facial plane blocks and looking at sensory nerves and stuff like that, do you think it makes any difference on the choice of your local anesthetic, either ropivacaine or bupivacaine?
Not at all. Not at all. I think for facial plane, I think I would actually say that people should be using ropivacaine. And the reason being that ropivacaine, you can use 3 milligram per kg. You can use larger dose, and these are volume blocks. Don't shy away with volume. The larger the volume you use, the better spread you get, the better area you cover. Okay. Whereas you would be restricted. You're not looking at giving a motor block or things. So it makes no difference at all. And I would actually say 100% that if you got ropivacaine and if the cost is not a concern or thing, is just use ropivacaine for that. It's quite a safe drug. And larger volumes can be used, safer volumes can be used. And again, you will also have a drug left for using for local infiltration.
When you are hello.
Yeah, go on, Dr. Kale.
When you are using lignocaine, whether you use plain lignocaine or lignocaine with adrenaline?
Yeah. Lignocaine with adrenaline is really good.
Always.
Yeah. Our surgeons, when they are doing the surgeries under their block, they always use lignocaine with adrenaline, 1 in 200,000. We already have the pre-mixed one.
Right.
Then the volume is actually much less. See, that's the problem with lignocaine. The volume, they just get 20 ml vials with 1 in 200,000. So you will have to keep loading quite a few of them. But we don't use it. You don't use that blocks.
Generally, the people try to avoid this lignocaine with adrenaline, particularly in hypertensive or IHD patients.
Yeah.
They don't like to use adrenaline, and that is why maybe the plain lignocaine they use, and then automatically the volume is then less.
Yeah.
Then they try to add bupivacaine to that. So
No,
whether it is correct or no?
No, like I said, you just use a long-acting local anesthetic, simple
That's it.
and easy. And as far as lignocaine with adrenaline, about in hypertension, 1 in 200,000, that's a very small dose normally. But again, the more volume you use, the more adrenaline you are acting. So it can actually, that's where it becomes. But when you're using for a smaller surgery, like I said, for digital or for any other, surgery, they use very less volume. Like for example, for the carpal tunnel release, our surgeons, they tend to use lignocaine with adrenaline.
Okay.
Yeah. So yeah, it's a very good point actually, Dr. Kale. Thanks.
Yes.
Adrenal is
Thank you.
bupivacaine or lignocaine, even for
Yeah.
perivascular blocks. Sometimes,
Correct.
if you go look at most of the Canadian side, if you're going to somewhere where you're going very close to a blood vessel, it helps you
Yeah.
detect an intra-arterial or an intravascular injection
Absolutely.
with a couple of mils. So I think we'll have to leave it there in the interest of time. I think it was an excellent discussion. Excellent talk, Shiv, as always. Thank you very much.
Absolutely excellent, Shiv. Thank you very much.
So I'd like to invite Preeti now, who is gonna go very, very distal after, we started with the head this morning, so we are gonna probably end up with the foot. So Preeti, can you please go ahead with your presentation on ankle blocks, please? Thank you very much.
Yeah, thank you so much, Dheeraj. And fitting me suddenly after Dr. Shiv sir is like, I'm getting shot in my own foot now. So yeah, is my PPT visible to all?
Not yet. Have you shared it? You have not shared it.
I think I did. Just a second.
Try again.
Not yet. Yeah.
Not yet. Okay. Yeah.
It's not visible to me now. Yeah. Yeah. Okay.
Yeah.
Yes.
Yes. Let me wish. I think it's good day. Almost good day to the guys in the West. Good afternoon to everyone in Mumbai. And on behalf of Team Rads Mumbai 2023, it takes us gives us a lot of pleasure in inviting all of you face to face a little less than a fortnight from now. Now, I'm a small-time freelancer working in suburban Mumbai for the last, say, 20 odd years or so. Here, I do not have any conflicts of interest. However, I'm very grateful to my daughter, who's been a model and graciously allowed me to use pictures for the purpose of my presentation. Coming to the fag end of the body or the toe end of the body, I would like to take up Dr. Kale's challenge and present to you blocks that require no high volume, no additives, no adrenaline, and hence you got to really try your best to create any sort of complications. Okay, now ankle blocks are a safe and effective method for delivering anesthesia and analgesia for surgical procedures on the bones and soft tissues of the foot. Now, where all would we be using these ankle blocks? For procedures, mainly say you got 3 kinds of patients coming to you. You could have the pediatric kind with developmental anomalies or simple procedures on the toes, like maybe an ingrowing toenail or K-wiring for fracture phalanges or MTP joint issues. And forefoot surgeries, K-wirings, debridements, diabetic foots, warts, calluses, and the like, amputations. And there is another special category of patients here, let me mention, with multiple comorbidities, the old kinds with really bad diabetics and peripheral vascular diseases. So it's this special type of category of patients that require more attention. So commonly we do say that I would like to use ankle blocks when GA or a CNB or an epidural would be contraindicated. And of course, it is an excellent method of administering post-op analgesia to whatever surgery you're performing on the foot. Coming to the main nerve supply of the foot, you have 2 main nerves. There is the saphenous and the sciatic. Saphenous is simply an extension of the terminal branch of the femoral nerve, and the sciatic breaks up into the terminal tibial nerve and the common peroneal, somewhere in the middle of the thigh from the behind. So the tibial nerve, you have it breaking down into the sural and the posterior tibial nerves, and the common peroneal breaks up into superficial and deep peroneal. Neuroanatomy of the foot, very, very simple as opposed to the complex diagrams that we have seen so far. You have the median peroneal nerve, the lateral peroneal nerve supplying the foot from underneath. The sural nerve has a very small sliver on the lateral side. Saphenous nerve, again, the arch of the foot. Now, so here, if you know exactly what the procedure is or where the area of surgery is, it's very easy to actually pinpoint and go and block that particular nerve. Hence, there is a massive reduction in the amount of drug that you're going to give. Heel is mainly covered by the tibial nerve. So if you have, the osteomyelitis of the calcaneum, which is again very common in diabetics and those with peripheral diseases or vascular diseases, this is a good nerve to block. Again, on the dorsal aspect, you have the saphenous nerve covering the medial aspect of the ankle along the medial malleolus. You have the superficial peroneal nerve. Now, this forms a very significant area of distribution. And you will see that it covers almost the entire dorsum of the foot, barring this little part over here. That is the lateral aspect of the great toe, the web space, and the medial aspect of the second toe. Now, this is provided or innervated by the deep peroneal. And you have the sural nerve laterally. Now, this is one thing I had spoken to about in Nbfm Hyderabad, and I had forgotten all about it until one delegate came up to me in November, again at Hyderabad, and said, "Madam, I love that statement of yours. Give me a syringe, give me some LA, and watch me block." So all you require for this particular procedure is skin preparation, drapes, marker pen if you have one, if you're luxurious enough, some gauze, syringes with the LA that you could choose, and a 25 gauge. I prefer a 1.5 inch needle, the longer needle. Standard medications that we use for all particular procedures, you calculate your max doses. You don't really require this much. 10 to 12 mils is usually sufficient for the entire ankle block, not more than around, say, 15 to 18 mLs. Now, what are the blocks that we commonly block? Just three major things, three major landmarks or three major nerves need to be remembered here. Posterior tibial nerve, it is the largest nerve in the ankle with sensory branches to the medial and the lateral plantar nerves in the foot. There is motor innervation to the intrinsic muscles of the foot as well. So how do you locate? You have the medial malleolus, you have the tendoachilles posteriorly, okay? Just behind the medial malleolus, you can feel the posterior tibial artery. The nerve is just lying posterior to the posterior tibial artery. That is it. So what I would do is at this level between the medial malleolus and the tendoachilles, palpate the posterior tibial artery, just go behind it, hit the tibia, withdraw the needle a little, a millimeter or two, and just inject, say, around 4 to 5 mils of local anesthetic. That is enough. Nothing more needs to be done. For those who have an ultrasound, it's prudent to go a little higher up, and same thing you will find. You will find the posterior tibial artery, go behind the artery. That's where you will find the posterior tibial nerve, and that's where you would inject. Now, why I'm adding the ultrasound images is you have to remember that when we are going distally, you have these in close proximity. So when you're trying to inject, it's quite possible that you might actually hit the vessels. Now, these vessels in these compromised patients are possibly mostly sclerosed or thrombosed, and it's easier to visualize on the top. That's the only thing. Coming to superficial peroneal nerve, this provides sensation to most of the dorsum of the foot that we saw, except for the lateral aspect of the great toe and the medial aspect of the second toe. So where would we go for the superficial peroneal nerve? This is where it is going to be. That's the superior peroneal nerve. So you have the lateral malleolus. So we just go, what I do is I simply go for the external hallucis longus. I shall show another picture later on. Find the extensor hallucis longus, locate the lateral malleolus, and you just inject subcutaneously in between these 2 points. Just a band, around this area is what is required to block the superficial peroneal nerve. Another, say, 3 to 4 mils, max 5 mils is usually enough. Ultrasound, you would again go a little higher up. Coming to the deep peroneal nerve, it's also known as the flip-flop nerve. It is a little deeper in the ankle, behind the extensor hallucis longus tendon. Now here, this looks a little difficult, but it is not. This is where you just ask the patient to dorsiflex the toe a little, Once the grade 2 is dorsiflexed, you will see the extensor hallucis longus and the anterior tibial tendon. This is the tibialis anterior tendon. And you have the extensor hallucis tendon over here. Locate the dorsalis pedis artery. And the nerve lies in between the dorsalis pedis and the extensor hallucis longus. So this is exactly where you're going to go at the level of the medial malleolus. This is exactly where I would inject. Now here again, with patients who have a compromised blood supply, it is very difficult to palpate the dorsalis pedis artery. So I try and go as close to the extensor hallucis longus tendon as possible. That again is a landmark based block. You do not need a needle or a PNS. For a PNS, you can go a little higher up, poke a PNS a little, maybe 2 centimeters above, and you will find it. But these are all landmark based blocks. So what we do is you go inside, hit the tibia, withdraw for a millimeter or 2, and inject about 5 mils of LA. Saphenous nerve. This is again somebody who had asked on the group about saphenous nerve. It provides sensation mainly to the arch of the foot. So where would I go in for that? You just give up raise a subcutaneous wheel between the anterior tibial tendon that we saw and the medial malleolus. So this is the point, or this is the area that I would like to inject my LA into. So this is like maybe another 2 to 3 mils over this area. Another point, if you're somebody had asked around the knee. So what you can do is you can just infiltrate around maybe around 5 mils about say medially, medial to the knee, about say 3 to 4 centimeters below the crease, the popliteal crease on the medial side of the knee. Sural nerve. Sensation to the lateral and the medial aspect of the foot. Okay, so how do we locate the sural nerve? This is the easiest of them all. You don't need to feel or palpate for anything. Locate the lateral malleolus, locate the tendoachilles over here, go to the midpoint. That is exactly where the sural nerve is going to lie. Hit the tibia, come back a bit. Once you hit the bone, come back 1 or 2 millimeters and inject your local. That is exactly where you need to put your needle into. What are the contraindications? Hardly any. There is intolerance, then you cannot use. And if there is localized infection. So you may have a surgery that is at the level of the ankle or maybe distal to the ankle. But because of the cellulitis and the edema, you may not be able to block these nerves around the ankle, in which case you need to find alternative approaches. Now, this is a pretty clear, clean-cut debridement that we had, mostly over the area of the superficial peroneal. And the ankle, if you see, it was pretty nice and very well marked. It was easy to give here again. I could feel the dorsalis pedis at this level. So I had made that marking, and medial to that was where I had gone with my local anesthetic. Again here, laterally, lateral malleolus, the calcaneum or the tendoachilles here, the midpoint was where I had gone for the sural nerve. This is another patient that we did just about 10 to 12 days back, came up with, actually had come for debridement of both the feet. This one, he had come for amputation of this particular digit. I would have probably gone with a block over here, but then we were not really sure about the extent. So we did give him a block, an ankle block. And this is how, see, it went as a ray amputation, they went pretty deep in. So it was good or prudent enough to block him at the ankle level. On this particular guy, yeah, this is, they planned a distal amputation, but they ended up doing a ray anyway. The whole digit along with the metatarsal, head of the metatarsal was taken out. This is how it looked at the end. Subsequently, this guy did turn up for amputation of this and these toes, the second and fourth toes as well, because he was really, really bad. He was in urosepsis as well. So it was very difficult infection to control. So here you can see both his limbs were involved. Okay, this is another, this is where your surgeon makes a fool out of you. He said just one nick on the medial side, there is a little bit of pus that is discharging on the, sorry, this is the lateral side, a little bit of pus discharge here. We will just take a couple of nicks and we will be done. And somehow when I palpated, it's a good practice to actually palpate the area of surgery. I realized that there was a lot of bogginess happening over here, and it really felt like pus, it didn't feel good. So I thought for this particular individual, I can go higher up and probably block the popliteal sciatic. But then when I went higher up there, it was completely covered with very bad fungal infection. And it was also, it was a weeping sort of an infection. So then I had to go higher up and do a sciatic plexus block for this particular person. See, this is all that was leaking. So he said, I'll just make a couple of nicks and it'll be done. Now, this particular guy had uncontrolled diabetes, he had hypertension, he had IHD, he was advised a CABG, decided not to go in for it. In the meanwhile, he became anuric, ended up with urosepsis, had to be dialyzed. They took him off for dialysis pre-operatively. He ended up with hypotension. He had to be transfused. So this is like, everything that could go wrong was going on in this patient. He was already on a lot of supports by the time he came in for surgery. So yeah, see, this is where, that one little nick that they were talking about, this nick kept getting extended. We went almost up to the knee in this patient. Just about, say, 2 centimeters below the knee was still where the pus had tracked up. This was after the debridement. And he said the procedure was over and then kept on extending it right up to the knee. This is another very interesting case that we did a few days back. I thank Dr. Tendulkar for sharing this case with me. This was another guy with multiple comorbidities who had come up for a simple IND, which turned out to be, partial calcinectomy had to be done, and a lot of bad bone had to be debrided around for here. This again was done in an ankle block. This is how it looked. Okay, so for that particular patient, which I did this block, the one with the amputated forefoot, this is exactly as how Dr. Shiv had described it. The point between the posterior superior iliac spine, the ischial tuberosity, mark the thing and go 6 centimeters below that, or I could have probably gone a little shorter. This is exactly where I found it, and it worked beautifully. So now the clinical pearls that I would like everybody to take home are: anesthesia to the posterior tibial nerve may cause a lot of a loss of sympathetic tone to the vascular supply of the foot. So there's a lot of vasodilatation. So in these patients who are, requiring dialysis, who are kept very dry, or who may be compromised, who are in the ICU, or who have a lot of fluid shifts and cannot tolerate any volume changes. Now, these are the guys who will not tolerate any amount of vasodilatation. So this particular, this can cause injuries. They're very injury prone, and they're absolutely intolerant of any kind of vascular stress. And also now these patients, we need to tell them, because they feel there is no pain, so they can, get up and move around. Now, these patients have to really take care of those numb areas. As Sir said, you can have analgesia for up to 18 to 24 hours. Now, these days in smaller nursing homes, they have a tendency to send the patient away faster because they don't want to stay more and pay more. So if you're thinking of take care surgeries, you need to actually tell these patients to take care, because you can end up with a lot of tripping post-operatively when you send them home and they come up with more difficult injuries later on. Always avoid re-injection into the same points. Take out the needle and go in somewhere else. Go in laterally. If you're having a blood in your aspirate, do not immediately inject again. And always, always, always aspirate before every injection. I shall be happy to take on any questions, and I thank you for your time.
Thank you, Preeti. You can stop sharing. And I think, again, a wonderful lecture with a lot of, I think, clinical cases, which actually make sense. And yeah. I don't know if there are any questions. Okay, yeah. What is the advantage of multiple injections at ankle or saphenous nerve block and posterior tibial nerve block?
What are the advantages of multiple? See,
multiple injections, yeah.
Now, most of these patients who come to us already have a lot of vascular neuropathies, so they're not going to feel the injections that you give them. Now, in babies, when I would be doing, or a young person, I would prefer to sedate or, quieten them first before I go in for the blocks. So then again, the problem of, pain at multiple injections is minimized. But yes, if I go distally, what we do is we inject at one particular point, and then we just move the needle. You withdraw it up to the skin and you move it a little bit and then inject at the next place. You're actually making the use of a single puncture to go at 3 different places. And, it's like fanning out. And you utilize your local anesthetic, the injection or the earlier injection to further your next function. So it's very difficult to sort of cause pain in this person or really cause complications. I mean, I literally tell my patients, I have to take a hammer and beat you up to, give you some pain. So it's quite simple. It's very simple. And anybody, for me, it was like my foot surgeon. He called me up one day and he said, "Okay, would you be interested in doing a series of ankle surgeries with me? And do you give ankle blocks?" And I was like, "Yeah, sure." And I had never seen one, forget give one. And then he said, "Okay, fine, we'll be doing 3 cases tomorrow morning." And for the life of me, I didn't know how I would survive the next day. But then I read up, I saw a lot of videos on YouTube and did everything. And then we've done over 500 surgeries together so far. And now he recommends me to all his friends as well. And earlier it was like, I would give a block and then I would pray to God. But now I give a block and I pray to God, and I also thank the GAS group for letting me learn so much on this forum and for making life easy for me. So I don't have to really go in for larger volumes or extra additives, or I'm very comfortable even in small nursing homes or resource poor nursing homes. All I need is a tube and some oxygen. I know I can block this patient. If not, there's always oxygen on hand that way.
So the actual answer to that is that the ankle blocks can be done by landmark technique. So if you have ultrasound, I can understand that you could actually just do it, or maybe with PNS. But somebody who hasn't got an access to ultrasound or PNS, they can still do ankle blocks. So that's where the answer lies. And to be frank, when I was only using PNS, I used to actually do, there is a video on the YouTube channel, my YouTube channel, with where these blocks can be done with PNS as well. And I used to love actually doing them with PNS. And I wouldn't go popliteal for that, because you need to lift the leg up and do that. All that positioning is not required. But when I started using ultrasound, I now don't do much of ankle block unless I actually have to teach my juniors. So still teach juniors to actually do ankle blocks. And even there, I say that I think with ultrasound, one single block at popliteal sciatic is, I think, enough. And all you need to do is then supplement with the saphenous.
Yes.
So the answer is okay for ultrasound, but this is not a workshop for ultrasound. This is for the landmark technique and for PNS. So it makes sense to use, landmark technique and PNS multiple injections rather than a single injection.
It's one of the simplest blocks to give, sir. There's not really, you're not encountering a lot of vasculature. So there's, it's impossible to go intravascular unless you really try for it. And you don't really require a lot of infrastructure. So in small nursing homes, it works really well.
Also
even the onset of blockade, I think, sorry.
Yeah,
I think
one
of the things which you actually have to realize is the onset of blockade with your ankle block. It's a much simpler block as compared to if you try to go for a sciatic block and you have to wait. I mean, sciatic is probably one of the thickest nerves, and we know with the ultrasound where you actually, it's not just injecting outside, you have to be in the perineurium, and there are things there, and it takes time to act because it's a huge fat nerve as compared to a peripheral block. So I think even the duration wise, and it's a very simple block to do with a landmark and a PNS guided technique. But she was absolutely right. When I used to do that previously, I used to be so happy. Even with the wrist blocks, I mean, it is something we didn't cover, but it's a very, very quick block, and a lot of surgeons actually use it for minor surgeries. So I think it does definitely have a role, especially in the kind of setting and the kind of conference we are talking about today.
And now, like again, I need to tell you that the distal surgery, distal blocks act quicker, act better. Okay, so that's where the ankle blocks actually comes in. And I can tell you with 100% guarantee that if you are using popliteal sciatic for the ankle surgery or around it, you need to give at least 20 minutes to 30 minutes before you can actually put an incision on a patient. If
Absolutely.
you got time, all the time in the world, that's fine. You do it. Otherwise, just go for ankle blocks.
It would be an absolute overkill for really these, tiny surgeries that have to do with, small fractures and small debridements. It's only when, your conscience tells you that this is going to be a big abscess and it's going to keep tracking up and, you never know the upper extent, especially in a diabetic patient. So what I generally do is I get the whole limb, the lower, from the shin downwards, I get it surgically scrubbed. I wash up myself and the surgeon washes up immediately after me. By the time he's donned his gloves, patient is ready for incision. So it's that quick. It's really very fast.
Yeah. So I'll likely give an example of where your popliteal likely works or has to be. So during the COVID time, we had a patient, diabetic patient who had was COVID positive, was on oxygen, was breathless, and they called me to see this. A patient actually had a foot abscess, and they say, "Oh, can you do this?" And patient was big as well, and he was really sick. This patient was really sick, and I gave a popliteal sciatic block. And the surgeons, they started debribing, and then they went from the foot, they went to mid-tarsal, and then they came to the ankle, and they ended up doing him a modified SIMS on him. And that was not enough, but there was still pus pouring out, and I was actually so glad that actually I ended up doing a popliteal sciatic in that patient rather than trying to go for an ankle block, which would have been impossible actually. Looking at his, when you have fluid and edema, it's difficult to actually see the structures even on the ultrasound. It's not very, very easy to do that. So in some places there is a role for it, and but like you said, if you got patients with smaller surgeries, foot, the ankle block, I think they work. And Dilip had asked, I say, "Oh, and does PNS?" 100% PNS works. You can, so the motor blocks you can do with PNS is your posterior tibial, you can do deep peroneal, superficial peroneal. The sural and saphenous are purely sensory, but superficial, deep peroneal are motor, and posterior tibial is motor, and you see the responses. There is a video, a good video on the YouTube, which I have posted with that, and they work really well.
So I think there's one more question from Vikas, which actually is generally not about ankle block, but generally I think is a very interesting question. Is like, do you really sedate patients before you give your block?
No, not at all. Mostly they do not require, but then you do have a class of patients who want to be sedated even before you've taken an IV line. So in that class, probably I would like to give them a little bit of angiolysis before I put in the needle. And it's always informed. You will feel a needle prick at this particular point in time, but I promise you this will be the last. So every time I prick, I promise them that this is going to be the last, and I prick at 3 different places. And usually my block is covered in those 3 shots.
I think it's very important to realize in regional anesthesia that your block is as good as your patient is. Yeah. I find that people find that if I give something, a little bit of propofol or something, I have failed. You have not. Okay. It is the patient and the patient comfort, because if you actually want to do a case successfully under a regional procedure, you require the cooperation of the patient. Now, if the cooperation of the patient means having to give a little bit of anxiolysis and sedation, then I think you should actually do it. Because with every block, even when we, like if I do awake shoulders, I know that even if it's an arthroscopic procedure, when they start going towards the ACJ, you always invariably have to give a little bit of alfentanil because of the innervation of the ACJ. So there's nothing wrong in doing it. So if a patient says, "Oh, I want yeah, I know I want a little bit of sedation, just give it, because it makes giving the block so easy. So it's not a blanket rule. So what I'm trying to say is that it's not a blanket rule that do you have to give sedation for all patients? No. But do you not give sedation for all patients? Again, that cannot be a blanket rule. It really depends on the patient. And I think I have always thought that if I want to make my regional anesthesia successful, I really need the cooperation of the patient. And if it is, albeit give a little bit of sedation, then so be it. Shiv had some opinion there.
So I actually do these procedures in the clinic, orthopedic clinic, where I do popliteal sciatic femoral with ultrasound, and the needle I use 100mm needle for all, and I don't use any not even local infiltration for the block. And yesterday I had a patient, a young patient, 30s. Patient with mental health issues, but well controlled on things, and like she was anxious. And when I did think, they say, "Whoa, I didn't even feel that." So I think we overdo sedation. I think we are just playing into that. That anxiety is there in the patient, but you explain to them, and they're fine. It's I'm actually amazed at what they. And then I have there is another group of patients. Where like the patients who are on opioids, or who are, have abused drugs, or smoke cannabis and stuff. And these guys will actually have the procedure, no problem, work well. And when you ask them, would you have it again? They say, no, please put me to sleep. Because they love that part of the thing. It's got nothing to do with block. It's got to do with what they actually love. They enjoy the effect of the drugs we use for them. So you see, either you're right, it's a spectrum of patients. But if you got normal spectrum, which is actually, these are skewed, actually, these are on the either side. But most patients do not require any sedation, and they do not require any kind of local anesthetic, even in the skin. One puncture, you're done. And I tell them this is actually less painful. Your flu jab is probably more painful, or COVID jab is more painful than the injection they have. And they understand that very well. They also understand that if you have had dental work done with local, that's how it's going to feel. They understand that as well very well. Yeah, the dentists don't use any sedation. They don't use anything other than just things. So why would you require for your regional anesthesia block? So same concept, all good.
Pramod, you wanted to say something?
In Indian scenario, I wanted to, sorry.
Yeah, go on.
Yeah, in Indian scenario, we may need the cooperation of the surgeons also for giving these blocks. That is more important. Not only patient. Yeah.
Yeah. No, I think it's interesting part. I don't think so there's ever going to be a consensus on this. And there are some areas in medicine where I think having different opinions is probably really good, because that makes you actually more patient-led. I mean, I think we have gone from that concept, and I very strongly believe the concept should always be patient-oriented. It can't be one blanket rule fits all. Look at what your patient does, look what your patient wants, make it very patient-specific and patient-oriented. Shiv, you wanted to say something?
Yeah, so I think one of the other things is the patient comes in contact with the surgeon more than us. So if the surgeon actually has primed the patient for a block or for everything, it's much more easier for us than we trying to actually explain to them. So when they come from the surgeon side and say, oh, patient says, oh, my such and such said that, oh, I can have that. It's so much easier for us.
Yes, always.
Okay, so in the interest of time and the program, we'll move on to our next lecture. And unfortunately, it's for Shiv, it's going to be Shiv again. And Shiv is going to talk to us about the posterior blocks for the spine. So Shiv,
nobody wanted to actually take up the challenge of actually doing this lecture. So I will actually be doing this one, and I won't take very long for this.
Thank you.
Yeah, it is interesting, but also, okay. So surgeries on the spine and the scapula. So we're looking at the back part of your trunk and the surgeries on that. We'll start off with block for spine surgeries, balancing act. So if you look at the nerve supply to the your spine, we have the dorsal ramus, which supplies most of the part, which was are involved in the spine surgery. So you're looking at laminectomies or trying to get to the disc. Now the area the surgeon is going to go through, and that is supplied by the branches from the dorsal root, the medial branch, okay, or the branches to the facet joint. But there could also be branches from the ventral, like your disc branches, sinovertebral nerves, which need to block if you are, doing a discectomy and other surgeries. But the commonest part of anesthesia for spine surgeries are by local infiltration and of surgeon, done by the surgeons. And most people say that it works quite well. And that's because it's probably the pain from the back, even though it's a back pain is very common, we say that. But I think the number of receptors and the triggers from the back are not as bad as you get from your joints. So patients tend to, do well with just local infiltration. But surgeons can also do other things if you're worried about. They can put in a direct intrathecal opioids. They open the dura. They can or inject into the, CSF directly and put intrathecal opioids. That's also used quite a lot. Or patients, they could actually leave a catheter in, epidural catheter, which you can use it post-op. But now, if you were to actually do a blocks, as we all love doing blocks, what blocks would you do for spine surgery? And one of the blocks, and I tell this very proudly, that even before erector spinal block was described, we were using it. But the reason why I didn't publish it because of the various reasons, the outcomes, and I'll talk about that in a minute. So erector spinal block in thoracic region, everybody knows. They do it mostly with ultrasound. But we have been doing this over the years. We do thoracic paravertebral block. So it's easy as that. It is just one step before you come out and angle your needle caudally into the paravertebral space. So just hit the transverse process, inject local anesthetic there, 20, 30 mLs, and that is that. I've already discussed about erector spinae in my previous lecture. Now, what about the erector spinae in the lumbar region? Okay, and that was a question which Dheeraj was asking. Is it any different, or rather, that was asked before? Is there a difference between thoracic and a lumbar? And the answer is yes. Now we know the way erector spinae block works in thoracic region is that we have the costotransverse foramen, and through which local anesthetic seeps through it and blocks the ventral rama. But it's seen that in the lumbar region, we don't know whether the local anesthetic is seeped through some of this foramen, intervertebral foramen, and block the ventral rami. But what is for sure is that it does block the dorsal rami. And again, we've seen in the thoracic region, you need to be 3 centimeters, 2.5 to 3 centimeters lateral to it. But in the lumbar region, you need to be slightly away from it. So you need to be at least 4 centimeters, or you can use the landmark, which are described for the lumbar plexus block, where you have 3 lines, one going through the spine, another going through the parallel to that, through the posterior spine. And then you go 1 centimeter or so above or below so that you hit the transverse process and inject local anesthetic there. So yes, you can do a erector spinal block in the lumbar region. But again, I do not know how the spread is across. But on the ultrasound, we've seen it does spread. So you can, go at L4 level and inject local anesthetic and hope that it'll spread at least 2 segments below 2 segments, just like you have for the thoracic erector spinal block. So can it be done for spine? Yes, it can be done. And then you can always combine, when you do a surgery like that on spine, which goes for long hours, you can give erectospinal block at the beginning, and you can in the end ask the surgeon to do local infiltration. So use both modalities and you will have a pain-free patient. And so I was talking about my experience with erectospinal block. What I have seen is that patients who come with chronic pain for spine surgeries, erectospinal block intraoperatively, absolutely wonderful. You'll get a straight line in your vitals. Post-op, patient will, he says, they're wonderful. I didn't need to give anything. But when the patient wakes up, they'll wake up with pain. This just shows that there has been a winding phenomena and the pain is actually in the brain, not at the site. That's what chronic pain is. So chronic pain, erectospinal block is not going to work as effectively for surgery as you would think. Okay. And this is just showing that what will be the depth of the needle. I've shown this in the other lecture. So depth will depend on the amount of fat which is there at the back, and it can be as deep as 8 centimeters in slightly obese patients. As spread in thoracic tree has been shown that it is 2 segments above and below the point of injection. And there has been studies where there's looked at 10 mLs, 30 mLs versus 20 mLs. And the difference between 30 and 20 mLs is not there. So it's no point using larger volume. 20 mLs will cover 3 to 4 vertebral levels. And so volume greater than 20 mLs have got no advantage. So if you're going to do erectospinal, does do it with 20 mLs. And if you have to go more segments, then do a multiple level. Multiple levels have been shown to work better with both erectospinal as well as with thoracic paravertebral blocks. So coming to the scapula, the scapular fractures are not that common, but you can get some cases of fusion. Scapulothoracic fusions are done in certain cases. So these are the surgeries which you will actually face there. And we have to think of dermatomes and myotomes. And I will come to that when you understand what the nerve supply or the myotome or osteotome involved, and then you know why I'm talking about combining erectospinal block. Now, if you look at the nerves, the dermatomes, so you're looking at the dermatomes at the back where the incision is given, and that is usually in the thoracic level, so T1, T5, T7. Okay, so that's where you're going to actually see that. And you need to know the landmark. The most prominent vertebrae is the C7, vertebral prominence, and the spine is at T3, and the inferior angle is at T7. So from there, you can calculate where you are at the level. So osteotome and myotomes. So if you look at the 2 nerves which are important for scapular surgery are the dorsal scapular nerve and the suprascapular nerve. Dheeraj has already described the suprascapular nerve block in his lecture, but I will just recreate it. So the landmarks are the spine of the scapula. So you mark the spine of the scapula, take the midpoint of it, then you go 2 centimeters cranially and 2 centimeters medially. And then you need to introduce the angle at this point, going towards the head of your humerus, going at around 45 degrees, okay, in the coronal plane, so that you go and seek the nerve where it lies in the inferior the groove and over the transverse ligament. Sometimes you can feel the pop through the transverse ligament, but that's not necessary. You can use a nerve stimulator and you will see the stimulation. So if you look at the nerves which are supplied by the suprascapular, you see supraspinatus, infraspinatus. Now these nerves, you will see the twitching of the nerves. Okay. And the other nerve, which is a dorsal scapular nerve, which supplies the your dorsals, what do you call levator scapulae and the rhomboids. And there is not much literature on how you block this nerve, dorsal scapular nerve, because with ultrasound it's fine. So you can use the interscalene. I'll come to that in a minute. So dorsal scapular nerve is a branch from C4 mostly, C4, C5, and it goes posteriorly through the your scalenus medius. There is only one article a long back ago published in Anesthesiology where they had used dorsal scapular block as a landmark technique. So dorsal scapular nerve, you will see here. Let me actually get the pointer, laser pointer. Yeah. So that is your triangle there formed by the posterior border of sternocleidomastoid, then the trapezius, and you got the levator scapulae, and you got the scalenus medius. And if you look at this triangle, the dorsal scapular nerve does pierce the scalenus medius. So what they described is that you look at a triangle, so you've got two borders, then at C5 level, okay, so you can actually mark, you can go from marking C7, which you easily felt, go 2 segments about, draw a line from there. And then you go almost at midpoint between the anterior border of the your trapezius and posterior border of the sternocleidomastoid at that point, and you point the needle. So it is needle is going posteriorly, it is going deeper and slightly medial, and try to get a twitch from the dorsal scapula, so which will stimulate your levator scapulae and the rhomboids, and you see similar to as shrugging of shoulder, as similar response as you see with the accessory spinal. But why go to that extent? Because we don't know. There's not a precise point where you can actually seek this nerve. So why don't we just use a interscalene block with low volume? So you go and inject local anesthetic, just 5 mL or so at interscalene level, and that will catch the dorsal scapular nerve. And suprascapular also comes from C4, C5. So your dorsal scapular nerve, the suprascapular nerve, both will be blocked with low volume interscalene block. And then you do a erector spinal block at probably at around T3, T4 level, and that will cover the incision. So speak to the surgeon, look at where the incision is going to be, and accordingly do a erector spinal block. So that would be my choice. And that is what I do. I do an interscalene and do a rectus spinal block for these patients for scapular surgery. I've done few of the scapulohumeral fusions, and they work quite well for these patients. And thank you. Hope this was short and sweet, and I'm happy to take any questions.
We're just waiting to see if there are any questions there.
It's not a common, I think people do spine surgeries, and a lot of times I've found that most people are happy with local infiltration, happy with the surgeons putting some amount of opioids, intrathecally. I just give a bit of morphine to the surgeon and they'll put intrathecally, which works quite well.
So what about epidural catheters which are placed? Have you seen this epidural, some of the surgeons actually, when they do the surgery, especially if they're doing sort of major surgeries, and then they place epidural under vision and come out. Does that work?
It can work, but we also have surgeons who are actually say that I put a metal work there, I don't want any infusion. So, they will just say local infiltration there. And that way, I think I've seen few cases long ago, but I think that stopped completely because I think putting morphine intrathecally probably works far better. And even if you don't have preservative-free morphine, maybe a bit of fentanyl or a bit of chlorine, those kind of things probably give a good analgesia. And you remember I was talking about how my erector spinal blocks didn't work in chronic pain, and I was in Delhi. So I had patients who came for metastatic, spine surgeries with metal work throughout, worked beautiful in them. patients who had trauma, acute fixation worked beautifully in them. But patients who had chronic pain, I was like, why is it not working? And you realize, well, it is all central. So when you probably put opioids into the CSF, it probably works because there is some amount of effect which is in the higher, not only supraspinal level locally. So chronic pain wise, it might be actually better than just doing erectrospinal block in them.
Yeah, because you're right. Most of the circuits are actually in the spine, in the spinal cord, they say, isn't it?
Yeah.
Where these are recurrent circuits which occur, and probably that's why it's. So, any recommendation on the dose of morphine for like segmental, or you just use like normally what you'd use for a, so maybe 100, 200 mics or
100, 200 mics is enough. So we would actually, if we tend to actually use diamorphin. And so we would use a 500 micrograms of diamorphin. It comes in a sterilized syringe for us. Just give it to the surgeon and you actually put it. Spines have actually moved out from our center now. They have moved to the thing. We used to do some very complex work, but that's moved out. So I don't do any more spines, but that's what I would do. I would just take 500 micrograms of diamorphin, ask them to put it in there. We didn't have preservative-free morphine, so we didn't use morphine.
yeah. I think we have got some national shortages, so the morphine of diamorphine, so morphine actually
Diamorphin.
came. So I think
No, ours
probably
is
that's-
because the pharmacy makes it so 10 milligrams you can actually make 20 syringes of diamorphin.
okay.
Yeah, it is made by pharmacy, sterile, so everything is good.
So I think there is one question from Dr. Banushali, says how
Yeah.
to convince surgeon regarding giving ESP block after induction.
You don't have to convince, you just give it. It's not the surgeon who decides about a block. It is between you and patient. Okay, so I think I understand what the problem is. So the problem is that if you have to do a erectospinal block, it's going to take time. You need to have the patient on the side. So there are two ways to actually circumvent that. One is that you can actually do erectospinal block before induction of anesthesia. You get the drip in, ask the patient to sit, and I'll tell you, the patient, you don't need to give any local, just they will tolerate it quite well. Injection in the backs are tolerated very easily. Okay, just do them. One of my friends does it for breast surgeries. He doesn't do it. He just get the patient to sit up while they're putting the ECG dots. He goes behind and actually give the erectospinal block awake. The other way of doing them is that sometimes I do that. You have one side surgery. I tend to, this is not intubation, just using supraglottic airway. I have the patient on the side on which I have to block. If we going to have it on the left side, the patient is down to the right side. I put them to sleep on the side, put the iGel in, do the block, and just flip them over. Okay, so it doesn't take much time. But if you are actually having to put the patient to sleep and turn on the side, and then surgeon say, you're eating away my surgical time. So that's how the surgeon will. So you have to find your own ways of doing it. And it's the patient who decides whether he's happy to have the block or not the surgeon.
So anyone, I can't see any more questions. If there is no more question, I think the next session is actually lunch.
Yeah. So you say, Dilip, say you haven't covered RLB. What are RLB? And MTP.
QLB, is it? No, RLB.
RLB MTV.
MTP block. I don't know.
Retrolaminar block.
Or retrolaminar block.
And what is MTP?
Mid transverse process block.
Do you need to?
I guess it's just a millimeter.
It is one of those, like I said, like red clavicular raise and that block. No, either. I think the standard is still thoracic paravertebral block. Okay, and then we can say that next would be erectospinal block. And there's another block which has been described now, which is in between the thoracic paravertebral and erectospinal block. You go a little bit in. I think that's what most people have been doing till now. it didn't matter when people were doing this blind block. Well, shouldn't be called blind. It's called landmark guided block. I think people never went into the paravertebral block completely. They were actually in between the erector spinae and the paravertebral, or some probably were already in erector spinae space, okay, because they were afraid to get the local anesthetic till the paravertebral block. So this is just a different way. I wouldn't. So erector spinal block or paravertebral block, that's all you need to learn. As long as you can do these two, you're fine with back surgeries or covering those areas.
It's like there is a river which runs from
Yeah.
point A to point B.
Yeah.
Okay. Between point A and point B, the villagers go, and each different village sees the river and says, "Oh, I will name this river." And this is
Yeah.
what is happening basically. With the ultrasound, you had a couple of blocks which were already there. Some person goes and finds with the ultrasound, there is one plane they can go and they actually name it. So I think as with everything, you just have to be a master of a couple of blocks which you need in that area. And I think rest you can name whatever it is. I think we had this discussion in Bangalore too with Shiv. I mean, we were seeing so many approaches you can actually go from, even for your brachial plexus, from your neck to your arm, and you can actually name it after yourself. It's just I think
it will still be
the same thing.
like a river will be a river. It won't be like you can name it anything, or road will be a road. And same thing, brachial plexus block will be a block. Whether you do it will be a proximal, sort of intermediate, and distal blocks. That's what it is. In between, you can put local anesthetic anywhere. You can put local anesthetic between the proximal and the intermediate, between intermediate and distal blocks. Anywhere you put, you can give it any name you like. So, but ultimately,
So there are a couple of questions. One question is that if we have given ESP block pre-op and surgeon lifts the muscle during the surgery, will it cause the drug to lose from our area of interest? So I think what they're saying is that if the drug is in between the plane and if they lift the muscle, will you lose the drug?
It's possible in the thoracic region.
Okay.
Like I said, in the your back surgeries, the advantage we have for giving the blocks and things is that by the time you give the block and the surgery starts, because patient is prone and then scrub and this and that, there's usually time when there is some amount of drug which is fixed. And for the back surgeries, you need to block the dorsal root, which is blocked in erector spinae anyway. But if you're giving erector spinae for a ventral root, then you need time. And that's why it works for back surgeries. You don't lose as much. You have already blocked the dorsal root, which supplies the muscle, so it works. You don't lose anything.
Okay. So I mean, I think there are few comments rather than, I can't see any other questions there. So most of them are comments. So will for abdominal surgeries, like I think we're covering abdominal surgeries later. So I think that's a separate
we
talk.
have
So we'll cover
abdominal
it at
surgery
that
later
time.
on this.
So Shiv, what do you want to do? Do you want to break for lunch now? And
People can actually have tea, and if people want to discuss or ask questions, we can continue. Those who wants to have tea can have a tea break, and then.
So maybe in another 15-20 minutes.
How are we
we'll
with the
look to,
time?
So time is good. I think the next lecture was supposed to start in half an hour, but I think if people are not very fussed about it, I think it's more like if people want to have a break or something, a comfort break and a coffee and stuff like that. Next 15 minutes they can have, and then in 15 minutes we can start with the next lecture. So that'll be okay.
Yeah. So we next lecture would be on your Minoti is doing that.
Yeah, Minute is doing the next
Minute
lecture. It's on post. So and then we can talk a little bit of fractures and stuff like that. Sorry.
And then we got abdominal and the segmental before we. I think it's been going very well. I think till now, I think people have been interacting and then finding it useful. We're happy to take any questions before we start the next session, if there is any.
Shiv.
Yeah.
If a patient is coming for maybe multiple surgeries.
Yeah.
After how much time we can repeat the same block?
Yeah. So now this question is actually commonly asked. Again, it's also asked where we have given a block and then surgeons
give an
want to use local in there. How do you actually decide and what you decide? So the answer to is actually very, very simple. Now, you know the half-life of the drug. And half-life of the drug is actually a very specific and it's very well defined. Right. So, for example, the half-life of the bupivacaine, levobupivacaine is 90 minutes.
Okay.
Right. So, in 90 minutes, half of the drug is metabolized. Then it is exponential decline, isn't it?
Correct.
The half of that goes. So, after your the half-life, you can actually say that, okay, fine, you can use half the amount of dose. You do not know when, there'll be still, it'll take hours for when a small amount of that. That's why when you give a block, you can get analgesia just with local anesthetic. We talk about prolongation of analgesia from using dexamethasone and things like that. I had my block just with levobupivacaine. I had analgesia for 18 to 24 hours. Okay. And that's because the amount of drug which is there, there's little amount probably just remains, and that's probably enough there. But coming to your question, half dose after half-life. I think easy to remember, half dose after half-life, use that and you're fine.
Oh, yeah.
Would it make a difference if there is an infusion going on, like an epidural infusion or infusion of a local anesthetic? Because then your concentration is like quite a steady state concentration after a
You are a
couple of
steady
hours,
state,
right?
yeah. That's difficult. I think with single shots, it's easy to answer that question, but with infusion, you're having infusion, then
Yeah.
I think you have to actually think of that, what would be the total amount of dose used from the bag. But then again, we are using very low concentration. When using infusion like epidurals is 0.125%. And then you can look at that in how many hours you have used, but then you won't know, well, how much would you metabolize, how much is working. It's a, and then you're also using the drug more centrally at the epidural level and spinal level. So I think that's, again, very small dose and things. And then for infiltration, again, you can use lower concentration. You don't actually have to use higher concentration for infiltration.
Yeah.
Yeah. So I think the answer remains is when you have used a single shot and you want to say, for example, the surgeon wants to need to infiltrate because you didn't get a good response from the, say, skin side.
Yeah.
And if the surgery has been more than 90 minutes or so, you just say, okay, use half the dose, 0.25%. And then you'll be able to have enough drug for local infiltration.
Thankfully, last is not seen as commonly, it's just a site where you actually go, isn't it? Unless you are injected something intravascularly or you've injected something very close to the pleural sites and there is pleural absorption. It is thankfully not as common. Hopefully, that's what I'm thinking.
No, very interesting. I think when tab block was becoming very popular this year, looking at 2008, 2007, 2008, and around that time, there was a study done by a Japanese group. They wanted to look at bupivacaine plasma levels after tab blocks. And they were finding that the levels were above the toxic limits with no symptoms at all. So absorption happens. It's not, because I think it is a total dose which actually goes into the vessel, which goes and causes the effect. So you can actually have a much higher levels as compared to what you think is the safe level, but have no effects at all.
And that is why adrenalized lignocaine actually has got, the toxic dose increases massively, right?
Yeah.
The amount you can give is massive because you're basically vasoconstricting the vessels and the absorption from the vessel is minimal. That is why you see such a difference, isn't it? From 3 to 4 milligrams per kg, it goes to around 7 mg per kg. So
for where they use for tumescent anesthesia, the doses are massive. I mean, they go up to 30, 40 milligram per kg body weight. So that's dilute, and plus they're, I think, sucking out some of them. So the doses used are much, much higher when they are using it. But you're right. I mean, with if you're looking at using lignocaine with adrenaline as a single, and I think one question asked again, I think need to clarify that as well about bupivacaine with adrenaline.
Yeah.
Yes, it is available. We have 0.25% with adrenaline, and some surgeons like to use it, but it does not actually increase. Unlike where with adrenaline, we go from the dose increases to 7.3 to 7 milligram per kg body weight. It does not increase. So you can't say that now I can use bupivacaine of 7 milligram per kg instead of 2 milligram per kg. The toxic dose doesn't actually is not affected by the adrenaline one. Second thing is that bupivacaine actually is a vasodilator. And the effect of adrenaline in that is not as effective. And that's why the dose hasn't increased. They did not find that it was causing much of vasoconstriction. And that's why it is not a popularly used local anesthetic. So even if you use with adrenaline, you still need to use 2 milligram per kg dose, no more than that.
Yeah, I
Vikas.
just wanted to ask, yeah.
Dr. Vikas, yeah.
Hi. In our parts of the country, most of the pre-surgical fitness comes from physicians or cardiologists. And what they do is at the first hint of hypertension, a little and occasional ectopic, they would always say, no adrenaline in at any cost. And then that is considered to be a legal dictum. So
Yeah.
in most of these parts of the country, we have almost stopped using adrenaline.
You don't need to. Like
Yeah,
I already said, it doesn't make any difference. You can use 0.5% whatever bupivacaine or ropivacaine, and that the onset is similar, and it is duration is much better. Duration of analgesia is far better. So
Yes,
I think there is no such role as such of using lignocaine with adrenaline.
so the benefits outweigh the risks.
Absolutely, yeah.
Thank you.
I mean, you don't want to get into a tangle where, things can happen which are not associated or linked to what you're doing, and then they'll try to easily blame you for that. Why take that? You say, okay, fine. You don't want us to use, okay, we won't use, we got better drugs.
Okay.
You say, what will you do if the patient develops anaphylaxis? We're going to use adrenaline.
Yeah.
So I think they don't have the concept of what exactly adrenaline and things. So they think that, but also maybe they are still not updated because halothane and adrenaline absorption arrhythmias are very common. They probably still think we're using halothane. But some places might still be using it. In India, we can't say. So maybe they're right in that. But in Western culture, where the halothane is completely gone out of use, it's got no. But in India, still some places might be still be using halothane.
Thank you.
So we have a little break then.
I think so. Yeah.
Yeah. So what time are we coming back?
It's 5:40 here. So would 6 be a good time or before that?
I think we can come before that. I think
Okay.
we were just chatting, but rest of the people probably have had.
Okay.
Yeah.
So then 10 minutes?
Maybe
Yeah,
10
10 minutes
minutes.
will be fine. Yeah, 10 minutes should be okay. Yeah.
Okay.
Are you seeing the screen?
Oh, whose screen is that? Sorry.
Mike's Minoti. Yeah, Minati, it's visible.
Sorry,
Okay.
sorry. Hierarchy. Yes.
I'll stop sharing now. Start later.
Sorry, ma, you can leave it on. We
Okay.
can just say the next lecture due in 10 minutes.
Okay, fine, no problem.
Yeah. And you can start straight away from there.
Sure.
Hi, Minati.
Hi.
You're all set?
Yeah. Should we start?
Yeah, so Shiv is there. I was just waiting. Okay, Shiv is there. So
Yeah. You
Okay.
can start. You can start.
Okay.
so
Yeah,
so I
can we
think yeah, so we'll start with the second session. I mean, just third session. This should be actually just post lunch. Everyone's had a little bit of break, so I'd like to invite Minoti to actually talk about blocks for surgery on the ribs, sternum, and the breast. So Minoti, the floor is all yours. Please carry on.
Yeah. Yeah. So I would like to thank RADS Mumbai 2023 and Dr. Shiv for giving me this opportunity to speak on this topic on blocks for surgery on the ribs, sternum, and breast. I have no conflicts of interest, and the credits to this material goes to HAZDAC, Regional Anesthesia and Acute Pain Management textbooks, NISORA, Internet access, and few journal articles. Hello, am I here?
Yes. Yeah, we can see your slide has changed. Thank you.
Okay, so let's understand the nerve supply of the chest wall. So the major nerve supply is from the spinal nerves that supplies the thoracic levels. It supplies individual dermatomes in the distribution which is shown. They continue as intercostal nerves that supply the sensory and the motor parts and innervates the intercostal muscles. The anterior chest wall is supplied by a number of other nerves. Medially, it is supplied by the medial branches of the intercostal nerve, laterally by the lateral branches of the intercostal nerve, superiorly by the supraclavicular nerves. And there are other nerves which also supply the anterior chest wall. They are mainly the medial and the lateral pectoral nerve, which are branches of the brachial plexus, long thoracic nerve and thoracodorsal nerve, which are again the branches of the brachial plexus. Intercostal brachial nerve is one more branch which supplies the anterior part of the chest wall. So there are a number of blocks which can be done to block different areas of the chest wall. So it starts from the, I can enumerate them, and it starts from the thoracic epidural anesthesia, which is a gold standard block which has been used for many decades. Then we come up to erectospinal block, the paravertebral block, intrapleural blocks, intercostal blocks, serratus anterior plane blocks, which can be superficial or deep, PEC 1 block, PEC 2 block, and anteriorly there are two blocks which can be used, which is transversus thoracic muscle plane block, and we have the pectoralis intercostal block. So talking about thoracic epidurals, we all have been using this block, and this topic would not be complete without making a mention of it. It has been used for I don't know how many decades to provide analgesia and anesthesia and for segmental pain reliefs. So basically it blocks the spinal nerve in the epidural canal and cuts off the nociceptive inputs to the intercostal from the intercostal nerves. It has been a gold standard method of analgesia management. The benefits being providing anesthesia, analgesia, it promotes ventilation and thus reduces the complication during the hospital stay, and thus decreasing the duration of the stay. But it has some contraindication in patients who are anticoagulated or who have coagulopathies. Even if you want to have a unilateral block, generally the blocks are bilaterally placed. There is incidence of hypotension because it blocks the sympathetic chain also. The next block we look at is thoracic paravertebral blocks. They mainly block the ventral and the dorsal rami and also the sympathetic chain. They have a longitudinal spread of distribution. They are indicated in thoracic surgeries, rib fractures, breast surgery, upper abdominal surgery, in post-herpetic neuralgias, and also in chronic pain due to mastectomies. They can be used for acute pain during herpes zoster. So these blocks can be given in different positions, like in sitting, lateral, or prone positions. So I'll explain you the procedure in sitting position. Patient sitting on the bed, leaning forward with both the arms on the side, with head flexed. You palpate for the spinous process starting from T1 downwards. The area of the interest of analgesia is to be marked out. Then parallel to this, we mark a parasagittal line, which is around 3 centimeters away from the midline. Corresponding point at the from the spinous process is marked on the parasagittal line. At this point, we perpendicularly we penetrate the needle perpendicular to the skin mark and advance the needle forwards till we hit the bony prominence. Once we hit the bony prominence, that is the landmark for the transverse process. We walk off the transverse process and then advance the needle around 1 centimeter. After advancing the needle, we may get a pop, which is due to the endothoracic fascia. After negative aspiration for blood and CSF, we can inject a local anesthetic volume of around 15 to 20 ml to block the thoracic vertebrae. So the dermatom which is used for blocking the 2 dermatomes above and 2 dermatomes below can be targeted with a single block. So if we want to block more number of segments, we need to decide which two dermatomes we need to block. Then is the erector spinae block. It basically blocks the dorsal rami more than the ventral rami. But as the volume of the local anesthetic injection is high enough, the ventral rami also get affected, and sometimes even the sympathetic chains. It also has a longitudinal spread. It is indicated mainly in analgesia for rib fractures, back surgeries, and chest wall surgeries. It also can be given in sitting position, lateral position, or prone position. Marking the spinous processes, and 2 centimeter lateral to that, we draw a sagittal line on which parallel to which the spinous process, we puncture the skin and advance the needle till the time we hit the bony prominence. Once we reach the bony prominence, the needle is withdrawn around 1 to 2 centimeter, confirmed for negative aspiration of blood or CSF, and then we can inject the local anesthetic volume of 15 to 20 ml. If the injection point is not proper, and if we advance the needle too much ahead, there are chances that we can puncture the pleura and cause pleural damage, lung parenchymal damage, or even pneumothorax. Going forward to the intercostal blocks, as the spinal nerve leaves from the intervertebral foramen and traverses the thoracic vertebral space, it runs forward along the ribs in the intercostal groove. Around 6 centimeters away from the spinous process, there is the angle of the rib where it gives off lateral cutaneous branch of the intercostal nerve. So this block can be done from anywhere proximal to the angle of the rib. So you decide, it generally gives a unilateral dermatomal band of analgesia. So decide onto the rib which is to be blocked. You inject local anesthetic at the level of puncturing the skin. Go perpendicular to it, and as you hit the rib, you aspirate for blood, and then advance your needle 2 centimeters ahead, caudally or cranially, and then inject the local anesthetic solution around 3 to 5 ml of the local anesthetic is required. Indications for this type of block is rib fractures, mastectomies, thoracotomies, and cholecystectomies. The disadvantage of this block is that it has to be given at multiple levels to get be used for surgical pain relief. Next is the PEC1 blocks, which are thoracic facial blocks. It blocks the medial and the lateral pectoral nerves. They are indicated in surgery of the superficial muscle layers, surgeries in which breast expanders are introduced, subpectoral prosthesis, and even in pacemakers. So for the PEC1 blocks, next is the PEC2 blocks. It is PEC2 blocks involves the PEC1 block plus the lateral cutaneous nerve blocks and the long thoracic nerve, which is blocked. Indication for this block is radical mastectomies, deep lumpectomies, sentinel lymph node, and axillary clearance block. Next is the serratus plane block, which is again a thoracic facial plane block. It blocks the lateral cutaneous branches of the intercostal nerve and the thoracodorsal nerve. It is indicated in breast surgeries, lateral thoracic procedures, latissimus dorsi, flap reconstruction surgeries, in chronic pain after mastectomies, rib fractures, thoracoscopies, and thoracotomies. So let us understand the landmarks of these three blocks. So these three blocks can be given anteriorly. The PEC1 block, you palpate the second intercostal space in the mid-clavicular line. You advance the needle, you puncture the needle at this side and advance it to perpendicularly down, and you will get one pop. This is the plane between the pectoralis major and the pectoralis minor. This is the place after negative aspiration, you can inject around 10 ml of the local anesthetic. As you advance, go to the next place in the fourth intercostal space, in between the mid axillary line, mid clavicular line, and the anterior axillary line. In the fourth intercostal space, if you go perpendicularly down, you will get two pops. At the second pop, this is the facial plane between the pectoralis minor and the serratus anterior muscle, where you can infiltrate around 20 ml of the local anesthetic. As you go down in the fifth intercostal space, at the anterior axillary line, when you go perpendicularly down, you can get the two pops, and this would be the plane between the serratus anterior muscle and the latissimus dorsal muscle. So all these three blocks can be utilized for mastectomy or any anterior chest wall surgeries. So in a breast surgery, when they aim for a lumpectomy, it is expected that the lateral cutaneous branch, that is the lateral half of the breast, the anterior cutaneous branch, that is the medial half of the breast, and the supraclavicular nerves, cutaneous innervation is being blocked. For sentinel lymph node biopsy, the intercostal brachial nerve needs to be blocked, which can be done, which supplies the axilla and the medial aspects of the upper arm. The intercostal brachial block and the lateral cutaneous can be blocked by the PEC2 blocks and the serratus plane block. When you aim for a modified radical mastectomy, both PEC1 and PEC2 blocks are required. And if there is axillary clearance, then serratus anterior plane block is also required. Next, we come to the parasternal blocks. Now, these are the anterior blocks near the sternal and the parasternal areas. This is mainly supplied by the anterior cutaneous nerve of the intercostal nerve. So there are two blocks which can be done at this area. One is the transversus thoracic muscle block, and another is the pectoral intercostal nerve block. So pectoral intercostal nerve block is done between the pectoralis major muscle and the intercostal muscle, internal intercostal muscle. So you go 2 centimeters away from the midline of the sternum and go 1 to 2 centimeter down, and you will get a facial plane where you can inject around 3 to 5 ml of the local anesthetic solution to block that particular dermatome. Similarly, in transversus thoracic muscle plane block, the same needle can be advanced ahead around 2 to 3 centimeters, and you would be between the transversus thoracic muscle and the internal intercostal muscle. Again, you can inject a volume of 3 to 5 ml. The disadvantage of this block is that you will have to give it at multiple levels. If it is a sternotomy procedure, then you will have to give it on both the sides of the surgery, both the sides of the sternum. So when in a sternotomy procedure, the areas to be, the blocks which can be used are the pectoral intercostal blocks or the erectospinal block bilaterally. When there is a, for minimal invasive surgeries, right anterior lateral thoracotomy incisions, we can give a PEC 1 plus a PEC 2 plus a pectoral intercostal blocks, or we can give a erectospinal block, which would be the right-sided block. And in minimal invasive right-sided thoracotomy procedures, PEC 2 plus serratus anterior block or erectospinal block, which can be given on one side, on the right side of the side of the body. In transapical transaortic valvular replacement, a serratus anterior plane block or a erectospinal block can be used unilaterally on the left side. So as in breast surgery, for rib fractures, we can use blocks to relieve the pain and for better post-operative outcome of the patient. The gold standard thoracic epidural analgesia can be used where you can block multiple levels with a single epidural catheter. Otherwise, we can use thoracic paravertebral blocks, which aims at around 3 to 4 segments at one given time. Erector spinal block, where you introduce a larger volume, will block a bigger segment of the thorax. Then intercostal block, which will block only one segment of the intercostal nerve, and a serratus anterior plane block. So just to summarize, thoracic paravertebral blocks the anterior and the posterior rami with the sympathetic change. It causes a dermatomal spread as well as the longitudinal spread. The volume of injection is around 15 to 20 ml. So if you have to block more segments, you may have to decide on to 2 levels at which you can give 2 blocks to increase the block height. Next is the erectospinal block, where it mostly blocks the posterior rami, but it can block the anterior rami and the sympathetic chain. It has more of a longitudinal spread of action. The volume of injection is around 20 to 30 ml. Intercostal nerve blocks, which affects the anterior rami, and they are dermatomal blocks. So around 3 to 5 ml is required per level of blockage. Next is the PEC 1 block, which blocks the medial and the lateral pectoral nerves. It blocks the pectoralis major and the minor, and around 10 ml of local anesthetic is required. PEC 2 blocks, which blocks the medial lateral pectoral nerves, lateral cutaneous nerves of the intercostal nerve, and the long thoracic nerve. The dermatomes involved are the axillary fossa, upper thoracic wall, medial side of the arm. So around it requires a block of around 10 for PEC 1 and 20 for PEC 2 blocks. So serratus anterior plane blocks, which blocks the thoraco-dorsalis nerve and the lateral cutaneous nerve of the intercostal nerve. It gives a blockage on the lateral quadrant of the chest, and it has a longitudinal spread. It requires around 20 to 30 ml of the local anesthetic. Then is the transversus thoracic block, which blocks the anterior cutaneous nerve of the intercostal nerve. It gives us dermatomal blockage of sternal and parasternal areas, and it is a dermatomal block. So around 3 to 5 ml is required per level. And last, the pectoral intercostal block, which again is a anterior cutaneous nerve block, which blocks the sternal and the parasternal area and has a dermatomal blockage. It requires around 3 to 5 ml per level. So we can use different, all 3 types of local anesthetics can be used, like ropivacaine, bupivacaine, or levobupivacaine for these blocks. Only thing is, when you're giving large volume blocks, you really need to calculate the dose of local anesthetics which are used. When you aim for analgesics, you can use a very low concentration of blocks, like around 0.2% for ropivacaine, or as low as 0.125% for levobupivacaine and bupivacaine. And if you aim for an anesthesia anesthetic block, then maybe you have to use a higher concentration of block of around 0.25% for bupivacaine and levobupivacaine, and around 0.5 to 0.75% of ropivacaine. So you meticulously need to calculate the doses of the drugs before giving these blocks. In truncal blocks, the absorption of the local anesthetic is the fastest, because there is a lot of vascularity. So there are chances of local anesthetic toxicity.
Thank you, Minoti. That was very good. Excellent. Well covered. You can stop sharing.
Yes.
I think you were a bit anxious, I think. But you did
No.
so well. You did so well. Yeah.
Actually, I had very little time to prepare for the whole thing. So
No, you did very well. And I can see that you have also edited and formatted your slides as well. And they were actually excellent.
thank you so
Both, I think, in delivery of lecture, I think you should do more lectures. You'll get better at it. Yeah.
Yes.
I think, yeah. Very, very well done. Dheeraj, over to you, man.
Yeah, so this is rib fracture is a topic which is very dear to me, because as an intensivist, if as a regional anesthetist, if I ask you, can you name a block which saves the life of the patient? There are 2 blocks you can say. Yeah, one you can say is a fascia iliaca block for a fracture neck of femur. The second one is fracture for rib. Blocks for rib fractures. Let me tell you, they literally save lives. Okay, and we see this in our intensive care time and time again. So as an anesthetist and as a regional anesthetist, if there is a block which actually can make difference in mortality, it is blocks for these 2 procedures. Now the thing is that rib fractures are more common than what you think they are. So you actually see rib fractures with sort of 4 to 8 per 10,000 patients. That at least is the number in the UK. And following the trauma protocols they have, many of these patients will have a CT scan, and you will actually pick up rib fractures which you never used to pick up before. Now, rib fractures basically are associated with pulmonary complications, associated with critical care admissions, and they are associated with mortality. If you actually give adequate and appropriate blocks, you will actually reduce all these. The chances of rib fracture having mortality is higher when you actually have rib fractures associated with pulmonary contusions below. That's why when you actually assess any patient with rib fractures, you have to make sure that you have looked at what the pattern of the injury is, how many levels are injured, whether there's a flail chest present or not, whether it's a unilateral or bilateral rib fracture, as well as you have to see whether there's an associated pulmonary contusion. Now, if you actually have associated pulmonary contusion, a lot of people put in chest drains. Now, this makes your life much easier because most of the blocks which you give, you are worried about, oh, will I cause a pneumothorax? In patients who already have a chest drain in, you can go ahead and you can't cause any further pneumothorax. So you should be brave and you should give blocks. For example, now thoracic epidural used to be a gold standard for a long time. The problem is that with thoracic epidural, you get bilateral blocks. And then many of these patients with trauma will start having a little bit of coagulation disorders. They have coagulopathy, and then you have problems with inserting the catheter in a thoracic space. And we have generally become wiser because there are a lot of studies which actually have looked at thoracic epidural very closely. And you would not believe that almost in 50% of the cases, sometimes what you think you're in the thoracic epidural space, you might not be there. And the chances of them being successful is also not as good as before. But now with ultrasound guided, I think people are saying that, thoracic epidurals and getting them in the right place is getting better. But paravertebral blocks work beautifully, and especially if you actually already have a chest drain in there, be brave, give a paravertebral block. It will really help. It's much better. Or you can give a poor man's paravertebral, which is an erector spinae block. Make sure that you actually know the level of the fractures and the volume which you give. The other thing about the serratus plane block, it has made, and this, I think I have actually learned this from this nerve block from Process, because previously I used to always think, my trainees used to say, oh, I don't have an ultrasound. What am I going to do with the serratus plane block? I used to think that don't worry about it, like go feel where the fracture is, feel that the rib, go hit the rib, just come outside and inject local. I mean, that's like giving a landmark guided block anywhere, and you rather than give the patient nothing, that works very, very effectively. But please be conscious about where the rib fracture is, okay? So if you find that you've got a rib fracture which is lateral or slightly posterolateral, don't start sticking serratus anterior, serratus plane block there, because frankly, it doesn't work. It's not very efficacious. There are many blocks which have been described for the rib fractures, but which block is effective? It's like when I read literature for a tennis elbow, where, for one particular condition, there are so many treatments available. So again, as we said, when we started this talk, that it's like the river, and, different people have started naming different blocks at different places. But learn a couple of blocks for rib fractures and do them, because I think it really make a difference. So I would just say, make a difference, save a life and just give a block in these patients. That's very important. So that's me, Shiv.
Very, very valid point. I think I posted about this case just a few weeks ago, where there was this patient who was on the ward with rib fracture, elderly patient. And he was constantly on oxygen, requiring more and more oxynorm. They put it on PCA, they put a lignocaine patch, nothing. And I was actually called to, this was during the nurses' strike, see if I can actually give a block. And I went to assess him, and this patient couldn't move. I said, well, this is impossible to do a ultrasound block, a guided block in him. I said, can you just hold on to the rail and turn around? And I looked at he had around 7 rib fractures. I said, I'll have to do just 2 injections for you. And that's it. It says, it's be like your flu jab. And I did it. And the patient by evening was off the, oxynorm PCA. He was sitting up. When I went to look, follow him up after 2-3 hours in the evening, he was sitting up, he was smiling. It makes such a sense. And within 24 or less than 24 hours, he was off the oxygen. So I think you don't need to have anything sophisticated. You don't need to at least have. I just took lignocaine. I took, bupivacaine, levobupivacaine, 2 syringes, 20 ml each, and the needle, 50 millimeter needle. That's all. So this is exactly what we want to actually convey here. Is a lot of things can be done just with a syringe with local anesthetic and a needle.
And the most important thing you notice is that when you actually start giving blocks to these patients, they go to sleep immediately. And the problem which occurs is that the amount of opioids which they are loaded with. I mean, by the
Yeah.
time I think you mentioned that, Shiv, isn't it? By the time, one of the successful thing about these blocks is by the time you're doing that block, they go off to they doze off by that time.
Exactly what happened. So I was actually telling this patient, so this patient is a retired dentist, and his wife was also there in the room. And I said, if this is going to work, you're going to doze off in front of me. I gave him the block. He turned back on the side. And I was just talking to him about, what you do, and he's talking, and he's actually in between, his eyes was actually going, he's just dozing off. I said, that's where it is working. So I left him, went and did I said, I'll come back after 2-3 hours and see. When I came back, he was sitting and having his tea. He had cake and whatnot, and was like a totally different man than what I saw him in the morning. So it makes a huge difference with simple blocks, which can be done anywhere. I don't know why the intensive care or any doctors can't do that. That's why I actually shared it on the Twitter as well. I don't know whether people have seen it or not, but I had made a infographic and posted that you can do it with just a needle and a block. The syringe full of local anesthetic. So something very useful.
What's your opinion about catheters and single shots in these patients?
No, single shot. The catheters don't remain. You need to. I had put catheter in few patients in the intensive care, and then they come back within 24 hours. They come back and say, "Oh, it has got pulled out." But a patient actually are moving, around. However you fix them, they get pulled out, and you can't leave much of it in the space as well. So our experience with catheters, erectospinal catheters in these kind of patients has not been very good. Whereas like single shot, you break the cycle of pain and they're fine.
What about this, intrapleural catheters? There used to be a time when they were very popular. I don't know if you remember. So they actually used to put in intrapleural catheters, or they used to probably give intrapleural local anesthetic.
And that's why I say, why are you afraid of thoracic paravertebral block? That's why I say to people, worse come worse, you will do intrapleural analgesia with the thing and it works really well. So don't be afraid of doing a thoracic paravertebral block, which is a gold standard actually.
Yeah.
After epidurals, next is thoracic paravertebral block. The thing is, people find it slightly difficult to get into the space, the way it is angled. So that's probably the reason. But even if you're doing the landmark guided, I mean, there's nothing wrong in trying to go beyond the erectospinae and angle the needle more caudally by 1 to 1.5 centimeters or so, and fine. Yeah, I think spending too much time into rib fractures and things, but I think very well covered. I think your summary of what blocks for part of breast, whether they're going to axilla or doing an implant or things, I think that was excellent. And I think the last slide where you have added new blocks, parasternal blocks, I think that is also very useful because there have been publications on that, people finding it very useful. And I think they can also be used for chronic pain, post-sternotomy pains, they can also be used in there as well. And interestingly, with breast surgery, I actually found that when they go towards where there's a large tumor and they're going towards the medial side, despite actually having a good block, paravertebral block, I don't know why they get, when they're going to the medial side, they get a response. And I think there is some crossover. So what I've started doing is actually, when the surgeon says that they're going to have a long elliptical on a medial, I just go and put some parasternal block there as well. And that's been fine. Just few mLs, 3 to 5 mLs there, and that takes care of it. It's probably just that, you've seen that, you think that the nerves will come and just stop at one point. I don't think that happens. I think there is some
crisscross.
Cross at the midpoint. Because I couldn't explain at all. Rest was fine. As they go to the medial side, there was a response in the heart rate and blood pressure, and that was interesting.
Do you redo the paravertebral blocks in rib injuries?
No, most of the time we don't have to. That's what's surprised that once you break the cycle of pain, especially when they have been using it, then, but if you use it from the very beginning, yes, you can repeat. And what my experience has been, I don't know, Dheeraj will likely probably have more experience in that. That I thought that, like blocks for surgeries, the analgesia will last for maybe 18 hours, 20 hours, 24 hours. And the analgesia actually lasted for around 72 hours, a single shot. And that's for enough. I don't know what your experience is, Dheeraj.
Yeah, no. I actually, I think this is very important to understand breaking the cycle, which is probably, so you've got elderly population who actually get this most of the times. They have had some kind of background medical problem. Then they are already having a little bit of delirium. And then we give them more opioids. And that actually compounds the problem even worse. And then the opioid causes a little bit of respiratory depression, and it becomes a vicious cycle. And sometimes all you require to do is break this vicious cycle. You give a good local anesthetic block. They already are loaded up with plenty of analgesics. And then all you have to do is, continue with these analgesics. I've seen really difficult patients turn around very well with a single shot. I mean, I think we do put in catheters sometime. We try serotespline catheters, but I've never been impressed with ESP catheters or anything of that sort. I think once you break the cycle of pain, and this is why, I mean, even for shoulders, I mean, there was a time where I used to put so many catheters and stuff like that. I hardly do that anymore. I am not a great believer in that. So she was absolutely right. I mean, just that single intervention is very important, and it really helps. You don't even have to repeat it or do anything.
What is the lowest concentration of local anesthetic that you think it works? Like in labor analgesia, they say 0.062% to 5%. So have you tried using that low concentrations for nerve blocks?
Not me. I think that's you're talking about is epidurals, not the peripheral nerve blocks. Peripheral nerve blocks, I would probably, lowest I've used is 0.25.
Same with me.
Never
go below that. There's no point. You just want pain relief, just dense block it.
Yeah. I think more central you are, the lower concentration you can use, but I think peripherally, I think you still need to rely
You've
on
had a little higher concentration. So you need a denser block to break the cycle, basically.
Yeah, absolutely. I use 0.37. That is my standard is 0.375, which is mixture of 10 mL of 0.5 and 10 mL, 0.25 in 20 mL syringe. That's my standard for most blocks. But for some blocks, I would use 0.5, like I was saying, the elbow and ankle fusion and things like that. Dense no, and I think you need to have a very good block there. Yeah. Otherwise, even if you get a perfect block, they're still with lower concentration. I don't know. They still, complain of pain post-operative period. So, otherwise, 0.375 for most cases is my standard.
So on YouTube, there have been a few discussions which I think Kaushik and Preeti have had about doses with epidural. There's one question which has been asked by Ravindra Shah, and he asked, can we use PEG block for breast abscess? So I don't know whether he said PEG 1, PEG 2, but the question is, can we use PEG block for breast abscess?
Try to be away from this site. I think that's what I would suggest. Even though if you look at the breast abscess, it is not in that plane. It usually superficial to the muscle, but I think better to remain away and try to do a block more, at the proximal level, that is erector spinae, paravertebral, or
maybe intercostal.
Something like that. Intercostal, you have to go multiple
levels.
Intercostal is that you want. That way, I think serratus anterior plane block is pretty easy. Even you can do it, your mid-axillary line, you go at 6th rib and inject local anesthetic there. And again, I think that point of you need to inject only at 6th rib. No, that's also again wrong. You can go and inject at multiple levels, local anesthetic at multiple levels into it. So better to stay away from that.
So I think
there was another thing which hasn't been discussed here is that the surgeons not wanting you to give PEG block and thing. Okay, and that comes to the same thing we discussed about what is the effect of current on local anesthetic. They say, diathermy doesn't work. It's exactly the same thing. The local anesthetic, which is in that plane, when you apply current, it forms an ionic current, dissociates, and stops from these, diathermy working properly.
Yeah.
So they will say, oh, this local anesthetic is causing, my diathermy is not working properly and I'm having to use higher currents or whatever. That is the reason. It's not that a block is doing anything to that. It is just, it is dissociating into, even if you, like I said, if you flooded that area with normal saline, same thing would happen.
The other thing with this PEX block, what people don't see, there's PEX1 block is useful if you're actually going under the muscle, if you're actually bulging the muscle, if there is a subpectoral implant. Most of the times I've seen people go and do a PEX block for a lumpectomy or anything which is more superficial, where they don't reach the breast at all. And there is no point in doing this. I mean, you try to explain that there is no point. I mean, yes, it's a block, how to do a block, it's fine, but the efficacy of the block has to be there. And the other thing is that one of the rare, I think we had a slight a patient where we actually gave PEX block, and then we found that they had problems with the abduction and adduction of the shoulder later. And you got to realize that when you're doing that, you're blocking the lateral pectoral nerve, which is there, and it is a motor nerve after all. So you may, and I've started to explain that to my patient now after I do PEX block, saying that, oh, you might find that you might have problems in adduction later because it's a motor nerve and it does supply a motor muscle. So I think you have to be wary about these blocks too. So I think generally, going more away from the area, and especially if you're having an abscess, since this question is about an abscess, I really would not want to stick a needle anywhere where there is an abscess nearby, because all you're doing is you're just opening up plane for the infection to spread. And then, you can be blamed for it quite easily.
And I ask what volume you use for PEG block, 20 ml is enough.
Yeah.
Yeah. If you want to use larger volume, you can use it's fine, but 20 ml to 20 to 30 ml is more than enough for the surgery. Okay. Shall we move on to the next lecture then?
Yeah.
We want to introduce Prasanna.
Yeah. So I think the next speaker we have is one of the organizers of RAD, who's been helping us quite a lot in organizing this, and she's kindly agreed to give a talk. So Prasanna, you're going to talk about abdominal wall blocks. The floor is all yours.
Okay, am I audible?
Yes, and visible too.
Yes. A very good evening to everyone. And before beginning, I would like to thank Dr. Shiv and Dr. Dheeraj for challenging me with this talk, and the organizers of RAD. And a special thanks to Dr. Shiv sir for being my mentor, as I don't do this very often. So I hope I'm able to do justice to this topic. So with everything from the head to toe being covered, we have left a huge gap in between with the abdomen. So the abdomen, being the Pandora's box, as we all know, houses a large variety of solid as well as hollow viscera, most of which require surgical treatments and therefore incisions of varying sizes, right from the rooftop incision and the age-old laparotomy incision, going all the way from the xiphisternum all the way up to the pubic symphysis. And in more recent years, we have the laparoscopic multiple incisions, which are smaller and therefore causing lesser pain. But yes, the one thing that has remained common is the pain that the patients experience in the post-operative period. And this is where abdominal wall blocks come into the picture. Yeah. So most of these blocks are facial plane blocks, and depending on which facial plane we give the block in, we can broadly divide them into the transversus abdominis plane block, that is the TAB block, which has become very popular of late. That can be divided into the anterior TAB block or the posterior TAB block. Then we have the more centrally located rectus sheath block. And finally, for the lower abdomen, we have the ilioinguinal and iliohypogastric nerve block. So I will be speaking about each of these one by one. So coming to the transversus abdominis plane block, this block is very helpful in the sense that it helps us cover a large area of the anterior abdominal wall as far as pain relief is concerned. So going briefly into the anatomy, the abdominal wall is made mainly of 4 muscles. So the rectus abdominis is more central, and the anterolateral wall is made up of 3 flat layers of muscles with their accompanying fascia. So from outside to inside, we have the external oblique, which is most superficial, then followed by the internal oblique, and finally the transversus abdominis, which is the innermost. So the tap plane lies between the internal oblique and the transversus abdominis muscles. So this is where the nerve roots from T6 to L1 traverse in the transversus abdominis plane, and they leave the transversus abdominis plane at various points from the midline towards the mid-axillary line to give the anterior cutaneous and lateral cutaneous branches to the skin as well as the muscles. So more superiorly around T6, the nerves leave the transversus abdominis plane very close to the midline. So it's very near the linea alba, just below the costal margin. Whereas from T7 to T9, they leave the anterior, they leave the tap plane at the anterior axillary line at somewhere around the midpoint between the costal margin and the iliac crest. And from T10 to L1, they leave the tap plane just anterior to the mid-axillary line near the iliac crest. So why this is important is when you choose to choose a point for giving the tap block. So it is preferable to choose a point which is more posterior, more closer to the mid-axillary line, or else if we go more anterior, there are chances that we will be missing the lateral cutaneous branch, which has already left the tap plane at that point. So indications of the tap block are for lower abdominal wall surgeries. They can also be used for upper abdominal surgeries, but because of the limitation in spread of these nerve roots, it is better to combine them with the rectus sheath block. And it is very useful in umbilical and infraumbilical surgeries. It's a huge advantage in patients where epidural is contraindicated, either due to coagulopathies or altered anatomy of the spine, or where epidural or central neuraxial blockade might be refused by the patient. So a unilateral tap block can be given in surgeries which have predominantly one-sided incisions like an appendectomy, a hernia, or a renal transplant. We can use bilateral tap block in surgeries where the incision extends to both sides of the midline, like an LSCS or other surgeries with silent steel incisions, umbilical surgeries or lap surgeries. And then we can always combine the tap block along with the rectus sheath block for the midline laparotomy incision. Coming to the technique, the patient is always positioned supine with the ipsilateral arm either abducted to 90 degrees, or it can alternately be placed over the chest of the patient. And you can choose the point of injection as per the incision that the surgeon might want to take. So if it is a more upper abdominal incision, it would be better to go for a higher point of injection, which will be in the mid-axillary line just below the costal margin. Or if it is an umbilical surgery or just a supraumbilical surgery, it would be wiser to go at the point at the midpoint between the costal margin and the iliac crest in the mid-axillary line. And for lower surgeries, it is better to go at a point which is just above the iliac crest. So the technique is simple as has been explained multiple times. We pierce the skin with a short beveled or a blunt needle, and then we feel the bounce over the external oblique fascia, pierce it, feel the pop, and then we encounter the internal oblique fascia. So after the second pop, we have entered the transversus abdominis plane, and there, after careful aspiration, we can inject 20 to 30 ml of long-acting local anesthetic in 5 ml aliquot. In the scenario where you do not feel a clear-cut pop, you can try by directing the needle slightly forward until you feel the pop. So in the cross section, these are the layers that are there. There's the external oblique fascia underneath the external oblique, internal oblique, and then the transversus abdominis plane where the nerves travel with their respective blood vessels. So when we are piercing the fascia and entering the tap plane, this is where we deposit the local anesthetic solution to give the tap block. Now, there's one more variation in this, that is the posterior tap block. So this is given, if you can see, this is the point of injection for the posterior tap block. So this block is given direct. It is also called the transversalis fascia block. So the local anesthetic agent is injected directly into the space between the transverse abdominis and the transversalis fascia. So since it's a more posterior block, the positioning of the patient will be slightly different. So we have to give a slight contralateral tilt, or that can be achieved by putting a sandbag underneath the buttock of the patient, or alternatively, you can ask an assistant to give a lateral position to the patient. So the landmark we have to look for is the posterior, in just above the iliac crest in the posterior axillary line. Now, we follow the same method, 2 pops, and then after careful aspiration, we inject 20 ml of local anesthetic. The advantage in this is a better spread of the local anesthetic. Since many a times there are anatomical variations where the lateral cutaneous branches leave the transversus abdominis plane posterior to the mid-axillary line. With this method, we are ensuring that we are covering almost all the branches of the cutaneous nerve. That was about TAP. Moving on to the ilioinguinal and the iliohypogastric nerves. So a brief anatomy about this. These two nerves are formed as terminal branches of the L1 nerve root. They travel in the transversus abdominis plane till they reach the iliac crest. A little above the ASIS, that is the anterior superior iliac spine, the ilioinguinal nerve pierces the internal oblique and comes to lie in the plane between the external oblique and internal oblique, and continues to travel along with the spermatic cord or the round ligament to go ahead and give the cutaneous branches, whereas the iliohypogastric nerve continues to travel in the transversus abdominis plane. There are various anatomical variations of these nerves and how these two nerves are formed. So that is the reason we might need to give a certain amount of local anesthesia in the subcutaneous plane as well to cover these other cutaneous nerves which might otherwise be missed. So if you see in a cross section, it's the same thing. This is the iliohypogastric nerve, and this is the ilioinguinal, which, if you see in the cross section, it has pierced the internal oblique and come to lie in between the external and internal oblique to travel further. So if we go for the indication, the unilateral IIN and iliohypogastric nerve blocks are usually used for inguinal herniorrhaphy and orchidopexy. Bilateral blocks are used in gynae and obstetric procedures which have phalangeal incision. And bilateral blocks, along with a block of the femoral branch of the genitofemoral nerve, has been used for endovascular abdominal aneurysm repair as well. So there are two methods to perform this block. First is the classical inguinal nerve block. In this, the landmarks are about 2 cm medial and 2 cm caudal or cranial. There are people who do caudal and there are a few who say it can be done cranial as well. So we choose the point of injection. And here, since the ilioinguinal nerve has already pierced the internal oblique to lie in the space between the external and internal oblique, after the first pop itself, we have to give 5 to 10 ml of local anesthetic to block the ilioinguinal. After that, we go further and second pop. After the second pop, we again instill around 5 to 10 ml of local anesthetic agent. And while coming out, we give around 3 to 5 ml of local anesthetic agent in the subcutaneous region to cover any cutaneous nerves which might have been missed. So if we see in the cross section, this is how it will go in. So you go in from the skin. This is the external oblique aponeurosis. You get the first pop and you instill 5 to 10 ml of local anesthetic here for the ilioinguinal nerve, and you go ahead and instill 5 to 10 ml in the after the second pop for the iliohypogastric, and while coming out, some LA for the subcutaneous. Now, the second method that has been described by Eichenberger. So, as per his studies and by other cadaveric studies, it was found that the ilioinguinal nerve and iliohypogastric nerve travel in the transversus abdominis plane at a point which is 5 cm cranial and posterior to the anterior superior iliac spine. So at this point, a single injection can block both these nerves in the transversus abdominis plane. So the technique is the same as we use for TAP block. So at a point which is 5 centimeters or 2 inches above and 2 inches posterior to the anterior superior iliac spine, we instill about 20 ml of local anesthetic after careful aspiration after the second pop. So in the cross section, it looks somewhat like this. So these are the ilioinguinal, iliohypogastric in the transversus abdominis plane, where the local anesthetic can be instilled. And finally, coming to the rectus sheath block. Now, the rectus muscle is the most midline muscle of the abdominal wall, and it is covered by 2 layers of aponeurosis. One is the anterior rectus sheath, which is predominantly formed by the aponeurosis of the external oblique throughout its length, and in the supraumbilical region, the anterior lamina of the internal oblique as well fuses and interlaces with the external oblique aponeurosis to form the anterior rectus sheath. The posterior rectus sheath is also formed by the interlacing of the aponeurosis of the posterior lamina of the internal oblique along with the aponeurosis of the transversus abdominis. And a few centimeters below the umbilicus, all these three move anterior to the rectus muscle, leaving the relatively thin transversalis fascia alone in the posterior region along with the inferior epigastric vessels. So the rectus sheath block is more advantageous if it is performed above the umbilicus, whereby the intra-op and post-op analgesia for umbilical incisional hernia repairs, which are above the umbilicus or supra-umbilical incision, and in combination with TAP block for large laparotomy incision is where it can be used. Now, there are a few technical points which we have to remember in the rectus sheath block, since it has to be given bilaterally always to be effective. A very large amount of local anesthetic agent is required for this. And also, since it covers a large area all the way from the xiphisternum to the umbilicus, you can either go for single point, bilateral single point incision, or it would be preferable to just divide the rectus into 4 quadrants above the umbilicus and then go at the midpoint of each quadrant for better and more effective block. So how we perform it is again with a short bevel needle or blunt needle, 5 centimeter lateral to the linea alba at the midpoint of the midpoint between the xiphisternum and the umbilicus. We go in and feel the first pop. The first pop means that you have entered the anterior rectus sheath. And after progressing it further, we feel a second bounce. Now, it is very important not to pop this region, because if you pop this aponeurosis, you will be popping the posterior rectus sheath, and after that you will be instilling the local anesthetic agent into the peritoneum. There is no harm done, but it will not give the effective block as you expect. So after the second bounce, around 15 to 20 ml of local anesthetic agent in aliquots of 5 ml is instilled into the posterior rectus, between the rectus abdominis and the posterior rectus sheath. This can be repeated on the opposite side, and it can also be performed in the 4 quadrants with 10 ml at each point. So if you can see the picture, it shows where we have to inject the local anesthetic agent. Now, the caution that we have to look for here is the local anesthesia toxicity, because all these blocks are high volume blocks. So it is very important to choose your anesthetic agent and the concentration that you will be giving based on the patient's body weight. So to summarize, abdominal blocks are a very good analgesic modality for intraoperative, postoperative, and even bedside rescue analgesia many a times when the intraoperative analgesic technique has proved to be inadequate or has failed. These are very easy to perform at the bedside, and you can perform all of these blocks along with loss of resistance by landmark guided or even PNS. When you are using the PNS, all you have to look for is the abdominal muscular twitching. There are very limited resources needed. Like everyone has mentioned, you can have a blunt needle, a syringe of local anesthetic, and you're good to go. It largely reduces the requirement of IV analgesics and opioids that the patient might require in the post-operative period, with the only caution of local anesthesia overdose, but not very frequently seen. But it would be wise to choose your local anesthetic agent as well as concentration to give a good and effective block. And it can be performed anywhere to give the patient the advantage of a pain-free post-operative period. Thank you very much. And I hope I haven't bored you.
All right. Thank you, Prasanna. I think that was very well covered. I think these are some very, very basic blocks which everyone should know how to do them. There are no, you don't have ultrasound, doesn't matter. If you learn loss of resistance block, you can actually do them very, very effectively. And in some places, I think they work even better than ultrasound blocks. These ultrasound blocks, I've still seen ultrasound block fail with this one, but with loss of resistance, still get a good block. I think the way the local anesthetic spreads and your landmarks are actually a lot more posterior as compared to when you do an ultrasound block, so they work really well.
Yes.
I don't think there was any questions which are there for your lecture. If anybody has, faculty has anything to add, they are most welcome to comment or to ask or to add anything to Prasanna's lecture. Yes.
Many times what happens after most of the time laparoscopic surgery for maybe umbilical hernia repair or something like that. Most of the time surgeons, they feel like giving the tab block.
Yeah.
And they are under impression that they are giving it under vision.
Yes.
Yes, that's true.
I think that is not actually under vision. They just see whatever needle is poking out from the peritoneum, just withdraw some for some centimeters and then inject the local anesthetics. It's like as good as we are giving from outside blind block after 2 pops, or they also don't know how much to withdraw to come to the transverse abdominis plane. So what do you prefer, whether you will like surgeons to give or you will like yourself to give?
They are happy to see a bleb subperitoneally, and they feel that they are in the right plane.
And they're happy that the bleb has come, so it's in the right plane.
So they feel 100% assured that they are in the right plane.
They don't. I mean, surprising, isn't it?
So I would like to share one incident, since Sir has mentioned it. The same thing happened with me. The patient was undergoing an laparoscopic hernia repair, and the surgeon enthusiastically said, no, I want to give the block, and I can see it from inside. And they gave a block. They just saw a bleb, and I could see that it was much more anterior than the mid-axillary line. And then they gave the block, and they were very happy about it. And the patient woke up and had excruciating pain in the post-op period. So much to the extent I had to go to the bedside and give a proper tab block, and then the patient could sleep at night. So after that day, that surgeon hasn't attempted to give a block. So it does make a difference. What the surgeon feels that I am giving it in the tap plane might not necessarily be in the tap plane. He might just be giving it underneath the peritoneum, that what he can see.
Yeah, exactly. I think fair point. I think all they say is that it's similar to some of the people who have started using ultrasound. They said, oh, we could see this lenticular effect. Now, and one of your slides is very, very important, where it actually shows that the local anesthetic has to be below the internal oblique fascia. You can deposit local anesthetic above the internal oblique fascia and still see the lenticular effect, but it won't work. You need to pierce that internal oblique fascia, and that is a reason why probably the loss of resistance blocks work better, because you're always feeling for the second pop. And you're injecting local anesthetic under the internal oblique fascia. Whereas under ultrasound, they can actually be above the internal oblique fascia, which can lift off very easily from the muscle and still not work. Yeah.
I'd like to ask, what is the trend about installation of intraperitoneum local anesthetic, especially in laparoscopic cholecystectomies?
We don't do it, but there are actually reports where they say that if they spray the local anesthetic over the diaphragm, and then patient don't get shoulder tip pain. I've seen if you use proper multimodal analgesia, and the surgeons tend to deflate the stomach nicely and wash. The incidence is very low. I mean, I don't do huge numbers, but what I've seen, I have not seen shoulder tip pain that much as they think.
Sir, if I may add here.
Technique is also important, I think. Yeah. Hi, Preeti. Yeah.
Yeah. Well, I did a fair bit of subdiaphragmatic installation of local anesthetic, but this was mainly during the peak of COVID when we were doing most surgeries under lap surgeries under spinal or epidural. So at that point when they were insufflating, because there are some surgeons who straight away like to go in with a trocar. And not a Viris. So that sudden insufflation that is there of the pneumoperitoneum, that is when it really hurts the patient. So a little bit of ketamine, say 10 to 15 or maybe even 20 milligrams of ketamine and the subdiaphragmatic installation would definitely help in those times.
Yeah. I think that is very, very important. I think one of the things which they've seen is that the pain is much less if you keep the intraperitoneal pressure on the lower side.
Correct.
And the insufflation is also gradual. It is not like very quick, because pain comes from stretching on the peritoneum as well. It is not just that muscles are stretched, the peritoneum is stretched. But if you reduce this stretch, and you tend to actually have much less pain. So I think the surgeons are now actually understanding the concept that yes, you don't have to blow up the stomach like the abdomen as a balloon. You can do it with much lesser pressures, better techniques, and the post-op pain is much less.
So, Preeti, do you do the subdiaphragmatic installation prior to starting the surgery?
Yeah, as soon as the trocar or the Viris goes in. Once they're sure that it is intraperitoneal, I give a head low and I ask them to push around 20 mils of local anesthetic and wait for about, say, a few minutes and then start the procedure. And sometimes they demand pressures of above 15, 16, 17. One guy even asked for a pressure of 18 intra-abdominal. I said, the patient is already levitating. He'll go flying to the ceiling now.
Yeah. That is bad. That is huge pressure. Dr. Pramod, he can't hear you. You're muted, Dr. Pramod.
Hello. Hello.
Yeah.
See, we don't go beyond 15 millimeters of mercury as abdominal pressure. And what we do, we don't instill subdiaphragmatic installation. We never do, neither postoperatively nor preoperatively. What we do is we give just local anesthetic infiltration at the trocar site. That's it. And we put the trocar. So I don't think there should be any, and we are rather okay with that. We don't, or rather our patients don't complain of any kind of pain postoperatively also. And even after removal of the trocars also, we again infiltrate the trocar site with local anesthetic solution. That's it. And then multimodal analgesia is used.
Yeah.
However, we have found that tab blocks are of particular help in lap IPOMs, that is intraperitoneal onlay mesh for umbilical hernias. For big umbilical hernias, I think that makes a huge difference. The tab block definitely makes a huge difference.
Yeah.
I
don't allow my surgeon to do any infiltration. I said, leave it to me. I will put it, because what is doing, I'm doing under actually direct ultrasound guided block. They're putting local anesthetic where they will put the local anyway blindly. So what's the difference? Because when you do a tab block around the parambilical, which is also parambilical block, rectus sheath block, then I think there's no reason why the surgeon need to infiltrate. They're just injecting blindly into the area. It's not in a particular way. They just inject local anesthetic there. Yeah. And that is the site of most painful exactly from the parambilical site. The post-op pain, they may not have at the time of thing, they can come back actually with chronic pain from there. The chronic pain arises from the parambilical site.
Okay.
Especially there's nerve entrapment.
Generally, the epigastric port, which is the most painful.
It is.
Compared to the other ports. Because I think that's the muscular area.
Yeah.
And sir, I would like to add on to what Dr. Nair said. IPOM is visually very deceptive since it's a lap surgery. but they have this huge mesh and they fix it to the abdomen with 30 to 35 tackers from inside.
Tackers are the most painful.
They are very,
Whenever
very
they use
painful.
tacks, you need, and that's where the nice tab blocks actually make a huge difference.
That is why actually we started giving tab blocks after laparoscopic IPOM and all those.
Yeah. Okay, I think it's pretty late in the evening, and I think we are here for the last lecture. Nandini, are you ready?
Yes. Yes. Sir, am I audible?
Yes, you're audible, but I think you need to share your screen.
Yes. Yes.
Nandini will be talking on segmental spinal, which is very, very topical nowadays. Everybody wants to learn and do segmental spinal. So over to you, Nandini.
Yes. First of all, I would like to thank. Sir, am I audible?
Yes, Nandini, very clear.
Yes. First of all, I would like to thank the Rads team for inviting me to Rads team for inviting me to present this topic. I would like to express my special gratitude to Dr. Shiv Kumar Singh sir, who guided me through my presentation, and to Paliwal sir, who asked me to present this topic. So I want to say that I don't have any conflict of interest or any financial support received for this topic. So I will jump straight to my topic. This is the overview of segment spinal anesthesia, which I'm going to present. I will go through introduction, anatomy, the overview of the drugs, dermatology pattern, and the main crux of the presentation is the thoracic and abdominal surgeries, which are the commonly which we do, and the doses and the volumes. The advantages and disadvantages over other methods of anesthesia, and conclusion. So what is the definition of segmental spinal anesthesia? It is synonymous with thoracic spinal anesthesia. It is used to block the required dermatomes required for the proposed surgical procedure with very effective, and very low concentration of local anesthetic. The local anesthetic can be isobaric, hypobaric, as well as hyperbaric. So, a brief slide about the beginning and current era of the segmental spinal. So, Thomas Janesco started this technique in 1909 by giving spinal at T1, T2 level, head, neck, and thoracic surgeries. A landmark paper was published in 2006 by A. Van Zundert, where he gave spinal anesthesia at T10 level in a case of severe COPD with severe obstruction on his PFT for laparoscopic cholecystectomy. This case was a high risk for general anesthesia because the patient had respiratory distress as well as severe obstructive lung disease. And present era, it is being practiced by everyone, widely practiced all over the world, and post COVID-19 and COVID-19 era gained its popularity. So come to the anatomical explanation. This is an MRI image by Imbellini and Guerra. They studied MRI of 50 patients where they deduced that the distance in the thoracic spine between the spinal cord and the posterior dura at T1 level it is 5.19 mm, at T5 level it is 7.75 mm, and at T10 level is 5.88 mm. So first thing that comes into our mind talking about thoracic or abdominal, upper abdominal segmental spinal is that we are taught to give spinal below the level of the ending of the spinal cord, below the L1 level. So first thing that comes into my everyone's mind is whether there will be spinal cord injury, whether we will be medico-legally held, and whether there will be neurological injury. So I would like to answer these questions in the coming two slides by comparing between the anatomy of thoracic as well as abdominal area of the spine. Lumbar area. So a thoracic spine, the angulation that we require for the epidural as well as spinal needles is 40 to 50 degree up till T9 level. After T9 to T12 level, the angulation is 80 to 90 degrees, same as lumbar. Here the nerve roots are thin, since the volume is low in the thoracic region, because of which onset of action of local anesthetic is quick. The figure 4 here is suggestive. It is between the area of T4 to T6, where the distance between the spinal cord and the posterior dura is maximum. So spinal cord here is anteriorly placed as compared to the lumbar area, which is posteriorly placed in this figure number 18. So the lower doses of local anesthetic are required. Anesthesia incidence is 6%, and thoracic epidurals are used extensively. We are using spinal needles, which are much more thinner in length than the thoracic epidurals, and there are chances of CSF puncture or dural puncture in thoracic epidurals too. That time also we are worried about spinal cord damage, but the definitive point is CSF. So most of the time we hit the nerve roots and not the spinal one. So as I enumerated, the angulation required for thoracic lumbar spines is 80 to 90 degree. The nerve roots are thicker, the CSF volume is high, and the spinal cord is posterior to the closer to the posterior dura. So chances of paresthesia incidence are higher, around 13.6% in lumbar region, and higher dose of local anesthetic are required. So commonly used drugs in adjuvants, I compare about isobaric and hyperbaric drugs. Now isobaric, they are position independent. So we can give spinal in lateral position, prone position, as well as in sitting position. And this helps us in providing position for the patient during surgery. Like we can give spinal anesthesia with isobaric drugs in in a case bipolar hemiarthroplasty in the lateral position, in the position which is going to be provided for the patient during surgery, and save time. Hyperbaric drugs are gravity dependent. The isobaric, the blockade is more of sensory than motor block, whereas in hyperbaric, dense blocking more motor as well as sensory. Now in isobaric, there is partial lumbosacral sparing. That means sympathectomy is still there, but it is partial. As lumbar roots are more thicker, so isobaric drug at lower doses do not act as efficiently as in thoracic. So because of it, there are less hemodynamic fluctuations and slow onset is there at lumbar levels. Whereas in hyperbaric drugs, lumbosacral blockade is dense, so sympathetic turn is performed, as because of which there are hemodynamic changes, hypotension, bradycardia. Also, the doses used are higher, which we can taper in segmental spinal if we are using at the higher thorax levels. The onset is faster. The isobaric drugs have a disadvantage that their duration of action is 9 to 120 minutes without adjuvants, and hyperbaric 3 to 4 hours. So the density is similar to CSF, it is 1.00103 to 1.0013, and hyperbaric, our density is higher than CSF, more than 1. So the main point of the, so with isobaric drugs, which are the commonly used isobaric drugs, they are chlorprocaine, bupivacaine 0.5%, chlorprocaine 1%, and bupivacaine 0.5% to 0.75%. So chlorprocaine, the duration of action is 40 to 50 minutes. So we can use it for specific surgeries like laparoscopic tubal ligation, ruptured ectopic pregnancy, laparoscopic debridements, where also concentration is lower. The density of chlorprocaine is 1.007 to 1.008. So since the concentration is lower, we have to use higher volumes, around 3 to 3.5 ml. We can use it at L1 to L2 levels. The most important point to remember is that 1 ml of any isobaric drug covers 2 to 3 segments above and below the level of spinal injection. So if we know the upper and lower level of the dermatomal blockade for a particular surgery, we can taper the drug accordingly. Levonorgestrel, it is less potent than Anaesthesia, but more potent than ropivacaine. 0.5%, the duration of action is 90 to 120 minutes. And ropivacaine 0.5%, 0.75%, the duration of action is similar, but it is least potent as compared to levobupivacaine. Also, it has more sensory relaxation, poor abdominal relaxation, and less lipid soluble. Hyperbaric drugs, as we all know, bupivacaine 0.5. Recently, Neon has introduced bupivacaine 0.5% heavy and ropivacaine 0.75% heavy. So the problem with ropivacaine is less muscle relaxation, more sensory dominance is there in more sensory as compared to motor relaxation. About hypobaric, we cannot, hypobaric drugs are not commercially available, and anesthetist has to prepare them density is lower than 1. So these hyperbaric drugs tend to float against the gravity or float in the CSF. So these are reserved for selected cases, comorbid patients, blocks the posterior routes, also unpredictable levels are there, and chances of contamination are more. We can prepare hypobaric, for example, if we take around 0.5% levonavir, we can prepare hypobaric using isobaric drugs, 0.5% anavin. If we use levoanavin, we can take 10 milligram, that is 2 cc, and dilute it to 5 cc with distilled water. The concentration becomes 0.2%. And a hyperbaric drug can never be made isobaric or hyperbaric because of the dextrose content. So commonly used adjuvants, fentanyl 10 to 25 mics, clonidine 30 to 45 mics, dexmedetomidine 2.5 to 10 mics, preservative-free ketamine, as well as buprenorphine. Now, some adjuvants, especially fentanyl, are hypobaric. So they change the baricity of the local anesthetic and can modify the baricity. So fentanyl, especially, the specific gravity is 0.996. So it is hypobaric. It makes the solution more hypobaric. So how can we prevent it? We can use separate syringes. We can use the undiluted solution of the fentanyl. Also, in cases of dexmedetomidine, the most popular technique which we are recently using is rinsing the syringes with dexmedetomidine. So commonly used landmarks in dermatomes, for thoracic spinals, we use the root of spine, which corresponds to T3 of the T3 and inferior angle of scapula T7. So we can calculate the T4, T5, T6 level, which are required for upper thoracic surgeries and breast surgery for spinal anesthesia. Then the Tuffier's line, which corresponds to the superior aspect of the iliac crest, L4, which corresponds to L4, bed margin, which corresponds to L1. So coming to thoracic surgeries, commonly done surgeries are modified radial mastectomy, which we require segmental levels to be blocked from C5 to T7. Mastectomy with transverse rectus abdominal flap, which requires blockade from C5 to L1. Partial mastectomy and breast augmentation T1 to T7. Here the T1, T2 levels are covered. So most of the time, axillary dissection is done smoothly under these surgeries. So the question which arises if we can do axillary dissection under these surgeries, the T1, T2 levels are covered here. So if the adequate levels are blocked, then axillary dissection can be done smoothly. Then, as I said, there are other thoracic surgeries that can be done: bullectomies, axillary fibromas, V-assisted thoracic surgeries. Volume and insertion commonly used is 1 to 1.5 ml. We can use the dose as 1.2 to 1.4 ml too, depending on the patient profile, comorbidities, duration of action. Also, we have to supplement it with adjuvants. But most of the time, T4, T5, and T5, T6 levels are used for such surgeries. But if we are going below the level of T6, if the spinal is difficult at this level, the dose has to be increased by more than 2 ml. So we have to follow the law of 1 ml corresponds to 2 to 3 segments above and below. We have to supplement any for thoracic or abdominal, we have to supplement it with multimodal analgesia, with temporal blocks, with chest blocks, which has been discussed in previous surgeries. For thoracic surgeries, we can give PEC1, PEC2, sedatus anterior pin block, thorax paravertebral block is just erector spinae block. A multimodal analgesia is a must in any case of spinal anesthesia, be it segmental or a standard spinal anesthesia. Monitored anesthesia care, IV sedation as per the patient requirement. So, paramedian approach is preferred because the angulation of the spinous process is caudal. So, paramedian approach is much more preferred in thoracic spines. Then first, the question arises with high levels of spinal anesthesia, with higher levels of blockade at the thoracic level. The first question that arises is what are the problems facing cardiovascular respiratory parameters? But since the isobaric drugs are used, there is less venodilation, less partial sympathetic tummy, lumbosacral area is not blocked here. So cardiac output is preserved, enriched reflex is preserved. Also T1, T4 levels are blocked here, but the sensory routes are more than motor. So parasympathetic system is also preserved because which there are no major arrhythmias. Of course, with dexmedetomidine, clonidine, we will get bradycardia and hypotension, but that is as per the dose. If you use a dose more than 10 micrograms, they will be profound bradycardia and hypotension. For respiratory, will there be respiratory distress? No, because we are using low doses. So upper cervical levels are not blocked. So diaphragm action is preserved, cuffing is preserved, and expiration is passive. Also, abdominal muscle relaxation, abdominal muscles are preserved. So chances of respiratory distress are also less. Now, coming to some acceptance of thoracic spinal, there have been reports in standard journals about advantages over general anesthesia for breast cancer surgeries. This paper was published in an anesthesia in a peer index review journal, where they proved that segmental thoracic spinal anesthesia is better as compared to patient satisfaction, surgeon satisfaction, early recovery, and
I think we lost contact with Nandini.
Yes.
Yeah, I think there must be network problem. And that was just the last part. I think she's covered most of it. That was just the last part of the thing where she was going to show some of the recent publications which has led to acceptance of segmental spinal. And let's see if she comes back. Till then, if anybody has anything to add or anything, any comments? We will have few cases for segmental spinal demonstration, isn't it, Dr. Pramod?
Yeah, we are planning to have at least 3 cases. I don't know how much time permits, but we are planning to have one breast, one laparoscopic, maybe cholecystectomy or something like that, and one open surgery.
Yeah.
Maybe a hysterectomy or umbilical hernia, open umbilical hernia, something like that for segmental spinals.
Yeah.
And we will give proper demonstration of segmental spinal.
Yeah. Anything else anybody wants to? Yeah, she's coming back now.
am I audible, sir?
Yeah, you are.
Yes,
I think we lost connection.
Yes, sir. Yes,
You
sir.
want to share your screen? I think there was last few slides left, isn't it?
Yes, sir. Sir, is my screen visible?
Not yet.
Is it visible, sir?
No. Need to share your screen. As I think
Yes,
I would close your PowerPoint again if it is doing problem. Sometimes that happens, and then share it again.
So I'm sharing screen.
Okay. Yeah, it's coming. It looks like it's trying to come back. Yeah,
Yes.
it's back. Yeah, that's.
Yes. Yes. Sorry for the discontinuation.
No problem.
This another case report was presented in a Journal of Critical Care and Anesthesia case reports by one of our esteemed faculties, Dr. Shivkumar Singh sir, where they have said that cost effectiveness and feasibility of segmental spinal anesthesia in cases of breast debridement, and they have proven that it provides stable respiratory parameters as well as high patient satisfaction. So this was another review done by British Journal of Anesthesia in 2022, where they had mentioned about the segmental spinal levels as well as the volumes and the dermatomal blockade. But some corrections had to be done, like for colon resection, they have mentioned that spinal needle insertion is at T4 to T5. Also, the volume mentioned is too low. The level of insertion should be T9 to T10, or and the volume should be 2 to 2.2 ml. For nephrectomy, the dose mentioned is 1.3 ml. Around 2 to 2.2 ml has to be needed. So corrections have been corrections and letters to the editors have been sent for the same. Now, coming to abdominal surgeries, commonly abdominal surgeries, we need to know the dermatomal blockade. For abdominal surgeries, upper one, we require segmental blockade from T4 to L5 involving the plus sacral roots, laparoscopic T2 to L5, lower abdominal T6 to L5, orthopedic T11, T12 to L5, LACS T4 to S3. So I'll discuss about laparoscopic and open surgeries. For laparoscopic, the doses required is around 2 to 2.2 ml approximately in female, as the density of CSF is in females is lesser than as compared to males, and density is much more lesser in pregnant females than in non-pregnant females. So 2.2 to 2.5 ml for males. The level of spinal insertion can be anywhere between T10 to L1. Upper level that you have to achieve is T2 to L5. Then for laparoscopic gynecological surgeries, T11 to T12 level can be preferred, or T10 to T12. Two drug techniques to be preferred, which I'll mention in the open abdominal surgeries. For any kind of segmental spinal anesthesia, you have to follow, I follow all the proper protocol, like counseling the patient, taking informed consent, attaching all the standard monitors, and always keeping a plan B ready along with general anesthesia as a backup. Also, for laparoscopic surgeries, as mentioned in the earlier lectures, we can provide truncal blocks. Multimodal analgesia is a must in every case. Facial plane blocks. Then the first question that arises is about shoulder tip pain. It is very important. There are a few points one has to follow. That for the level that should be achieved is up to T2. You can ask the surgeon to insufflate from 7 to 8 mm of Hg rather than a sudden increase in pressure from 10 to 15 mm of Hg. Also, humidified CO2 can be used. Laprolift or gasless laparoscopy, if it is possible, can be used. Intraperitoneal installation with crystalloids around 15 to 30 ml per kg can be used to remove the CO2. You can ask the surgeon to remove the trocar after surgery by removing which will remove the CO2. So the shoulder tip pain is mainly due to tissue trauma, due to peritoneal stretching as mentioned before, due to diaphragmatic irritation. Also, recruitment manuals have been proved to be beneficial to reduce the shoulder tip pain. Then open surgeries doses are mostly similar, but you require adjuvants as well as blocks or epidurals or epidural volume extension to prolong the action more than 120 minutes. Two drug combination techniques, continuous spinal anesthesia technique has to be used in two drug combination. 0.5 ml of hyperbaric anavin 0.5% in separate syringe, and isobaric levoanavin 0.5%, 1.5 to 2 ml can have to be used. The reason for using hyperbaric bupivacaine is because lumbosacral sparing is there by isobaric, so we have to block those for adequate muscle relaxation. And truncal blocks, as mentioned by Prasanna ma'am, for abdominal surgeries, transverse abdominis, 4-quadrant tab block, rectus sheath block, external oblique intercostal or ESPB block can be used. Then this is one original research article published by our institute by Dr. Paliwal sir, where 60 patients were studied for laparoscopic cholecystectomy. The benefits of segmental versus general anesthesia were proved. And this is the most recent article published in IJA, where segmental spinal anesthesia has been included as one of the technical recent advances in regional anesthesia. Now, I'll just enumerate the variations because continuous spinal anesthesia is altogether a different topic. So I have already described why I am using isobaric and hyperbaric combination in certain surgeries. For continuous spinal anesthesia, 24 to 27 or 29 gauge catheters are available, but they are very costly, supplied by Pajun. So commonly, if you have 16 gauge or 18 gauge epidural catheters that can be used, aliquots of 0.51 ml isobaric solutions are preferred because hyperbaric solutions, which were used in 1993, they were getting pulled in the sacral region, leading to cauda equina. So they were the continuous spinal catheters were banned, removed from the market at that time. 2 to 3 centimeter catheter should be kept inside the subarachnoid space, minimum of 24 hours, and strict labeling has to be there, and it is reserved for morbidly ill patients. Dr. Dheeraj sir and Dr. Shiv sir have already given an emphasis for the fact that sedation or monitored anesthesia care or IV sedation for any kind of regional anesthesia, including spinal, segmental spinal, does not mean that it is a failure of regional anesthesia. It is a wrong concept of understanding. You have to overall see the patient comfort, surgeon comfort, as well as the entire, as per the duration of the surgery and the comorbidities of the patient. So advantages, it is cost effective, feasible, low doses, less complication, less chances of last or total spinal, hemodynamic stability, less post operative nausea, vomiting, early ambulation, follows all the criteria for ERAS criteria, but it less chances of pulmonary complications. It is not an alternative to general anesthesia. Disadvantages, it requires learning curve and expertise. It is technically a bit difficult, especially in thoracic region. Inadequate knowledge of the drugs, levels, and dermatomes can lead to disaster. Short duration for short duration surgeries, the half-life exceeds, half-life is less, so can't be used for short duration surgeries except for chlorprocaine, which you can use. And paresthesia and all the disadvantages of Neuraxil apply to. So to summarize, knowledge plus learning curve is important for segmental spinal. It is a great technique in the armamentarium of an anesthetist. All the basic principles of Neuraxil technique as well as all the proper protocols have to be followed. Useful in high-risk cases, low doses, so less chances of last or total spinal, safe, cost-effective, and feasible. Widely being practiced since post-COVID era. It is still yet to appear as a separate topic in standard textbooks, but some textbooks do quote about the drugs and thoracic epidurals and spinals. I thank you, everyone. I would like to just put a quote I found in one of the literature review by Dr. Mbeloni. He did say that I did not come into this world with a needle, but at least I knew how to use it very early in my career after becoming an anesthesiologist. I could fully utilize spinal anesthesia in my clinical practice. I identified myself with spinal anesthesia in such a way that I embraced it with such awareness that it was no longer an illustration, but a true translation. Spinal anesthesia is not new, it is simple, easy, and a popular technique. Anatomy, physiology, and pharmacology are very important and necessary for its understanding. Nothing is better than the freedom to decide what you can do with a simple technique. Only knowledge allows us to use it to its full potential. Thank you, everyone.
Thank you, Nandini. That was very elaborate. And I think covered most aspect of spinal anesthesia. You can stop sharing your screen.
Okay, sir.
There's a comment by Arun Agarwal. It says that duration of action in my limited experience of thoracic spinal and segmental spinal anesthesia is less.
Okay.
What is it?
Sir, yes, sir. if you use some adjuvants, if you use only plain isobaric levobupropion, it will last for 90 to 120 minutes. Also, the regression levels start from 70 to 80 minutes if you use it plain isobaric levoamylin. But if you use it with adjuvants like dexmedetomidine, it will prolong the action up to 3 to 3.5 hours. With fentanyl, slightly it becomes hypobaric, but it will provide a good hemodynamic stability. So you have to use it with adjuvants as well as supplement it with blocks like erector spinae, thoracic paravertebral, or peg blocks. And ideally, we prefer to use the higher concentration of the drugs for the volume blocks so that the analgesia is much better in the perioperative as well as postoperative period.
Or you can combine hyperbaric with isobaric, and then you can prolong your duration of action.
In one of the slides, she has mentioned combination of levobupropion with bupivacaine. What is the rationale behind using both the drugs? 0.5 ml of bupivacaine, 1.5 ml of levobupropion.
Yes.
I think she's lost connection again. I think she meant was heavy bupivacaine, 0.5% heavy bupivacaine.
Shiv, I also use many times for open surgeries.
Yeah.
The same thing. I give spinal anesthesia at around T9 to T10 level with initially 0.5 cc of heavy bupivacaine and 25 micrograms of fentanyl.
Yeah.
That is 1 cc I inject. Then I wait for 2 minutes in the sitting position. And then after that, 1.8 or 2 cc's of hypobaric levobupropion I inject. The syringe is rinsed with dexmedetomidine, that's it. And then I give 2 cc of that hypobaric this thing. So I found my duration of action remains for around 4 to 5 hours.
Yeah.
So that is the logic behind using hyperbaric bupivacaine is many times you get a very good relaxation, abdominal muscle relaxations. And in laparoscopic surgery, what happens if you give only segmental spinal with hypobaric solution, then maybe there is no pain, patient is very comfortable, patient starts moving legs. And that is quite time uncomfortable for the surgeon as well as this thing. So this prevents that moving, or motor blockade is absolutely there. So patient doesn't move legs. And that is why this hyperbaric combined with hypobaric is done.
So, but
that is how I am using.
Why he has mentioned it as bupivacaine and levobupropion? Why not bupivacaine and bupivacaine?
I think that she meant heavy bupivacaine. Is that right, Nandini? Where you mentioned bupivacaine and levobupropion combination?
No.
Was that heavy bupivacaine?
Yes, sir. Hyperbaric bupivacaine
that's
for lumbosacral relaxation in the surgeries where pelvic manipulations are there, where you require adequate muscle relaxation.
I think that was one of the questions from the delegates were, oh, drug preferred or isobaric or hyperbarics in segmental spinal, but I think we've just answered that question.
Yes,
it's usually you use them according to their advantages.
Yes, sir.
And how we use that to advantage. Yeah. I think this is a general kind of a thing. Is question. It says this is Samir Deshpande asking, will any long-acting paresthesia, if at all, can be defended in court for choice of anesthesia versus standard general anesthesia? I think this kind of question will always remain. The chances of nerve injuries are very small with blocks or with that. I think the incidence of death under general anesthesia and complication are probably far higher than complications we actually see with regional anesthesia. But I don't know why we still tend to actually think that general anesthesia is the gold standard for everything. Yes, for certain things we can't do regional anesthesia, or we may not think, but I think with segmental spinal anesthesia, I think our, domain, the region, or the kind of surgeries we can do under regional anesthesia, we have expanded our horizon, I think. And so I think these kind of things like long-lasting paresthesia compared to that, I think these are okay. Samir Deshpande, you are there on the line. I hope we have actually made it clear that this is not a kind of a, this is probably more hypothetical than a real situation.
Yes, sir.
You have to tell the complications which patients can, even if it is smallest, if you have recorded, if you have documented and explained to the patients are actually happy about it. It's problem happens when you have never actually discussed that, and that complication happens. So common things have to be explained to the patient, and they need to be recorded in your anesthesia chart.
Sir, can I add one point?
Yeah.
To that question, can I add one point? Sir, also we are considering the risk-benefit ratio of the patients. If we are using that technique for a case where general anesthesia poses much better risk, we can be called in the court to defend that also. Because as in, why did you give general anesthesia when he was at the risk of general anesthesia? Why another alternative technique was not given? Also, the incidence of paresthesias, as I mentioned in my slides, 4 to 10% in thoracic, 13.6% in lumbar area. And this can occur even during lumbar spinals, and patient may have paresthesia for weeks after that. So nerve injury is one of the side effects we have to explain even in our standards, although it is one of the not the common complication that we encounter. Also, a theoretical possibility that if we hit the cord, but most of the time we do not reach till the spinal cord as per the anatomical explanation. And if we reach or hit the spinal cord, most of the time it is insensitive, which is a theoretical explanation. I could not find literature regarding it, but this is also, you can, one of the explanation.
Okay, I think there's another question. It says, for LSCs, how much and at what level drug should be given in segmental spinal? I think for LSCs, I don't think segmental spinal anesthesia is indicated for that. I think that's a wrong indication for segmental spinal anesthesia. Then for a patient with interstitial lung disease posted for lap ventral hernia repair or open repair, what would be the ideal dose and site of segmental spinal?
Open ventral hernia repair.
Yeah, it's simple, isn't it?
Yes.
Umbilical is T10 level. Yes. We need to cover at T10. So I think that is, yeah. So you look at the your dermatomal level and then accordingly do that. And there's one, how do you explain for segmental anesthesia consent? I think a lot of these questions I think will be covered in the workshop. I think this is what is normally covered in the workshop. How do you consent? How do you explain? What this will be part of your workshop experience. So I think they need to attend the workshops, and they can actually discuss that in there. It will be in details. Plus, there'll be experts who do that day in, day out. So Dr. Naresh Paliwal is there, and you can speak to him. He's done, he's published, and he's done everything. So you can, yeah. Sorry, who's that? There was somebody else, I think. Yeah. Anything else? It's been more than 7 hours continuous of.
Yes.
We didn't even take tea break or lunch break, so it'd probably be overall.
Great.
It would have been more than 8 hours if we had, had the tea and lunch break.
Yes.
So we've done, I think, very well, and I think it's time to The end site
I
is
think
there.
most of the delegates are still watching it at the
Yeah.
till the end.
Yeah, it will. I think there is a slight delay on the YouTube compared to our
Yes,
regular session. So
and more than 1,000 views.
yeah, it's 1,269
Wow, very good.
at the moment. Yeah, and it will go up because
That's
people
great.
keep join it. Yeah.
Yes, that's great.
By tomorrow we'll be around 1,500 to almost 2,000 views. minimum.
Great, great.
Yeah. Okay. So I'm going to end this streaming. You can remain on the thing if you want. Yeah. Yeah. Have you somebody taken the attendance from the YouTube thing live? People have been putting their names.
Yes, yes. See, that is the MMC requirement. So
Yes.
we are taking that attendance and we will ask them to fill the
So we
feedback
have
form
taken
also.
note of that and we will be asking them to fill a feedback form to submit to
That's
the
right.
MMC.
Yes.
Okay. So you don't
Yeah.
need this thing because I think
No.
I'm sure this will still be there on that, but if it get lost, I don't think there is a way to.
I have noted it down. I have
You
noted
noted down.
down. Yes, yes.
Yeah. Let me see. Okay. Yeah. Okay. That's his end of the stream.